I cannot leave my session. So after 11 only I can join.
Yeah.
Yeah.
Madam, hello. Yes, madam, we can start now. Sorry for the interruption.
ठीक है, मैं शुरू कर लेते हैं.
Oh, thank you, madam. Thank you.
Good morning to all and most welcome to the second day of our symposium towards a new healthcare regime for the nation. We have very distinguished speakers today for this session and also touching upon very, very important subjects. I would like to welcome my co-chair, Professor U.C. Srivastava, who is also the treasurer of the Academy and has been with the Academy for many, many years. Professor Srivastava, I welcome you and thank you for joining as co-chairman. So, Professor Sudhir Kumar Satpathy, he will be speaking on public health emergencies, preparedness and resilience of our health system. A very important subject. He is a very renowned epidemiologist who is specialized in preventive and social medicine and public health, and the director of School of Public Health at KIT University in Bhubaneswar. He has a distinguished professional career of leading and implementing health and disease control programs, as well as advocating and popularizing public health education in India. Earlier, he was the focal point for many Government of India programs, such as National Health Programs, Reproductive and Child Health, National Rural Health Mission, National AIDS Control Program, and the revised National TB Control Program. He has contributed immensely to the NRHM by formalizing the Indian Public Health Standard, IPHS, and strengthening the health and infrastructure at district level, and also initiated SARS and influenza surveillance program in India to protect the susceptible individuals. Professor Satpathy is a very renowned specialist, and we are happy to have you, Dr. Satpathy. Please.
Thank you, Honorable Chairperson, Madam, and the co-chairperson, Dr. Srivastava, and the participants. Very good morning to all of you. At the outset, I will express my sincere thanks to the NASI organization and Madam Sharma for providing me this opportunity to be with you and to speak on this resilience of our health system in the face of these public health emergencies. So may I request now to please allow me to share my slides. Yes.
Yes, you have been allowed, sir. Please
Okay.
share your slides. Click on the share button, sir.
Yes. Share. Here. Yes.
Is it visible to you or not?
Hello. Hello, everybody.
Hello.
Is the PPT
Sir,
visible to you?
No, it is not coming, sir, yet.
Okay.
Please share button.
Santosh, are you running the slides?
No, madam, the slide is with Satpathy, sir, madam.
अच्छा,
So-
तो शुरू करवा दीजिए.
Sir, if you have problem for sharing, then you can just send me the mail. I will share here from.
Is it visible,
No, it
sir?
has started.
Now it started, sir.
Thank you, sir. It has started.
Started. Okay. Thank you. Again, I welcome all of you to this session. The topic for this session is public health
Kindly
emergencies.
keep it on the projection mode. The slides are not on the projection mode. If you put it on the projection mode, that would
Sir, please put it on the project mode. Presentation on the full
Yes.
screen. Sir, please share button.
Yes, we are double click. That one double click. Okay. Is it now okay?
Sir, make it on full screen or
Full
you
screen.
can go ahead, sir. If problem, if you please go ahead. We can
No,
see
that's
this.
right. You click on this icon. Yeah.
Is it okay now, sir?
Is it okay now? It is in my screen. It shows the full screen.
Sir, we can also see it. You please go ahead, sir.
Okay.
Thank you, sir.
Thank you very much. Not yet?
No. You need to click the display again.
Okay. The topic for this session is public health emergencies, preparedness and resilience of our health system. All of you we are all aware that we are passing through a very difficult time due to this COVID-19 pandemic. It is more than 1 year now. We are still continuing and we are still in the midst of this pandemic. And we have learned many lessons out of it. And also we have to see that even if we come out of this pandemic sooner or later, but our preparedness and the resilience of our health system must be there. So I will discuss the salient points on this, particularly our health system, then public health emergencies, then what is that preparedness and what is resilience of our health system. So this is in brief of my presentation. So I'm changing the slide, please, just a minute. So we all are very well versed that health is wealth and good health is very much an essential part of our overall social and economic development. But the realization of this importance is still lagging behind. And every country has developed its own health system, and India also has developed its own health system. And health systems and policies have a critical role in determining the manner in which health services are delivered, utilized, and affect health outcomes. In India, health being a state subject, despite the issuance of guidelines by our central government, the final prerogative of implementing all the schemes and provision of healthcare services lies with the states. That we must realize.
Sorry, sir, you are on the first slide only, sir. The slide is not moving.
I think the network is slow. It is okay.
And for full screen mode, sir, there is a F5 button on the laptop or the computer, sir. F5. Then it will automatically go in the full mode, sir. Full screen mode.
It shows in my slide F5.
Sir, please put it on the full screen.
Yeah, we have put it in full screen.
Sir,
screen, हाँ.
sir, you will have to exit first, then again put it, and don't put it on the full screen. You can show at least the slide if you will directly put it there, because I think your computer is not compatible with that.
Okay.
संतोष.
Yes, yes, it has come now.
संतोष.
Yes, madam.
आपको हर एक
It
का
is
बता
moving.
देना चाहिए ईमेल पे, है
Moving.
ना?
Okay.
ये मालूम है आपको कि यही होता है, तो
No,
you
no,
should.
madam. I mailed to everyone, but someone tries to show from their system only, madam.
तो अभी डॉक्टर द्विवेदी और निखिल का मंगा लो.
Yeah, Divedi sir has sent, but Nikhil sir has not sent, madam.
हाँ.
Okay.
दोनों का.
Is it okay now?
Yes, sir. Yes, sir.
हाँ.
Okay. So next slide, please. So this our health system, or even any country's health system, depends on their own policies, health policies. And in India, although we got independence and started our family planning program very quickly after the independence, but we had to wait till 1983 to get a national health policy. And since then, we have two more health policies in 2002 and 2017, and these health policies have focused on different aspects of the health system. So accordingly, our health system is functioning. We know all these focus points, so I won't elaborate on those things. Next. So India has developed, taking clues from this Bohr Committee report 1946, and after independence, India has developed a mixed health system. Our health system is a mixed one. The ownership is both public and private, and we have both allopathic and Ayush system. And due to India's federalized system of government, the areas of governance and operations of health system in India have been divided between the union and the state governments, that we are all aware of. So the important point is the whole implementation is very much as a prerogative of the state governments. Now, India has this rural healthcare system, a three-tier population-based health system, starting from the sub-center, which caters for 3,000 to 5,000 populations. Then above that is primary health center, which we are all aware of, covering a population of 20 to 30,000, and community health centers covering a population of 80 to 1,20,000. So this is the rural health infrastructure we have in the public sector. The urban health sector was not that much given importance, but now under this National Health Mission.
Your slide is not moving. Slide is not moving.
But it is moving here, just see,
No, it's not moving on the screen.
not moving. But it is moving on my screen. What is the problem?
No. It is not coming on the screen. Because that is the first or second slide, and after that there is no change.
Okay, so it's a chotu nails. Small one. Okay, now I will make it.
Yeah, okay.
Okay, so we were here. So now it is visible. This
Yeah.
rural healthcare system in India.
Yeah.
Okay. So that is the rural healthcare system. Urban healthcare system was not very much developed or was not given that much importance. But under urban national urban Health Mission, and also this under this National Health Mission, the urban health infrastructure is also now given importance. A 3-tier system is being developed. Now, coming to the overall healthcare system. So this is the pyramid of our public health system, and you can see that we have reached even to the household, every household in the village through our ASA workers. There are also support from Anganwadi workers, and we have a pyramid of this Indian public health system. I cannot say it as a robust healthcare system because we have many lacunae and also gaps in our system. But at least we should be happy that we have taken our public health system to the doorstep of the people through our ASAs. So this is the health system we are talking of. Is it changing now?
I'm not afraid
Yeah.
today.
Yes, we can see.
Okay, thank you. So,
Because I'm sure.
so we have this health system.
Not me.
Is it okay?
So we have left it. Why did you start all?
Is it okay?
I'm not understanding. I am always obeying you, so I did.
Yes, please go ahead.
Okay.
Yeah, you
So
can
in
do it
this,
on the mode of presentation rather than.
is it not visible?
No, it's very small, so you can make it bigger.
Sir, make it full screen, please.
I have made full
the
screen,
right
but
side.
you said that it is not moving. So
Okay,
that is why
never mind. Yeah, it's visible, so it's okay.
Then
One day we will become sick.
So, and
Yes. Why did you?
so, as I said, our health system is a mixed one. Public health,
That girl is not replying my names.
public health system in India is a mixed system, both private and public systems. And I must emphasize here that the private sector has actually been improving or increasing in a very faster rate than the public health system. In fact, it has been said that nearly 70% of ambulatory patients and 60% of the inpatient care is being catered by the private health sector. So private health sector is increasing faster than the public healthcare system. So that brings us that we cannot ignore private sector in the healthcare, and that has brought us to the concept of this public-private partnership. There has been tremendous improvements, no doubt, that we have reduced our IMR, we have reduced our MMR and the TFR, and we have improved our life expectancy also. So these we are all aware of, but we have several issues like availability, accessibility, affordability, quality of care, accountability, and low public expenditure on health. The availability, particularly in terms of the health manpower, especially the doctors and specialists, and also the drugs. So accessibility is also not in the desired manner. Many people, because as I said, the private sector is dominating now in our healthcare system, and many of our people are not able to afford the services. Quality of care is again another issue. accountability is an issue, and low public expenditure on health, that has been already discussed yesterday also by our eminent speakers. Currently, only we are spending only 1.6% of the GDP. The government is spending only 1.6% of the GDP on the health sector or health expenditure. So that is moving. The improvement has occurred, no doubt. When NHM was started, it was only 0.9% of the GDP. But now at least it has come up to 1.6% of the GDP. But you can see how we are moving in a snail's space from 0.9% of the GDP to 1.6% of GDP in last almost 15 years, more than 15 years. And as we know, the developed countries, they are spending 10% to 18% of their GDP. And it has been said that in order to implement this USC, universal health coverage, at least the government should spend 5 to 6% of the GDP. This is the minimum. But we are far behind. The criticism that comes on this, that probably our health system is not geared up to utilize the increased financing, but gradually the things are improving. With the capacities being developed, we should not just depend on that our health system is not fully prepared, but we have to see that it is increased. So we have many problems in our health system, and that is why we could have done better, much better, but we are not able to do that. Now, even if with the existing health system, whatever performance is existing, we are having the problem that our health system is getting stressed from time to time and getting additional shocks, additional shocking events occurring from time to time. And what is that shock we are getting, our health system are getting? It is the
search for them, do all those things I will do. That's all. I cannot do anything on computer. That's all.
The epidemiological transition that is giving a stress to our health sector, that is because of a trend. There is some background noise, please. This we are having increase in cities, and we are yet to control our existing infectious diseases, and the major problem is that emerging and re-emerging infections. So that is the major thing that is giving a stress on our health sector. The emerging infections, as we know, we had HIV/AIDS and still continuing. We had SARS, swine flu, MERS in Middle East, and Ebola in West Africa, and the ongoing COVID-19 pandemic has shaken the health system of most countries, including India. Moreover, the natural and man-made disasters are occurring at intervals in many parts of the India, and the new infections, that is a major problem for us. That is, it has been said that 70% of all the new infections that are being detected, that is coming from the animal origin, animal sources. So that has also emphasized that whenever you plan any resilience for our healthcare system, we have to bring in intersectoral collaboration and One Health in our One Health strategy. So new and emerging infections are creating problems for us. One of these is that COVID-19. The health, and one fact is that we must bear in mind that these sorts of events and these sorts of public health emergencies will continue to occur in our health system, in our country. So we have to prepare ourselves for this and become resilient. So I will slowly move to this. What is this public health emergency? A public health emergency is defined as an occurrence of or imminent threat of an illness or health condition caused by epidemic or pandemic diseases or a novel or highly fatal infectious agent or biological toxin or even bioterrorism that poses a substantial risk of a significant number of human fatalities or incidents or permanent or long-term disabilities. So this is the general definition given by WHO. Just a minute. Slide. So what constitutes a public health emergency? This is defined as public health emergencies are because of is depend on their health consequences. So what health consequences the public health emergency is having by their causes and also by precipitating events. So that is defined in the terms of this public health emergency. A situation becomes emergent when its health consequences have the potential to overwhelm routine community capabilities to address them. Definition focuses on situations whose scale, timing, or unpredictability threatens to overwhelm routine capabilities. The definition is also aligned with the all hazards approach to preparedness and response, and thus allows for the optimal development of capabilities across scenario and better prepares the communities for the broad spectrum of our potential risks. So a state of public health emergency demands that it is to be declared by any authority in the government, who at certain moment will also have to lift it. So public health emergency have to be declared by the authority and also they have to lift it. So this is one of the criteria in that. Thus it is usually defined in time and place. It requires threshold values for specific diseases and it implies that rules of engagement and an exit strategy also should be there. So conceptually, it relates best to the response to the public health emergencies. The declaration of the state of public health emergency permits the government to suspend state regulations, change the functions of the state agencies, bring in restrictions like we have faced in the lockdown and other restrictions still going on. Emergency preparedness action is taken in anticipation of an emergency to facilitate rapid, effective, and appropriate response to the situation. There is also another term that called public health emergency of international concern. So this is related to the global health. Even in one country is having epidemics, by spread to the other countries, it can have a global health problem. So this is new term. It has been coined by WHO. It is not new. It has been in practice since the SARS pandemic. So public health emergency of international concern is a formal decision or formal declaration given by World Health Organization, like in this COVID-19. It was declared in January 30th January, it was declared as public health emergency of international concern. It is defined as an extraordinary event which is determined to constitute a public health risk to other states through the international spread of disease, and that potentially requires a coordinated international response. And this is a situation that is serious, sudden, unusual, or unexpected, which carries implications for public health beyond the affected state's national border and may require immediate international action. So this is about the public health emergency, and for COVID-19, WHO has declared that on January 30th that it is a public health emergency of international concern. And this declaration makes a certain binding activities for the states, like travel restrictions, like other or putting in place a good surveillance and quarantine, so many other activities that is related to this declaration of this public health emergency of international concern. So this is being regulated by, or the guidelines are given by, the International Health Regulations, IHR. And under this, it makes the countries, other countries, to have a legal duty to respond promptly to this public health emergency. Every country has to be under this guidelines. They have to perform under this IHR. The declaration is published by an IHR emergency committee of the international experts, which was developed following the SARS outbreak in 2002 to 2003. And since 2009, there have been 6 public health emergency of international concern declarations by WHO. So those were in 2009, H1N1 or swine flu pandemic, the 2004 polio declaration, the 2014 outbreak of Ebola in West Africa, the 2015 to 16 Zika virus epidemic, the 2018 Kivu Ebola epidemic, and the ongoing COVID-19 pandemic. This public health emergency of international concern is not confined to infectious diseases alone. It has the scope of covering these chemical agents, these epidemics or pandemics occurring due to chemical agents or radioactive material. Now, coming to this current COVID-19 situation, I do not want to bore you with so many statistics and others. We are all aware of, we are daily monitoring these aspects in our own state or also in our own country, and also the globally. So this is just a glimpse that since its declaration, the globally we have about 100 this more than 1 crore of 1 crore 12 million 1 crore 12.2 million cases. That is cumulative figures, and India has about 1 crore 1 million cases. This is the latest figure of 25th, and deaths have occurred 24 million 2.4 million deaths in globally, and also 1.56 lakhs cases in India. And the total vaccination, fortunately, the vaccination process has started, first given to the healthcare workers and the frontline warriors or workers. And now it has been said that about 126 lakhs of cases of these health workers and frontline workers have been vaccinated. So before that, we were mainly depending on this non-pharmaceutical interventions like social distancing, mask use, and sanitizers, hand hygiene, like that. So what is important here that even after 1 year, we are still in the problem, and we do not know. Although in our country the cases are reducing, but unfortunately, again since last week, we are observing that some states, at least 5 states, are showing an increasing trend of these cases. So we have a problem, and we have to prepare ourselves to continue taking actions so that this pandemic is over. And the preparedness means that activities and measures taken in advance to ensure effective response to the impact of hazards, including the issuance of timely and effective early warning. It requires a strong and effective surveillance system and the temporary evacuation of people and property from the threatened locations. So preparedness is very much important. We have to prepare ourselves, and India is doing remarkably in this, that we have got a very good system of surveillance that is called IDSP, Integrated Disease Surveillance Program. So under this program, we are keeping a watch on the happenings of these infectious diseases. So pre-disaster activities, including an overall strategy, policies, and institutional and management structures, should be geared up for helping at-risk communities safeguard their lives and assets by being alert to hazards and taking appropriate action in the face of an imminent threat of the actual onset of a disaster. So these are the activities that are required in this preparedness. The early warnings and IDSP. So here we know there are several things that yes, in our surveillance system, we have been able to detect epidemics, and the number is increasing by the year, and we have rapid response team, that is RRT, in every district. So their responsibility is to investigate the epidemics and respond to the epidemic, and their primary responsibility, of course, it is with the local health organization. This rapid response team is a multidisciplinary team. It consists of epidemiologist, clinician, and microbiologist, and it can be added. This team members can be added to this team depending on the type of epidemic we are having. So if it is a vector-borne disease, entomologist can be added. If it is mainly concerned with the pediatrics, pediatricians can be added. So like that. So it is a flexible composition. Depending on the epidemic, we can add to the professionals to this team. So we have, it is a good thing that we have rapid response system now in our every district. So who can really help in not only confirming the epidemics at the early stage, but they will also investigate and take appropriate actions. So that is a good thing for us, our system. But only thing is, the criticism is that our IDSP or the surveillance system is not sensitive to pick up the early warning signals at the early stage. It is because of the process that is getting delayed in analyzing this information that is coming to the higher ups. So it takes time, and by the time we get it analyzed and realize that something is happening, the time is lost. So we have to make our surveillance system more sensitive to get these early warning signals at the earliest. Of course, we have added this media monitoring also, because media many times they bring out the information faster than our health system. So we have in place some of the important aspects or requirements to remain prepared. So under IDSP now, on an average, 30 to 35 small outbreaks are being reported to the central surveillance unit every week, and the number is increasing day by day. Media scanning is also being done to catch up this early warning informations. And once this public health emergency is there, so a time will come that we have to recover from this emergency situation. And in this, the decisions and actions are taken after a PHE, with a PHE means public health emergency, with a view to restoring or improving the pre-PHC living conditions. So in the recovery phase, we have to restore and go back to our PHE prior to what situation we had before this public health emergencies. So that is a recovery phase, and this involves the reconstruction and restore the disaster-stricken area or any other public health emergency through repairing or replacing homes, business, public works, and other structures. Like we are slowly in the process of recovering from our lockdowns and restrictions. Gradually, we are removing those restrictions. And it has to deal with the disruptions that the emergency has caused in community life, and also meet the recovery related needs and victims needs of the victims. Then we have to mitigate the future hazards also. So that is our resilience. We have to mitigate, we have to remain prepared and mitigate the future hazards. Now I will move to the health system's resilience. Health system resilience is defined as the capacity of the health actors, institutions, and populations to prepare for and effectively respond to crises like the current one, maintain core functions when a crisis hits. So that we have observed that because of this COVID-19, our regular functions or regular healthcare services through the hospitals and health centers have been badly affected. So, but we have to, if our health system is resilient, we will continue with this regular activities or regular healthcare services and informed by lessons learned during the crisis. So in this resilience, we learn from our past and reorganize ourselves to face these such future situations. So that is the resilience, how quickly we move in to tackle the current situation that has emerged. And then again, how quickly we go back to the previous situations, learn the lessons what we have, and then remain prepared for the future. And as I have said already, that our health system is going to get several shocks at intervals. It is not end even if the COVID-19 pandemic is over, but we still continue, we will have some of the other shocks sometimes or other in form of public health emergencies. So we have to remain prepared and be resilient. So health systems are resilient.
Sir, please
if
sum
they,
up. Please sum up.
Okay, just
We are running short of time.
okay.
There are 2 more
I will
lectures.
sum up. Okay, so we have to be resilient. I will skip some of the slides and then we'll see that how these are the six building blocks of the health system and around which our resilience must be built up. Like, what are our 6 building blocks in our health system? Is the leadership and governance, our health workforce and health information system, essential medical products and technologies, service delivery, and financing. So our resilience system should be built around this. And I have collected information from the available literatures that we have to build up the resilience. Our resilience will depend on the leadership and governance we provide, our proficient and health workforce, vulnerability, capacity and adoption assessment, risk monitoring and risk communication, early warning, research, sustainable technology and health infrastructure, access to medical supplies, equipment and medications, and so these are the resilience points that has to be built into the our uh, health concerns, the 6 building blocks. And to conclude this, I will say that we should not be complacent even if our numbers of cases are coming down, even if the COVID-19 pandemic is over, but because there are emerging infections are coming and it will come. We may have to face several public health emergencies like this. So we have to remain prepared and remain resilient, and we have to have a strong data and technology. We have used this technology in this COVID-19 that has helped us very well. So we have to develop further. So this is in short I wanted to tell. So thank you very much.
Thank you, Professor Sudhir Kumar.
Yes.
It was a very, very inspiring lecture. And what is important is that you have brought out some of the very important issues with regard to the health emergencies and how we should be prepared, and also what is the resilience of our system. And the leadership and all those six building blocks which you have presented are very, very important. So thank you once again. And Dr. Srivastav, will you introduce Dr. Dwivedi?
Yes. Professor S.K. Dwivedi, he is going to talk on cardiovascular and hypertension. Professor Dwivedi is a senior professor in the Department of Cardiology, King George Medical University, Lucknow. He specializes in interventional cardiology and electrophysiology, which is very important. I would request Dwivedi ji, Professor Dwivedi, to start his presentation.
I would request
Professor Dwivedi, you can listen me.
Time 25 minutes.
25 minutes.
I would try to finish, madam, in 20 minutes. The earlier speaker has not stopped sharing his screen, has he? Sir, you please share. Earlier speaker has stopped sharing. You please share. I am pushing the share button. But I'm still not able to see my slides myself. Give me one moment. Yes. So I hope you are able to see my slides now.
Yes, sir.
Yes.
Yes, sir. Make it a full screen, sir.
Yeah. It is full screen now.
Yeah. Yes, sir. Good.
At the outset, I would thank Professor Manju Sharma and NASI for sharing me some of my views. I would be talking about the cardiovascular care in COVID times, a newer perspective, how COVID-19 has changed the whole epidemiology of cardiovascular disease as a whole and coronary artery disease in particular. This is my college, 1905 building, nearly 115 years old. And this is the work that we are doing. This is 2019 statistics. We are a faculty of 10 residents, 24, 75 beds, and we are adult-oriented department. We are very, very busy department. I would rather very quickly go. COVID is three-stage disease. Mild is 80% and severe is less than 5%. And that is the most serious problem that come across. And this is a classic slide which tells us over days how from viral replication to immune dysregulation comes because of cytokine storm. So cardiovascular system in COVID is also involved, and cardiovascular involvement can occur as a presenting like coronary artery disease or acute coronary syndrome, or it can directly involve the myocardium presenting as myocarditis, or it can present as embolus or thrombosis in arteries and veins, and lastly, it can present as arrhythmias. Now, the mechanism, as we know, it is different than other coronaviruses only because it is attaching to the ACE receptor. And ACE receptor we know is ubiquitous. It's found mostly in lungs and almost all vascular endothelium. So it is basically causing an endothelialitis. And that results into a organ system involvement, predominantly heart and any other, the whole vasculature, because it produces activated tissue factor, plasminogen pathways, and results in venous or arterial thrombosis. So this is what differentiates from other coronaviruses or influenza-like viruses because the mode of action is peculiar.
Now, managing cardiovascular disease in COVID is like riding two horses. You have to manage cardiovascular disease in COVID patients, and also there another aspect is managing COVID in cardiovascular disease patients. So my talk will be predominantly focused towards the cardiovascular disease management in COVID patients. We know that case fatality rate goes higher as more if there are only risk factors involved which are predisposing to arterial involvement like hypertension and diabetes mellitus, then it is threefold. But once the frank cardiovascular disease is present, then the case fatality rate rises to 5 to 6 times. Most of the guidelines, most of the international societies have issued their guidelines how to deal with a particular situation, and we have to basically wait for the situation to arise. Uh, Guideline directed medical management remains the mainstay in cardiovascular disease. Statins, there is minimal data, but since inflammatory response in COVID also destabilizes the atherosclerotic plaque, producing myocardial infarction, statins may be helpful. Initially, there was a concern that since it is coronavirus is attacking the ACE receptors, and conflicting data were available, but now some large retrospective and some prospective data have also shown that it is a misplaced concern and they should be used as and when required. So, coming to cardiovascular involvement, it may present, as we discussed, as acute coronary syndrome and differential, which presents as chest pain. And once it is presenting with chest pain, it can be either a type 1 myocardial infarction or usual myocardial infarction, heart attack that you are aware of, which is because of the plaque rupture of acute thrombosis, or it can be a demand supply mismatch because the target organ, that is respiratory failure, is there and it is a response to hypoxemia. The other type of chest pain, non-specific, can be because of direct myocardial involvement. And then besides this, pulmonary embolism and non-cardiac respiratory or gastrointestinal, other systems may also cause this. So once you are analyzing whether this patient is having chest pain, whether it is a coronary artery disease or not, you will have to consider the scenario, the symptoms, ECGs, and enzymes. Coming to enzymes, troponins are known as cardiac specific enzymes, and they were known to tell us that yes, this rise is because of myocardial injury. However, in COVID has changed all this. Troponin elevation is very frequent, as high as 50%. So it depends upon which population is involved, and it may not be directly telling us the involvement of coronary artery disease or myocardial loss as such. However, one thing is certain that if there is a elevation of troponin, then mortality is manyfold higher. So elevation of cardiac markers, which used to be the hallmark of myocardial infarction or heart attack, is not reliable for diagnosis. The diagnosis becomes tiresome. Coming to ECGs, these are the systematic review of the Indian literature. And what they showed is commonest finding is probably QT interval prolongation, but that is not much dangerous. Sinus bradycardia, or let us say the heart rate slowing, is ubiquitous. It can be seen as high as one third of population. But ST elevation, which is a hallmark of acute blockage of coronary artery, is also seen without any block in the coronary artery. And this is a beautiful case series by Bangalore and his colleagues. Out of 18 patients who presented with ST segment elevation, that means that mimicked the heart attack, only one third had coronary artery narrowing. And the ECG is very classical for inferior wall MI or very classical for anterior wall MI, but the coronary artery disease was not there. But one thing is sure, so we come to a conclusion that ST segment elevation may be present without coronary artery obstructive disease. However, if ST segment changes are present, it is a high risk scenario. So, how to proceed for diagnosis? Because symptoms are not helping, enzyme rise is also not helping. There comes the value of echocardiogram or imaging. A traditional echocardiography machine is a huge machine, but a point of care, that is POC, handheld echocardiogram, comes as a boon in such situation. And this has been very helpful in the current scenario in most of the hospitals, at least in our hospital, to screen whether you find any involvement of myocardium or not. Now, another aspect of incidence, how it changed the epidemiology, is that when the COVID started, From Italy came the report that there is a reduction in hospitalization for myocardial infarction. And all across, there was a 25 to 60% reduction in various types of myocardial infarction. And this alerted. However, this trend was worldwide. What reduced the incidence? There were many theories. They said that it is basically travel restriction or hospital phobia in the people, and they are hiding their symptoms or they are not coming. But still, others believe that this is health promoting circumstances. We know that pollution was less, the life habits changed to better life habits, eating habits, work stress was reduced, and regular exercises helped. So, another theory was proposed that probably the incidence of coronary artery disease in newer occurrence has probably reduced. Or other possibility can be these are holding them their problems and they will be presenting late. This scenario has been there throughout the world, which is you can see here right from 25% to 50% reduction. What happened in India? This is a survey of Cardiological Society of India, which involved about 270 hospitals, and they took two periods. One, a period of 2019 between March 15 and June 15, and compared it with the same period in 2020, that is during the lockdown. And what they noticed is this data is yet to be published. Uh, they noted that there was generally one-third reduction in admissions. So compared to more than 25,000 admissions during 3 months in 2019, there were 15,000, 16,000 admissions. And another important thing is that despite that, the ST elevation proportion was significantly higher, but intervention was much lower. Despite these, the mortality or death rate was similar in both the issues. And I am pleased to tell you that our university was the highest volume center during that period. That is what was seen in our records also. This is the 2019 number that I showed you, and this is a 8 months number. You can see here that there is nearly one-third to one-half reduction in all admissions, procedures, angioplasty or whatever. Everything was reduced. Then where did the MIs or heart attacks go? It really did not occur or they did not report. But then suddenly started coming the increasing incidence of sudden cardiac death, again starting from Italy. What you are seeing here is these are the days after 28th February, increasing days, and here you see the difference between the blue bar and the orange bar is telling you the sudden cardiac death. Now, this trend was also observed all over the world. This increase was from 40% up to 3 times in New York State. It was 3 times increase incidence of sudden cardiac death. However, the number by which the sudden cardiac death increased can only explain 10% of missing heart attacks or the numbers that were reduced. We still don't know where are the other numbers, but the presumption is that those patients they did not report and they will add up later with increased incidence of heart damage, probably at a later stage. How it changed the management strategy? For hospitals were full with COVID patients and there was a resource crunch. Guidelines, in the meantime, downplayed the angioplasty gold standard strategy, and they divided European guideline, American guideline, even Cardiological Society of India guidelines. They said that identify low risk and high risk, and then high risk can be managed or subjected to angioplasty. Low risk can be managed with less invasive procedures. However, United Kingdom remained on invasive strategy in all patients. What was the outcome? This is the Italian data. You can see here the blue bar tells you before the pandemic and yellow bar tells there is an increase of mortality or death rate by 2 or 3 times in Italy. Similar data was reported from other parts of the world. But discoordinated or disjointed or exactly opposite data also appeared from all this the English data, England data. This is a and what they showed is that from earlier period to later period, the heart attack death rate has been going down. That means there is a disparity between the results of management strategies in various countries and societies. Rational approach, as I said, should be doing a angioplasty. However, fibrinolysis, or what we can also say clot lysis, is probably more rational because it doesn't require a intensive care unit. It once you give a drug and you have the evidence that the artery has opened, patient can be taken up for coronary intervention, and this strategy reduces the need for healthcare personnel and avoiding unnecessary exposure to COVID-19 to patients. And so we evolved our own strategy, that is a pharmaco-invasive approach. This was taken by most of the teaching hospitals. Almost all general hospitals, they took their patients in a triage area where they decided whether it is high suspicion or low suspicion. If it is a high suspicion, they took them to the isolation or holding area. COVID test was done, then they were taken to destination ward or dedicated COVID facility if COVID was positive. And the management of ST elevation MI that we followed was, if the patient is coming within 12 hours and he is stable, we went for thrombolysis in holding area itself. Intensive care was created in a holding area, a semblance of intensive care, and their thrombolysis itself was given. In our routine periods, we probably may not be doing that. And in patients who are coming with more than 12 hours of heart attack, they were waiting for the result and then they would be subjected. However, if there is any patient who is serious, sick, or unstable, he would go to the COVID cath lab, which was dedicated for COVID patients. And this was the similar guidelines which was given later by Cardiac Society of India that we have been already finding. And as we have told you, there was no difference in Cardiac Society of India survey, and mortality in 2019, that is pre-COVID and during COVID period, was less than 5% using this approach. In non-ST elevation, almost all societies said that let us go for conservative approach. Let us not run or push the patient for angioplasty, only limiting them to seriously ill patients. Coming to another area of myocarditis, we do not know what is the precise incidence of myocardial viral involvement, that is myocarditis. However, due in patients who are suffering from COVID, the magnetic resonance data had shown a lower ejection fraction and increased heart size, indicating that probably there is involvement in the heart. At the same time, there were biomarker elevation and active elevation on endomyocardial biopsy if you're taken from that. Very lately, we have found that viral RNA has also been identified on autopsy in those patients which were not having very fulminant or severe myocarditis. And nearly two-thirds of these patients had upregulation of inflammatory genes also from the autopsy specimen. Now, what is the interpretation? And this interpretation has been put forward by CMR data in a very recent, beautiful study, who have taken 67 non hospitalized COVID recovered patients. They did not require hospitalization. And CMR, that is magnetic resonance imaging, was done after 7 weeks of the illness. But there was still evidence of myocardial edema and inflammation. And 80% of these patients had troponin, that is enzyme positivity, indicating myocardial damage. How to interpret this? Probably we do not know what is the intermediate or long-term sequelae of hidden or manifest myocarditis and how they would manifest in future. Only long-term follow-up and time would tell us. Coming to another aspect of heart failure, patient presents with breathlessness can be because of systolic functional abnormality, or this can be directly because of the myocardial injury, or it can be a diastolic abnormality, or this can be an entirely different organ system, predominantly the respiratory failure. Now, how to approach? Because this breathlessness is a hallmark sign for heart failure. But dyspnea can be multifold, and classic enzyme, that is B natriuretic peptide, may not be reliable because again it is elevated in various other situations, particularly of respiratory illnesses. So this is not able to differentiate. So we cannot say whether it is a respiratory problem or cardiac problem. Again, here the point of care imaging, that is echocardiography, comes to help. So what we had done is that in admitted patients, whether it is admitted whether we are screening them in OPD or in screening area or isolation area or ICU, we had given the residents a handheld echocardiography system, which can immediately tell us, and that put our reside. We did not reliance on the enzymatic or biomarkers or other investigations were reduced, followed by optimal guideline management. But in out of hospital care, telemedicine services were provided, and we have learned that telemedicine can reduce the patients coming to hospital
Thank you very much, Professor Dwivedi. It was a very informative lecture, especially in the present circumstances when we are facing the pandemic. And you have really given us the insight into the cardiovascular and related problems. Our next speaker is a very renowned physician, a very renowned academician, and a brilliant scholar, Professor Nikhil Tandon. He is an endocrinologist, and he is also the former president of the National Academy of Sciences. He is the president incumbent, general secretary of the Indian Society for Bone and Mineral Research. He's the recipient of B.C. Roy Award, the highest Indian medical award in 2005. And he was honored by Government of India, Padam Shri, in 2015. He's a fellow of NASI, fellow of National Medical Academy, and also the Royal Society of Physicians of London. As I said, Professor Nikhil Tandon is a household name in Delhi and also outside India or outside Delhi. And anybody who has diabetes wants to know who is Professor Nikhil Tandon. And so today, Academy is very pleased to have you, Nikhil, give us this lecture. Nikhil,
Thank you,
please.
ma'am. Santosh, should I share my screen?
Santosh, Nikhil is asking, should he share the screen?
Yeah, yes, sir, please.
Every time we shouldn't face this problem, Santosh.
No problem, madam. No, there is no problem.
Okay. Before I start, just want to confirm that the screen is visible.
Yes,
yeah,
sir.
Very good.
If okay, let me once again convey my greetings on this occasion. Thank the Dr. Manju Sharma, NASI, for having conferred on me the Professor M.G.K. Menon Award lecture. This is conferred in 2019, but with COVID, everything is running late. So here I am 2 years after the award, presenting this lecture towards you. I appreciate the fact that the previous two speakers have done an exceptional job looking from a COVID perspective. My talk will have nothing to do with COVID, except for one very, very important point, which I need to convey to the audience as general, that there is some evidence that people with diabetes may be at higher risk of getting COVID, but there is categorical and unequivocal evidence that once a person with diabetes gets COVID, their outcomes are unfortunately more severe and more adverse. So the likelihood of need for hospitalization, the likelihood for ICU care, the likelihood for ventilatory care, and even worse, the likelihood of mortality is much, much higher in people with diabetes than without diabetes. But I will not talk about acute care today. What I will be doing today is speak on an area which is called technology and task shifting, and see if that is of any utility as we evolve our strategies for care in people with diabetes. It is customary to show some information about the named lecture, and in this case it is Professor M.G.K. Menon. If I start giving a description of his achievements, I will use the entire time of my lecture in doing that. And in any case, providing information to NASI about Professor Menon is like preaching to the converted. So I will not say anything except to bring in a slight personal touch. I mean, everybody knows the relationship with Professor Menon had with NASI, but what many also know is the extreme bonding and association which my father, Professor P.N. Tandon, had with Professor M.G.K. Menon. And we as a family were fortunate that this relationship not only was limited to the two gentlemen on the screen, but transcended to the families. And I've had the privilege, pleasure, and the honor of knowing Professor Menon through my formative years. And I owe him a great debt of gratitude for some very, very significant advice and interventions which he made at critical junctures of my career. And I'd like to put on record this substantial gratitude, and it's an immense honor for me to be able to give a lecture which is named after him. Okay, so I'm going to break this talk up into three parts: what we know, what we don't know, and then what we did. What we know is then going to be divided into two parts: the burden of the problem I'm dealing with, and then the gap between our knowledge and what we actually managed to deliver, which is the bulk of today's talk, because I will be talking to you in terms of translational research, which is trying to bridge the gap between evidence and practice. Now, numbers are always joyous, because every specialty tries to say that we have a lot of patients we look after, but there are about 75 million people in India who have diabetes. Most of them, unfortunately, 80% of people in India with diabetes have blood sugar levels which are out of control. 80%, right? That there are 6 to 8 million cases of retinopathy, kidney disease, nerve disease, and heart disease, which can be attributed directly to diabetes. But I think the important part in this grim scenario is that reducing HbA1c, and HbA1c is a measure of an average glucose control over 3 months, reducing HbA1c by 1% sounds like a very small number. Actually, it is a very difficult thing to achieve. But reducing A1C by 1% reduces the likelihood of kidney problems by 33%, retina problems by 30%, leg amputations by 40%, and heart attacks by 14%. So it's a very, very desirable objective to keep glucose under control. But it's equally important for us to understand that there are similar benefits in reducing blood pressure and reducing cholesterol. All put together give a substantive benefit. Now, what is actually needed, and I'm grateful to Dr. Satpathy for having introduced some of these concepts in his talk, but essentially to say that there are three broad domains in which an intervention is required. Clinical health services, which I as a practicing physician can do, in which I make efforts to reduce sugars, reduce blood pressure, reduce cholesterol, ensure that people come for their routine testing, they go for their eye examinations, they take the immunization as required, etc., etc., etc. There is also a behavioral and health promotion aspect, which is saying that the patient themselves have to do diet control, physical activity, non-exposure to tobacco, ensuring that they make visits to the doctor, ensuring that they monitor their sugars at home, and also get educated about their disease. And that is something we need to assist patients to do. But equally important is the third angle, which is policies which influence the health system and the population. Legislation for healthcare, drug supply, reimbursement, insurance policy, population registries. You just heard what Professor Satpathy mentioned about the need for a surveillance program. This is being done primarily for infectious diseases and acute outbreak, but registries and surveillance for chronic diseases are equally important. What we really have fallen extremely short in is our inability to translate whatever evidence we have into sustainable, economical, proven strategies. Right? And that is an important aspect which I will then talk to you about in the next segment of my talk. Right? And this means in simple, and nowadays it's fashionable to use terms. So we use a term called the no-do gap. We know what is to be done, but we don't do that. So it's a no-do gap. Again, I would like to look at three parts: physician barriers, clinical inertia. Patient comes to me, is already on 2 or 3 different types of tablets for diabetes. Sugars are not well controlled. I know I need to put this patient on insulin. I'm concerned, and I'm sorry for ridiculing my own community. I'm concerned that if I suggest insulin to this patient, patient bhag jayega. I will have one less patient, I will have one less customer. And the patient says, no, doctor, give me another chance. I'll fix it. Last time it was too cold. Last time it was too hot. It was raining. I couldn't go for my exercise, etc., etc. There's a standard list of excuses. And the physician shows an entity called clinical inertia. They are reluctant to escalate. It is not India alone. The average gap between the time when, for example, insulin should have been started in a patient to when it was started has been seen to be as much as 18 months plus in good clinics across the world. So we are culpable. Patient level barriers, of course, overall, there are low levels of awareness. Diabetes is a relatively asymptomatic disease, and therefore people don't worry. When the symptoms because of complications appear, the doctor says it's too late, we can't do anything. So it becomes troublesome. There is no adherence to self-care activities. There's often a lot of confusion about medicines. You know, they say, kitni dawai khayenge? There are 10 tablets. Khana khaye ki dawai khaye? It's a problem. Really, it is a problem. And then, of course, there's system-level barriers. We're a big country, few doctors, few clinics, which are overcrowded, disorganized. The diagnosis of diabetes gets delayed. There's a fascinating 50% rule for diabetes and for several other non-communicable diseases. So out of every 100 people who have diabetes, 50 don't know they have it. Of the 50 who know it, half of them don't go and see a doctor. Of those who go and see a doctor, half of them don't start treatment. And of those who get treatment, half of them don't meet targets for control. So out of every 100 patients of diabetes, 12 actually have well-controlled sugars. 12. 50, 50, 50, 50. That is the story. Right? So before I shift to the next segment, which is what we did, I think I want to introduce a concept called task shifting. there are not enough doctors in this country to manage all the patients. So can we ask non-physicians to offload some of that activity? And this whole concept of task shifting is a well-known, well-substantiated, well-validated, and well-endorsed by the WHO. So it's basically trying to use non-physician healthcare workers to implement a part of the activities. We have blood glucose monitoring equipment in the clinic. Why do I have to do that sugar test as a doctor? There are automatic blood pressure instruments. Why do I need to measure blood pressure in the patient? If the patient is spending 10 minutes in the clinic and out of that 5 minutes or 8 minutes, I as a doctor are spending measuring sugars, measuring blood pressure, I'm wasting valuable time. I can still have that patient for 10 minutes, let the patient do a lot of this stuff by a nurse, by a non-physician care provider. Let me spend that 10 minutes in treating the patient properly. Let me do what only I as a doctor am trained to do, and let whatever can be done by anybody else with less training be done by them. And that is a concept of task shifting, and that has been a central core of what we have been trying over the years. And I'm going to take you through a set of studies now which really show how we try to overcome the no-do gap. So this was the first study with this. This is 10 years ago. It's called the CARS Translation Trial. The CARS was a Center of Excellence we were awarded by the NIH, called the Center for Cardiometabolic Risk Reduction in South Asia. This is a randomized control trial. Randomized control trial became popular a couple of years ago when Abhijit Banerjee got the Nobel Prize in Economics for introducing RCTs in economics. I just want to reclaim the primacy of biomedical research. Randomized control trials were done by medical scientists 50 years ago. This is our preserve. The economists have just tried to steal it for their own purpose. But remember, the RCTs are done by clinicians. So this is an open label randomized controlled translation trial in which we evaluated a strategy which was low cost and sustainable to try and improve delivery of care and assist people in reaching multiple targets for control in patients of diabetes. These are 1,120 patient, 10 centers in South Asia. And we used two interventions, a human intervention called the care coordinator, which is a non-physician healthcare provider who became the fulcrum of care provision. The patients did not first go and see the doctor. Obviously, they went to the doctor because the doctor would then eventually treat. But they were coordinated by the care coordinator. They assisted guideline adherence. They facilitated the patient follow-up referrals. They acted like an advocate for the patients. Please remember that the average patient from the socioeconomic and educational class they come think that the doctor comes from another planet. There is an absolute gap between their relationship between them and the doctor. They are not comfortable. They don't open up. They don't tell. And the doctors, of course, speak to them as if they're on a pedestal and they talk down to them. You need an intermediary who can understand the problems of the patient, who can effectively communicate that to the doctor, who can then incorporate that information in arriving at management solutions. And the second part, which was technology, was creating an electronic health record, which are now quite frequently used, especially in corporate India, but also in the government sector. And we developed a decision support software. So we developed algorithms for control for managing diabetes, for managing blood pressure, and for managing cholesterol, which essentially worked on the principle that if this is the medication the patient is on, this is their current value, this is what needs to be done. Increase dose, reduce dose, or keep it constant, right? And these records helped us store and track. This is chronic care. This is not acute care. This is not treatment of malaria. This is not treatment of typhoid. Patients do not get better in 3 days or 5 days or 7 days. My patient of diabetes is my patient unless they get tired of me and walk out of my clinic, or they succumb or I succumb. My patients stay with me for 20, 30, 40, 50 years. This is not a week-long treatment, and we need to understand the principles of continuum of care, which is critical. So this is what we did. We randomized patients, a single level randomization, into a strategy which was usual care. We did it in high-end tertiary care hospitals with good practitioners. They were standard treating endocrinologists. And we use either usual care or we use the assisted strategy involving a care coordinator with the electronic health record. And the outcome we said, so these were people who had poor control. So they had elevated sugars and at least one of the following: poorly controlled blood pressure or poorly controlled cholesterol or both. And the outcome we were looking is to see whether we could improve the likelihood of them achieving their multiple targets of control. So bring their HbA1c to under 7%, bring their blood pressures to less than 130, or their cholesterol less than 100. And that was what we intended to do. 10 sites across India. We eventually recruited 1,146 people. So this is what really happens in a clinic. You go to a doctor, you go to the clinic, you register, you tell them, "Meri bari hai, aa gaya." Somebody looks at your lab values, looks at your height, weight, blood pressure. The doctor sees you, does whatever examination they want. Say, "Okay, next time you need to come back after 3 months, take these medicines and get these tests done when you come back." And then you go, pay the bill, and off you go. Whether the doctor's message has gone through, whether the patient has understood anything about the medicines, whether they're going to take the medicines, whether they're going to get the test done, whether they'll come back in 3 months, 4 months, or 6 months, nobody knows. And unfortunately and bluntly, nobody cares. What we did was change this around totally. We said the person who's going to provide that central role as a care coordinator, they will contact the patient, they will get the patient, will come to them. The patient's measurements are done by this person. The lab data are entered into the electronic case record form by this care coordinator. There is then an output which is generated. So the software then delivers an output. Then the care coordinator, along with this recommendation for treatment, go and see the doctor. The doctor is now therefore getting, if I use a dietary analogy, a digested patient, a triaged patient. All the information is there, so the doctor is going to spend 5 minutes. It's going to be 5 solid minutes for what the doctor alone could do, and not idhar-udhar ki baat, right? Once that visit is over, the patient then again sits with the care coordinator who explains, ye dawai hai, itni khani hai, itni baar khani hai, ye karna hai, itne din baad aana hai. And then arrange their next appointment, call them for the next appointment, get their investigation done, and the cycle goes on, right? So that's the role of this human being. And we employ these people at a salary of 10 to 12,000 rupees a month, which is nothing. Because it doesn't make a difference to the clinic cost. So we, as I said, created these algorithms for glucose, for blood pressure, and lipid profile. This is a screenshot of that. To give you an example, you can see the current values, you can see the previous values, you know what treatment the patient is getting. You get an advisory as a doctor, you're free to accept or reject. See, the prescription has to be done by the doctor. The doctor says, no computer is going to tell me what to do. We say, no computer is going to tell you what to do. The computer is presenting to you evidence-based suggestions. You may have additional information which overrides that. You're the boss, do what you want. But since this is a clinical trial, only one request. If you don't accept the recommendation, just let us know why, so that we understand why you didn't do it. Feel free to do whatever you want. And this happened day in, day out, and this happened. And I'll show you some very interesting data related to that. This is just to show that the two groups of people were matched in terms of their ages, gender, their baseline A1C. As you can see, 10% average A1C. The target is 6.5 to 7%. Similarly, elevated LDLs. They were overweight. They had a history of heart disease. Very small proportion were smokers, and they'd all had diabetes of 7 years plus. Long story short. Now, normally when you present data, you say, this group had a 10% benefit, 20% benefit, 30% benefit. Let me put this in another word. The likelihood of a person achieving multiple risk factor control if they were randomized to our strategy of technology plus task shifting was 2.25-fold higher Converting that into percentages, the likelihood of them meeting multiple targets for control was 225% higher. Not 25%, not 30%, 225% higher. That was the level of impact for multiple risk factor control. This was predominantly driven by an improvement in their glucose, which was nearly 1.93-fold higher. That's nearly 200% higher. Smaller but statistical impact on cholesterol, which is about 25%, and even smaller on blood pressure, which was 15%, but a consistent benefit. We didn't change a medicine. We didn't add a new investigational agent. We didn't change the doctor. We just changed the strategy, right? So we had a whole bunch of papers. We got a paper in the Annals of Internal Medicine, which is really top end. I mean, this was 5 years ago. This was really, really applauded everywhere. And since then, we've actually sort of done many rounds of secondary analysis. But clearly, what we've demonstrated that a simple, inexpensive, evidence-based tool in task shifting could quickly and effectively improve diabetes care. Now, interestingly, different prompts were accepted differently. So the likelihood of a suggestion for diabetes, that is glucose control, was less often accepted by the doctor because the variables in play are so many that all of them could not be captured in the scenario-based algorithm. So it's cold, it's hot, घर में बेटी की शादी थी, बारिश हो गई, दवाई छूट गई, मैं वैष्णो देवी चला गया, इंजेक्शन घर में छोड़ के चला गया. This is impossible to capture in a rule-based algorithm. Very high acceptance of blood pressure and very high acceptance of cholesterol problems. Very interesting again. And we asked the physicians later on, would you, if this was available to you on a routine basis, take it up in your clinic? 100% said yes, yes, and yes. For the feeling that they said we can dispense with junior doctors, it's cheaper, we get evidence-based care, we actually focus on the important issues, and it helps us think through the patient-level problems. So very positive feedback. Again, though this was not supposed to look at the prompts alone, we analyzed what happens if you accepted our prompts and you didn't accept the prompts. Clearly, if you accepted our prompts, you had a lower blood pressure, a lower cholesterol. The results on the HbA1c were not as, were generally more equivocal. So the actual algorithm also worked. So this was tertiary care. We actually then went and did this in secondary care in Solan district in Himachal, 6 community health centers and district hospital. We did it in primary care in PHCs in Ballabgarh. We then did it more in secondary care. We also did it in heart disease patients. And then we did it in comorbidity. So we did it in people of diabetes with depression. And this was a study which we published a few months ago. Essentially, this was, we know that there is a bidirectional relationship between diabetes and depression. Chronic disease causes depression. Depression reduces your ability to manage your chronic disease. And essentially, we therefore used a similar process of a care coordinator along with the electronic health record, along with treatment of sort of a team care approach in which the records were shared between the endocrinologist and the psychiatrist without the patient ever going to a psychiatrist and seeing what happens. Again, I'm going to run through these slides quickly to show that there was a clear benefit in glucose control and there was a clear benefit in depression control, right? There wasn't any benefit in blood pressure control. There wasn't any benefit in cholesterol control. In this study, it was comorbid diabetes and depression, but clearly the two main parameters, HbA1c and depression, improved, right? This is a study from Himachal, and this was spectacular because, you know, when you do things in tertiary care, the doctors are usually better trained, they know what is to be done. This was a primary care physician sitting in a community health center, and you can see that this was a pre and post study. We looked at it when they came in, we looked at it when we followed them over a period of time. Look at the drop in blood pressure. Look at the drop in sugar, right? A mean drop in systolic pressure of 15 millimeters of mercury. 1 millimeter of mercury can change your complication profile. 15 milligrams per deciliter reduction in glucose. This was whether this was a walk-in new patient or a follow-up patient. This is absolutely spectacular. So this actually summarizes what we've done over 10 years. This has been a long journey for us. We started in 2010, as I said. Tertiary care, we've done the CARS trial for diabetes, comorbid diabetes, hypertension, cholesterol, the independent trial for comorbidities. At the community level, we've done the SIM-card trial. At the primary care level, we've done and the MPAR study, which is in Solon. We've also done the MWellCare trial in Karnataka and Haryana. You'd be really pleased to know that 2 states of the country, I know they're northeastern states and they're small, but Mizoram and Tripura took this on as their standard of care. So all secondary care institutions in Mizoram and Tripura follow this approach to manage. And now we've moved on to do the same thing across all levels of healthcare in Punjab, and I'm going to take you through that very, very briefly. And the WHO Southeast Asia region has used our assistance to develop this model for delivering NCD care in Maldives. So we've gone outside of India. I'm not going to spend time in this except to confirm what I just mentioned, that in Tripura, 40 hospitals, 2 PHCs, 19 CHCs, 12 sub-district hospitals, 6 district hospitals, and 1 state hospital have now taken this on. There's a dedicated website for the project, and everything is run by the state government, right? Nearly 200,000 patients have been enrolled, and they are being treated as we talk. The same in Mizoram, the smaller state. Again, about 10,000 patients, but 5 CHCs, 3 sub-district hospitals, and 8 district hospitals. And this is the story of the MPEN and in Maldives, in which we've gone beyond diabetes and hypertension. We've gone to asthma, chronic obstructive pulmonary disease, and some cancers also. And now to bring you to the last, and we're very, very pleased with this effort, because till now, as you see, what we've done is looked at primary care institutions, looked at secondary care institutions, looked at tertiary care institutions, but people don't do that in our country. People go in wherever they want to. There is no system, there is no process, and people can get referred wherever. So we decided we will take over 1 full district in Punjab and cover all the institutions. So actually what we did was we took 1 block in a district and all the institutions and did a comparator block in that. This is ongoing study, which is again funded by the NIH. And we have a large team from AIMS, from Center for Chronic Disease Control, PHFI, from Emory University, from Dell, which is providing the software for the government of India, which we've helped develop for the government of India, from Tata Trust, which are doing the training, and the state government of Punjab. This is a massive, this is really translational, because this is actually us at the back end and the government doing what they should be doing. So the goals of this study were to strengthen hypertension and diabetes care in the public system. We already have a package of technology and task shifting, tailor this for each level, integrate the software application across the levels of the healthcare system. And I think very important to understand is that in 2016-17, the government of India decided to offer universal screening for diabetes, hypertension, and 3 common cancers, breast, cheek, and cervix, to all people above the age of 30 years. To aid that, they've developed a software which we as a team helped and assisted in development. To that, we developed a decision support software which is pluggable, like through an API, into that software, which can go different levels of algorithm for different levels of healthcare. So if you only have a sugar which is random, which is available through a finger stick, our algorithm works on that. If you have formal fasting in PP, our algorithm works for that. If you have fasting in A1C, our algorithm works for that. You bring your value, we will run an algorithm. Right? So this is again to show that this is, if you remember Dr. Satpathy showing the multiple levels of the public health system. So we have primary health, there are sub-centers at the village level, PHCs which cover 3 to 5 villages, community health centers which are for a block in a district hospital. We have now installed and implemented this across all levels of healthcare in district Nawa Shahar, now called Shaheed Bhagat Singh Nagar, in Punjab, and we have this in the intervention block in Mukandpur and a control block. And essentially what really happens is that the ASHA worker fills in, and now we've actually gone ahead of the government of India. We provided a mobile phone to the ASHA workers so that they fill what is called a risk factor form, which is to be done by them. It's normally filled by them on paper and then digitized by the A&M in the sub-center. We gave it to them so that they fill it up and the A&M's work becomes less. Anybody who is screened positive then goes to a PHC, and then our system kicks in terms of nurse review. So the nurse in the health system works like a care coordinator. The doctor works like a doctor. The recommendations come and the doctor can decide what to do. But here we've also defined referral thresholds. We've also created referral linkages and said, इतनी शुगर है, इतनी दवाई चल रही है, कंट्रोल में नहीं है, पेशेंट को हायर लेवल ऑफ हेल्थ केयर में भेजो. We send message across to the higher level of healthcare. They are received out there, treated, stabilized, and then can be sent down back. So it's a whole integrated system which is working. And again, I won't tell you, this is a lot of background. It took us a year and a half just to get things started. We launched it last year in January. 2 months after we launched it, COVID came, right? So we had a bit of an interruption, but you can see we've trained nearly 400 government providers, doctors, nurses, A&Ms. We've given them training on medicine, medical aspects, training on software. We've trained about 90 ASHA workers on technology. And this is our hand-holding going on there. So the impact has been of all these efforts over a period have been, we've tried to standardize care across all healthcare facilities. Let me just say, we just started Punjab a year ago, so we don't have data. Hopefully one of these years I'll be able to share that data. So, but we've realized that task sharing and task shifting are important. We're reducing some workload of the medical officers so they can actually do work which only a physician can do, and taking the non-essential work to non-physician healthcare providers. We're improving the quality of care, and we're generating a powerful information system. With the click of a button, I can tell you today how many patients came in any CHC in my block, any PSC in my block today, yesterday, a week ago, a month ago, what happened to them, were they referred, if they were referred, did they go to the next level of care, if they went, were they treated appropriately or they were not approved. It is now available. The Punjab government, if they want to, their state data center in Chandigarh can get this information in real time. And data, as you know, is money. So we've also been very fortunate that this work has been acknowledged in a lot of places, and I won't go through that. So the take-home messages, and I'm winding up here, is that unfortunately, the quality of care we deliver is not great. There are factors which are physician, patient, and system level which contribute. The translation of knowledge to practice is suboptimal. There's a massive no-do gap. Therefore, we need not only to educate everybody, we need to improve care delivery. What I'm presenting is one strategy. I don't want to leave you with the message that this is the only way of doing things, but this is a way which has worked for us. And we hope that this is a way which will be taken forward by the rest of the country. Thank you so much. I will stop here, and my apologies for overrunning my time slightly, but this is an area I'm passionate about, and I do tend to overrun. My apologies once again. Thank you so much.
Over to Santosh.
Thank you, Professor Nikhilji. Thank you very much. Dr. Santosh.
Sir, yes, sir. Thank you very much, sir. First of all, I request to Professor U.C. Srivastava, sir, the co-chairperson of this, kindly say about this lecture, and then we will announce about this lecture award, Professor M.G.K. Menon Award. But before that,
we heard
about to conclude all the three sessions and about the sir lectures and details about his so informative talk, sir.
Dr. Santosh, we heard a very nice lecture about the diabetes, and I was really waiting for such type of lectures. Now I read the citation.
Sir, sorry,
M.G.K. Menon Lecture Award.
1 minute, sir. But before reading that citation, because this award lecture is so prestigious award and instituted by the Academy in the year 2015, And Professor Menon sir is one of the most renowned scientists and architects of Indian science and technology. He need not any introduction. But here we are joining with so many young students, new scientists and new budding scientists. They must know about this legend personality of this iconic personality of our country. The academy is so much grateful for Professor Menon sir. And here I want to put one slide about his very brief about Professor Menon sir for our new generation, sir. He was the only one person, I think, no any ministry was left by the Professor Menon sir to develop and design, shaped either in the Ministry of Science and Technology, Health, Department of Agriculture, all the ministries he was supposed to be the secretary and so many prominent places. Even the asteroid 7564 Goku Menon was named in the honor of him. And I request to all the new generations to must know about this legendary personality. And here, as earlier told, that Professor Nikhil Tandon sir has delivered his talk on the dedication of the Professor M.G.K. Menon Memorial Lecture Award. And earlier, the great other recipients of this prestigious award was Professor Balram Bhargava sir, Dr. T.R. Sharma from New Delhi. Earlier, Dr. Ajay Parida from Director ILS Bhubaneswar has also received this award. Dr. Ram Gopal Rao, Director of IIT New Delhi. And yesterday we have also heard about this Memorial Lecture Award 2020 by Dr. Amit P. Sharma, who is the Director of NIMR. And we are grateful to the Professor Nikhil Tandon sir to kindly, he has also delivered this talk, the Memorial Lecture Award 2019. Next slide. I request to Professor, next slide, UC Srivastava sir to kindly read the citation. And as per the announcement, the awardee will be given a medal, a citation, and the cash award. Because we are going to share this program by the virtual mode. So the medal, citation, and the cash award will be sent to your address, sir. We are thankful to you. I request to Professor UC Srivastava sir to kindly.
Okay. Professor M.G.K. Menon Lecture Award 2019 has been conferred to Professor Nikhil Tandon, Professor and Head, Department of Endocrinology, AIIMS, New Delhi, for his significant research contributions in the area of endocrinology, metabolism, and diabetes, especially in thyroid and metabolic bone diseases.
Congratulations, Professor Nikhil ji, and thanks for delivering such a nice lecture. Namaskar.
We really enjoyed this lecture. Thank you very much.
Sir, on behalf of Academy and our own, we must congratulate you, sir, and thank you very much for sparing your time. And we are here, we have a lot of our distinguished guest is also here. I request to them also to kindly share their views with this session, sir.
Now we request Professor UC Srivastava ji to kindly conclude this session.
Actually, we had 3 different lectures in this session, and all the lectures were very good. The third lecture, which was delivered by Professor Nikhil Tandon, we all were waiting because it is very close to our heart, and we are concerned with the diabetes. And he has told about preventive measures and what the things are going on, how ASHA workers are being trained to look after the diabetes patient. That was very nice. And I would say that I have also learned something from his lecture, and I will try to do what he has narrated, what he has told. Thank you once again. Thank you very much. And
sir,
thanks to all the speakers for their nice lectures.
So now before end of this session, I request to felicitate the chair and co-chair of this session, respected Professor Manju Sharma madam, and the Professor UC Srivastava sir, who had kindly chair and co-chair this session 4 of this our 90th annual session. We are very much grateful to our speakers, Professor Sudhir Kumar Satpathy ji, Professor S.K. Dwivedi sir, and respected Professor Nikhil Tandon sir, who all the three speakers are especially in the medical areas, and they are very much busy, but they have given their valuable time to this to our audience as well as this academy. We are very much thankful. And now we are going to end this session, and for the next session, with the permission of the convener, I think we have living just behind the schedule, so that we may start the next session. And I request to our colleague Dr. Pavitra Tandon ji to kindly coordinate this session 5. Over to Dr. Pavitra Tandon ji, please.
A very good morning to all of you. May I request VM Patul sir? Sir is here. And the speakers of this session are Professor Isan Patro, sir is here, Dr. A. Lakshmaya, and Professor Pramod Gar sir. So I think he may join later. We may start the session.
Pavitra ji, Pramod Garg sir will be joining later on.
Okay. Now again, welcome to the next session, that is session 5 of 19th annual session of NASI. And this session will be chaired by Dr. VM Patul sir, who is the former Director General of Indian Council of Medical Research and currently the NASI ICMR chair, and who is the recipient of many prestigious awards like the Renbexy Award and so many awards, and fellow of National Academy of Sciences, Indian Academy of Sciences, and Indian National Academy of Medical Sciences. May I request sir to kindly chair the session.
Sorry, sir, Dr. Panda sir, we could not contacted to him, and he is not given any information. So the co-chair is you have to only kindly chair this session. Our co-chair is not present here, sir.
Thank you, Shuklaji. Thank you very much for the information. But anyway, take the personally they feel he is there with us, so there's no problem. I think a good morning to everyone. So the three talks in this session. First is actually all our three distinguished people, very well known to all of us. We will be starting with the talk by Professor Ishan Patro. Currently, he's a former Vice Chancellor, Ravinsha University. I thought he's still the Vice Chancellor, but I don't know. There's a typed as a former. But I know him from the days of nearly more than 3 decades in working in GYG Gwalior, where I think one of the very enlightened colleagues who has contributed immensely to developmental biology, particularly for the brain development. And he is going to talk on the protein malnutrition, brain development, and aging. I think that his talk addresses everybody from boom to town. So we look forward to hear him. Professor Ishan Patro. Yes.
Namaskar. Can I share my slides now? I don't see the share. Before I start my slides, I'd like to thank Ma'am Manju Sharma ji for giving me this opportunity to speak to all of you on a rather more important topic. She named that topic as mental health and aging. So I tried to, it was too much to speak on that in half an hour. So I wanted to confine it to developmental part, and then specifically for protein malnutrition. And
Sir, Professor Patro, sir, please share your slide.
I'm not able to do that here.
On the bottom of the computer or your laptop.
It's not giving they've not allowed me, I believe.
No, you have been allowed, sir, from here. Please put on share button.
No, it's not on. That's the problem.
Sir, once again it has been allowed, sir. Please click on the share button, sir.
The share button is closed here.
Sir, niche on the bottom of the.
I know it is there, but it is not functional on my screen.
Oh. Sir, then please send the slide. Dr. Santosh?
Yes, sir.
Do you have the slide of Professor Patro, sir?
No, sir. In the morning, we discussed to the Patro, sir, but still we are not having any slide, sir. Because sir told that the slide is very high file size.
Oh. Large slide. Huh? Okay. Sir, can you... Actually, we have allowed from here, sir, share button. It is allowed. It is showing on the participants also, sir. The button is showing here.
Sorry, he can leave the meeting and again join. Then might be share button start.
Yes, sir. Patro, sir, please leave the meeting and again join.
लक्ष्मैया आप अपनी ईमेल कर दो स्लाइड है यार, क्योंकि चक्कर आएगा.
Sir, mine is ready. I can share. If you want, I can present, sir. Good morning.
Okay. We will wait. We will wait for 1 minute, sir.
Yeah.
Let Professor Patro, sir. Just we will wait for 1 minute.
हाँ ठीक है, बिल्कुल ठीक है.
Okay, sir. Professor Lakshmaya, yes, it is okay. You can share. No problem. But please wait for Professor Patro, sir.
ठीक है.
अभी कॉपी चाहिए. आ फोल्डर में भी लेना कि कॉपी चाहिए. कॉपी వస్తావా? అట్లా కదా ఈ టైటిల్ కాపీ చేయండి. వస్తారా?
Or may I request,
sir,
Honorable Chair.
Sir, Katoch, sir. Just contacted to the Patro, sir. He is saying that we may start with Lakshmaya, sir, and then Patro, sir will join.
ठीक है.
Okay.
Well, I think we invite Dr. Lakshmaya again, a former distinguished colleague from ICMR NI in Hyderabad. Was really, I know is actually the reach to the different parts of the country when I worked with him. The NNMP program of the ICMR, and how it got extended to medical colleges, his contributions to he has a very deep link with the state health systems across the country. We look forward to hear, that his challenges in the broadband connectivity in rural India, the frugal 5G. I think it's a very different topic. I've never discussed this topic, but we look forward to hearing from him. Dr. Lakshmaya, please. Yes.
Yes, sir.
Lakshmaya, please.
I'm presenting, sir. Yes, sir. Full. Good morning, sir. My slides are visible, sir? Hello?
visible है.
Yes, sir. Okay, sir. Fine.
Good morning, all of you, and respected chairperson and other dignitaries. And before going to start, I'm very thankful for NASI for inviting me this important conference at Symposium. And I also thank you, Dr. Manju Sharma, for giving this opportunity to present strategies for control of undernutrition. And this strategies is not new for everyone. Strategies, and we have actually, as Dr. Katoch said, that we have extensively worked on under in the banner of undernutrition and double burden of malnutrition, triple burden of malnutrition. And we have also developed different strategies to control this undernutrition. And even we are very thankful, Dr. Katoj, when he was DG, he has initiated an important program, that district level intervention program, and it was started in more than 40-50 districts in the entire country. And I am also one of the main important contributor in this program. So as you know, we are suffering from triple burden of diseases, and one is macronutrient malnutrition, micronutrient deficiency, and diet-related chronic diseases. And these problems, nutrition problems, everybody aware of these problems, and the government also initiated several programs. More than a dozen programs are available on these aspects to control these strategies, and different this triple burden of diseases. We have given this especially clinical forms of PEM and subclinical forms of PEM, and macronutrient deficiency. Especially we are discussing 3 or 4 important one iron deficiency, vitamin A, iodine deficiency, and we are now currently even zinc deficiency also a very important program. And one other diet-related NCDs, but as you know, now NCDs prevalence is in epidemic proportion is increasing, and we have to control these NCDs is also very important. And this is a very complex of diseases. You can see elderly malnutrition, adult malnutrition, pregnancy, low weight gain, and adolescent malnutrition, child malnutrition, fetal and infant malnutrition. So the burden of nutrition-related diseases is more than 60 to 70% is related to nutrition. So if you able to control undernutrition, we can come down more than half of the disease burden in the country. And adult disease start at childhood. So this is also very important, because until unless if you control the diseases during childhood itself, we cannot control or we cannot prevent adult diseases. So this is just a basic definition. What is the normal child looks, and wasting and low weight for height, and something low weight for height for age, and underweight, low weight for age, and overweight. You can see obesity. And these are the double burden of diseases also there in the NCD. In the overweight candidate, the overweight person may also suffer from double burden of diseases. And this is the magnitude of undernutrition. You can stunted children is almost 46 million children are suffering from India, and diabetes 72 in diabetes, and overweight, obesity, and anemia. Anemia is a big problem and is the highest prevalent nutritional disorder. And you can see diabetes, I need not tell, because even Dr. Nikhil Tandon, he has given very good lecture and very good talk. And this is stunting, of course, declining on under 5 children over a period of time, but still the current scenario is very, very high when compared to other neighboring and other developed countries. So still we have to be reduced further, and even Poshan Abhiyan also started very ambitious program, and as per Poshan Abhiyan targets, we have to reduce undernutrition at least 2% every year for this current 3 years, and anemia we have to reduce 3% every year, that is 9% we have to reduce from the current levels. But the current reduction is not that much high, it is only 1 to 1.2 only, but we have to put extra efforts to control undernutrition. And of course, this is adolescent, even among adolescents also there is a lot of undernourished adolescent children are there in most of the states. So the prevalence of overweight, obesity among adolescents also, this is recently completed CNN Comprehensive National Nutrition Survey. This is the Ministry of Health, UNICEF, and NIN also a partner in this study. And this was done in almost 30 states. It is a very representative sample we have done. And as per these surveys, the adolescent prevalence, adolescent overweight, obesity is a very significant problem. And especially in some of the states, it is very high, Delhi, Goa, and Tamil Nadu, even Arunachal Pradesh and some of the states. So the anemia is another problem. It is you can see anemia is almost 40% in some of the states and some of the age groups. You can see 1 to 4 years, it is very high compared to other age groups, and it is also prevalent in pregnant and lactating women, more than 50%. And the you can see the prevalence over the India. The anemia is very severe. Anemia is very high in West Bengal and some parts of northeastern states. And this because we have several programs for anemia control program, but the impact is not that significant. And this is also state-wise. You can see the anemia prevalence among adolescents. And then diabetes also a big problem in among adolescents itself. You can see then West Bengal and some of the Kerala and some of the states, the diabetic prevalence is also very high, and total cholesterol is also high. So the percentage of cholesterol among adolescents, you can see in the map, and the triglycerides. So then hypertension, especially among adolescents, hypertension is also now becoming a big problem. You can see the prevalence of hypertension, especially in Uttar Pradesh, Manipur, is very high among adolescent people. And this is, of course, NNMB, National Nutrition Monitoring Bureau, over a period of time, how it is increasing, especially even in rural areas, you can see. So men and women, it is just like a step ladder pattern from 1975-79 to even 2011-12. This is the last rural survey we have done. Then this is also tribal, rural, urban variation also there. You can see this among men. Urban, it is very high. 32% urban population is suffering from this urban adults. You can see urban adults is suffering 32% and 3% tribal, 10% rural. And this among women it is still more. You can see 3%, 10%, and 42% urban women are suffering from overweight, obesity. So hypertension among men and women, you can see it is very high. At least 38% men are suffering from hypertension, and 29-30% suffering from hypertension among women. So then some of the prevalence varies from state to state. You can see the Kerala is very highest, even Assam also highest, because some of the findings we observed that in the diet surveys, the Assam population, the consumption of salt is very high, especially the tea gardens and other labor population is consuming very high salt. And this is, of course, age. This is a well-known thing. If age increases, hypertension also increasing, you can see. And men and women, this is a diabetes prevalence among men and women. You can see that diabetes is very high. So in men, almost 28% men are suffering from diabetes and 23% among women. And this age stratified, we have also age stratified figures. And if you take age stratified, it is around 4% men and 22% among women suffering from diabetes. And this is also same following the age. If age increases, diabetes prevalence is increasing. And of course, the cost of malnutrition is very high because the time is very short. I cannot explain I cannot read all these things, but the GDP loss is almost 4 to 9% because of just this undernutrition. And you know, the determinants, you can see the use of sanitary latrine. The Swachh Bharat is working very well because wherever the sanitary latrine is there, the undernutrition is very less. You can see all the three indicators: underweight, stunting, and wasting. And especially underweight and stunting, the difference where the use of sanitary latrine is there in that house, the children are undernutrition is very less, significantly less. So that means the role of sanitation is very sanitary latrine is very high. And this is both among men, girls and boys also seen. And of course, the Kacha, Semi-Pakka, it is a proxy indicator for income. Where the income levels are high, the prevalence is less in both boys and girls. And especially the nuclear and joint families, you can see. Where joint family is there, So the joint family system is also this survey showing that it is good because the care of the child will be much better compared to nuclear families. So then community also. This is also a good determinant, and scheduled tribe, scheduled caste, and backward and other things, and others are better compared to scheduled caste and scheduled tribes, both the boys and girls, and the undernutrition. This is also illiterate, and the literacy also showing very significant difference among the different levels of education. So the college and above showing the children belong to college and above people. So the prevalence is significantly lower. So that means the education also, if you improve the 100% education, definitely the undernutrition also will be decreased. So the family environments, why it is happening? These are the different reasons, and food availability, parental modeling, and food involvement, and then media exposure, parental feeding styles, physical environment, rules and restrictions, parental modeling, and parental support and encouragement. So these are the things, because our focus should be children, and it is just like a life cycle approach. We have to intervene in a life cycle approach, and especially a special focus on children. So the importance of diet during different stages also life is given here, and you can see this whole life cycle approach we have to follow in order to control undernutrition or malnutrition. So regardless of who the father of disease is, surely its mother is improper diet. This is per the old Chinese proverb. This is very true, because we are also seeing during the COVID time, and most of the people are protected just because of immunity and immunogenic foods consumption is showing. And the balanced diet is very important. I need not tell this balanced diet. Everybody aware of that. A balanced diet can be defined as one which contains various groups of foodstuffs, such as energy yielding foods and bodybuilding foods and protective foods. So the healthy food diet should contain these are the components, as fiber foods, protective foods. Then of course, so I already, when Dr. Kadosar already said that this is NNMB. So we used to collect NNMB in a periodical diet and nutrition surveys, and we have village cohorts for rural population, village cohorts for tribal population, and these are the two important objectives of NNMB. And as per this NNMB data, the food consumption pattern, you can see the cereals, pulses, legumes, leafy vegetables. The consumption of leafy vegetables is very less, even among urban population, and rural population still low. So some of the foods, but only urban population, the fruit, the fats and oils is consumption is very high compared to 100% RDA. This red line shows RDA. And suppose if you see the nutrients, the protein, energy, some extent thiamine, and vitamin C, and dietary folate, but especially vitamin A, iron, calcium, and riboflavin deficiency is very high among this population also. So especially children diet is very, very poor. You can see where is that red line, and where is the actual consumption. So the consumption of children diet is very, very suboptimal. You can see even except protein and some extent fat and dietary folate, all the nutrients are consumption is very less compared to the actual requirement of RDA. So this is especially even 4 to 6 months children also. Then then this adult sedentary male and adult sedentary women, we have given both the people some of the only few foodstuffs only they are meeting, but other especially in and the unfortunate thing is NPNL women diet is little better than even pregnant women diet. So that is the paradox in this. So here you do not have to eat less. You just have to eat right. This program, this campaign is also going on, and we are conducting several meetings. So through NSI, Nutrition Society of India, and even Indian Dietetic Association also, we are propagating this slogan. And especially one of the most important reasons is IYCF practices, infant and young child feeding practices. And if you see this infant and young child feeding practices, these are this won't involve only any cost. It is only a behavioral change. You can see less than 1 hour feeding, breastfeeding won't involve any cost, but only 42% of mothers only can do less than 1 hour breastfeeding, and several articles also there, and the one Lancet publication also there. If the mother is able to give less than within 1 hour of breastfeeding initiation, even 22% neonatal and under 5 mortality also can be reduced. So the time of initiation of breastfeeding, this is different states also showing, and exclusive breastfeeding 6 months, the child may not require any food other than breast milk, but only few people are doing that exclusive breastfeeding in different states. And these are the problems, and what are the preventive strategies you can see. So the nutrition is a complex problem, as you all agree, the society role and then biology and behavior and economy. So this all determinants also we have seen in the previous slides. And these are our global targets also there, 40% reduction in the number of children under 5 year children stunted, and 50% reduction of anemia, 30% reduction in low birth weight, and no increase in childhood overweight, and increased rate of exclusive breastfeeding, reduce and maintain childhood wasting. So then NCD related indicators also there, even NCD related some 9 indicators, 21 targets also there. Those we have to achieve by 2025, some of the targets, SDG goals also there, sustainable developmental goals. So what are the preventive strategies are available and what we are doing, and preventive strategies at various levels is very important. At family level is very important. We have talked about different issues in the family level itself. It may be behavioral issues, it may be practice, and at community level, at national level, at international level. And at national level and international level, very active programs are going on, but we are lacking at community level. The creation of community awareness and the acceptance of this program by community, and at family level, creation of awareness at family members. These are the issues we have to give more focus. And levels of prevention, of course, primordial and primary prevention and health promotion and specific protection we have to give. Early diagnosis and treatment, and even government already started Anemia Mukt Bharat and several programs, that is a screen and treat immediately. You screen and treat immediately, and in order to prevent other consequences. And tertiary prevention is also very important, and establishment, we have several NRCs established in India, but their functioning also very important, improve their functioning and efficiency of these centers. And hospitalization of some of the children very severely malnourished, and follow up and home care also very important. The home care is very, very important. And in order to, that's what I just talk about this. This is improving health and nutrition status of children by implementing multi-component health and nutrition education intervention as a sustainable model. And this was initiated, and thanks to Dr. Kato sir, because when he was DJ, this project was sanctioned in almost 40 districts, and it is a huge project. Teja is the principal investigator. I was the co-principal investigator for all these 40 districts. So the type of interventions is based on the findings of formative research. In 3 phases, we have done this intervention project, and this project was very successful, and it has given very good results. You can see baseline and end line. There was a behavioral change, and there was even outcome indicators, very significant outcome indicator changes. Because of lack of time, I cannot explain all these things, but this project is a very good project and initiative. And this is another project. This is nutritional status of AIDS and other population. And this is other project. And another second one is the establishment of nutrition surveillance in selective states. And this is also a very innovative project, and because this project is because this nutrition surveillance is a very important intervention, but we are this project was mentioned in all the 12th plan and even 13th plan, and from since the 10th 5-year plan onwards, the establishment of nutrition surveillance system is very, very essential. But the government could not do so far, but we have implemented as a pilot project in 6 states. And this is and one is a real-time data collection we have started here. These are the primary stakeholder departments as we discussed earlier. So nutrition is not a one department cannot do. It is a multi-sectoral approach only. The nutrition can improve. These are the 6 to 7 primary departments, and these departments convergence is very important. Even Poshan Abhiyan also one of the pillar is convergence. So convergence is not happening even since we are trying more than 2 decades, but convergence is very, very important in order to control the undernutrition. And this nutrition surveillance has been established in 6 states, that is Telangana, Kerala, Madhya Pradesh, Maharashtra, Meghalaya, and Orissa, to provide regular nutrition and health information and the early detection of nutritionally at-risk population and its determinants and action also we have to take immediately. So this nutrition surveillance system should work on EEE approach: assessment, analysis, and action. And at present, what we are doing is only assessment and analysis, and we are sending the recommendation to the different stakeholders or governments. But whether they take the action or not, we are not bothering. But in this project, action also we should, as a researcher, we should also monitor the action, whether the government or different stakeholders action is taken or not. So that is the main important focus in this project. So this is the digitalization of the data. You can see it starts with the Anganwadi worker in the household, and it flows up to the state level and even central level. The approach is there, and we have developed a server, central servers at NIN, and one at each state, all 6 states in the DWCD department. So whatever the Anganwadi worker collects the data, information on child, mother, pregnant, lactating women, adolescent girls, the Anganwadi worker presents this data every monthly, and that reach and deposited in the central server. And here some staff is watching those data deposit, and they see and give the immediate comments and actionable points to the stakeholders. That is the important thing. This is we have inaugurated this program in all the 6 states by involving even MLAs and MPs and their stakeholders, and all the 6 nodal departments also we invited for this inauguration. And this was very successful going. We have already completed 3 years, and we recently have evaluated. And this is a conceptual framework of this EEE cycle, and it starts with the household and it up to Commissioner of DWCD and DMNHS and Director of Health Services. This information flows, and this is the even tracking, online tracking of weight of every child. Every month we have to track, and another important thing is here we have created a QR code for every child, and we are covering almost 1,000 Anganwadi centers in this project. In each Anganwadi center, at least 50 to 70 children enrolled, and this all 50 to 70 children in 1,000 Anganwadi centers. We created a QR code. With QR code, we need not get, if you open the QR code, all the child information will be tracked from once 3 months, 3-year period also we can see these children. And another important issue is this Anganwadi teacher or Anganwadi worker, they are not well trained for measurement of height, weight and other things. We have retrained, and now after retraining, the inter-individual variation of this measurement is very good agreement was achieved in among these 1,000 Anganwadi workers. So this is height measurement and weight measurement, you can see. And another third project is the effect of health and nutrition education and body weight and body mass index among urban adolescents. A school-based intervention trial. It is like a RCT trial, and this was done more than one academic year. And in this project, especially, we discussed with the school teachers and school administration, and we have changed the curriculum. We have suggested a revised curriculum to the schools, and at least we kept 1 hour every day some physical activity. And we have also given what are the physical activity, what are the games and sports to be given to these children. And we helped all the, this was, of course, this was done in only one area, Hyderabad only, because of feasibility, and this is a pilot project. And this project also successful because shortage of time, I am not presenting all the details. And this is the trial school randomization. We have done 5 control schools, 5 intervention schools, and we have taken all the statutory permissions from this health education department. And this is the actual results. 2 tables are very important. How overweight, obesity is shifted to thinness or shifted to normal. We can see this is in control group and this is in experimental group. And the overweight, obesity is 2% shifted, and especially overweight is 21% shifted to normal side. That is the achievement in this project. And these 3 projects are models are ready. And if anyone wishes, also we can send these models and they can implement anywhere if they have resources for control of undernutrition. So these are the recommendations. We need a better understanding of the role of family, environment, and research is essential. And we need to find ways of better supporting parents. For example, child and maternal health services, and school and education system, child care and child support system. And the family environment and parenting behaviors are likely to be critically important, and we currently have a poor understanding of the influence of the family environment on the development and maintenance of children's eating behavior, physical activity, the risk of the child and adult overweight and obesity. And so that ending my presentation, and this is prevention is better than cure. That is my last word. Thank you for giving, once again, thank you for giving this opportunity. So if any questions are there, I would like to answer. Thank you, sir.
Thank you, Dr. Lakshmaya. I think, you know what, because since I've known you for the whole life, see the leadership given by you, hard work done by you as a medical person, as a connector with the community, I think it's a superb. And your contributions to the policy, you know, your colleagues, that will always be remembered. I think if at the end, if there's some pertinent questions, definitely stay on. So we would like to answer that. But I think you've covered everything. You know, you covered the total journey of the ICMR, NIN-led work on the area for the several decades over the time. Very much futuristic. Thank you very much, Dr. Lakshmaya.
Thank you, sir. Thank you, sir. Sir, this same, sir, one word, sir. This same NSS, our model is also adopted in the Poshan Abhiyan. So they have taken our from ICMR. This was taken by Niti Aayog and DWCD, and they included in the Poshan Abhiyan. So that, yeah, thank you, sir.
No, superb, you know, that I know that it can be a 1,000 list of the contributions, you know, which have led to the policy change. I'm aware of that. And continue to do it. We wish you very good luck, but stay on. Yes.
Thank you, sir.
We get back to Pastor Ishan Patro if he's on again. Yes.
Sir, you are muted, sir. Patro, sir, you are muted. Sir, unmute yourself, sir.
Please unmute because there is no sound. There is no sound. We cannot listen you. Professor Patro, we cannot listen you.
नहीं वो तो समझ गए डॉक्टर साहब, पर उनको उनको पॉइंट आज ऐसे मिल रहे हैं जो चल नहीं रहे।
ये अपने कंप्यूटर में अनम्यूट नहीं करेंगे तो नहीं होगा।
Okay, sir, I've done it now.
हो गया डॉक्टर साहब, चलिए।
ओके,
चलिए पात्रो साहब, बिल्कुल।
So can I see the slide? Can you see the slide now?
हाँ, स्लाइड भी सुन रही है, आवाज भी सुन रही है, ऑल वेल, चलिए।
In the beginning, I like to thank Professor Manju Sharma for giving me this opportunity to speak on mental health and aging. But then it was for 30 minutes, it was too much. So I wanted to confine it to something that we are doing for past 10 years on protein malnutrition, rather maternal protein malnutrition, brain development and aging. 3 lectures have made my life very easy. The last one on nutrition. Yesterday we listened to Professor Vijay Lakshmi Ravindranath on dementia and aging, and there was another lecture on nutrition again. So what I'm going to do today is I'm going to just confine myself to maternal protein malnutrition and aging. But before that, I'll just like to tell you that this is something everybody knows, but there are some salient features that I want to tell you that amongst 1.38 billion people that we have, more than 50% people are under 25 years of age. And we are having every minute, we have got 53 births, and deaths under 5 is about 32 children or 33 children per thousand now. So why this is one of the alarming situations when we have got so much of children dying, and what bearing it has got to the maternal nutrition status. That is what I'm going to deal in a few minutes now. For those people who have less idea about the brain, the complexity of the brain, I have got this slide just to tell you that the brain has got 100 billion nerve cells, and what is very important in this is it has got 3.2 million kilometers of wiring. Imagine how many house wiring can get into it, and it's all packed into 1.5 kg of tissue mass, which is about more or less 2% of the body weight. And it is, we say that is the last frontier of the body to understand today. These are the major components everybody knows about neurons, but very few people were aware about the astrocytes, microglia, and of course oligodendrocytes people were talking about. But about microglia and astrocyte, very few people were aware of it. And in 1995 on, we started looking into it. As it goes today, the nervous system, in fact, is will be almost non-functional without the presence of the astrocytes and microglia there. So in my lecture, I'll be covering some aspect of it. Whatever malnutrition studies we had earlier, a lot of work was done in India itself. We're all confined to neurons and neuron health and neuronal structure function like that. In recent past, in about 15-16, National Brain, the NIMHANS, National Institute of Mental Health and Neurosciences, did a very wonderful survey on National Mental Health Survey, that is what they call of India, and this was supported by Ministry of Health and Family Welfare. And this summary booklet has got a lot of information that I believe all scientists and all biologists in particular should have a look into it. It's available in the net. Just to give a few data, that is only very little data I have extracted from that for everyone, is that any mental disorder, if you go to speak about it, then our country has about 10.6% people have got this some one or other kind of mental disorder, and there are all other listed over here: schizophrenia, mood affective disorders, bipolar affective disorders, and so on. If we go by prevalence, the rural urban and urban rural, non-metro, rural, urban and urban metro, you go by that, then what happens is amongst the total, if you go by total mental disorders, then the urban metros have got the largest number of people with mental disorders. And to my utmost surprise, what I found is we were thinking that the alcohol use will be more in the alcohol use disorders will be more in the metros. It is not true. And if you go to economic standards again, there will be another thing coming up there. So by age prevalence, if you go 40 to 49 years age bracket, the largest number of people have got some mental disorder. And if you go by income groups, the lowest income group people have the largest population of people with mental disorders, and the median household income is lowest there. But if you go by sex again, the gender, the males are more prone to a mental disorder than the females. But the two disorders where the female are suffering a lot is the mood associated disorders and the neurosis, of course. And the most alarming thing in this our country is that for every 1 lakh people, we have not even one psychiatrist available. And if you go by clinical psychologist, also the same is the situation. Is only in Kerala where we find one psychiatrist per 1 lakh people. I have states where we do not have even one for 5 lakhs. So this is one area where the education system and the medical colleges in particular need to attract people to get into this kind of studies as well. If you open up a newspaper, if every other day you find an article on malnutrition and child death. And the worst thing that I have seen in my life is I live in Madhya Pradesh, and one time it wrote it's a sin or worst place to be born in Madhya Pradesh. So that is not exactly in only true for Madhya Pradesh, for all other states also it is true. And what is the most difficult thing to digest and accept is India is under 5 death is the worst in India, and we are the worst in the world. If you come to the hunger index, India stands at 102 amongst 170 countries, 17 countries, and we have not really improved a lot in past so many years. 1992, the global hunger index started to be calculated, and since then we have only deteriorated. And one time we did better was in 2016. Again, we are performing very low again. Every third malnourished child in this world is an Indian, and every third child in India is malnourished. And kind of malnourishment, and it could be anything, but we are working on the protein aspect of it. Protein malnutrition is a multifunctional worldwide public health problem affecting millions of people in underdeveloped and developing countries. Maternal protein malnutrition is again very important because it affects the neurological and intellectual development of the offspring, leading to motor, behavioral, and cognitive deficits at later life or the aging. Maternal protein malnutrition affects the neurological development and brain development. That is what I'm going to show you in a few slides to come. And we have also worked on supplement part of it also. And what is very alarming for anyone to understand, this is the social and economic development of any nation is indexed largely by its infant and child mortality. India has not achieved the millennium requirement development, and we have really missed our goal. One of the major factors for this has been antenatal dietary status and the mother's health, largely dependent on biological, socio-economic, and environmental factors. And infant mortality is more in rural areas as compared to the other parts, and also amongst the scheduled tribes. There is one in one Lancet psychiatry paper, it was written mental health sustainable development goals, and target 3.4 and 3.5 are very important to note. By 2030, it should be reduced by 1/3 premature mortality from non-communicable diseases through prevention and treatment, and promote mental health and well-being. And 3.5 requests that the countries strengthen the prevention and treatment of substance abuse, including narcotic drug abuse and harmful use of alcohol. And we are really lagging behind in this. Although it is a global burden, India needs to be very careful because the most useful in time when India, one child dies every 15 seconds due to neonatal diseases or deficiencies. 4 lakh newborn die every year within the day of their birth, and 20 lakh children die before their 5th birthday. And these data actually prompted us to get into more studies on mental health related to maternal protein malnutrition. These pictures I have taken from the internet. I never wanted to show this, but this is important. I show you here because the poor are malnourished because they don't have food. The rich or those who have food are malnourished because they do not know what to eat. Under non-availability of a particular thing and over-availability of a particular thing, both the things lead to malnutritional status. We try to create a model. We have been able to establish this model long back. That's what we call is intergenerational protein malnutrition model. And this model is very important because most studies are done for short durations, and this is one where we start putting the mother a pre-gestational period to a protein malnutrition condition, and it goes on to the post-weaning state, and then the animals are the pups. So F1 generation is studied carefully. So these, I don't have to go into this. This is just to show you that if you go for a protein malnourished model, you can just have a look at these two rats. You can understand this is a protein malnourished rat and born to a protein malnourished mother, and this is a rat born to the normal 20% protein diet, right? And then in both the cases, both body weight and brain weight get drastically affected. You can see this in these graphs. They're very and these are self-explanatory anyway. There are a few papers that were published. I'll be dealing with the findings of these papers that we have recently published in 2016 and now. Maternal protein malnutrition deprivation induced reduced population, colonization, and turnover of glial restricted protein progenitors, restricted progenitors, leading to impairment of temporal astrogenesis and oligodendrocyte formations, impaired oligodendrocyte maturation, and poor myelination. All of us, we know if myelination is poor, then there is a lot of issues there, leading to functional behavioral impairments. And poor spatial learning, memory in the F1 generation rats, early adolescent mimics only the onset of dementia. And this is just, I will not get into the detail of it. This is just to say that if there is, we call it as intrauterine growth restriction state when there is malnutrition, and we can go for some kind of supplementation where all that is restricted due to malnutrition can be achieved by supplementation. That is what is expected. In our case, we have used spirulina as one of the supplements, and we have got data to show that is what works really wonder, and it's a real wonder food. These are the papers on the spirulina supplementation. I'll be dealing with 6 papers that we have published on these issues in past few years. And when the mother is malnourished, the pups born to them have a high risk of assessment behavior and indicative of impulsive behavioral profile in neonates following maternal protein malnutrition. They don't do well on any of the motor development skill, motor skill development things, and they do not do good cliff avoidance or surface writing or inclined panel tests that we perform. Hyperactivity, and which is a clinical hallmark for neuropsychiatric disorders, is one of the major findings that we have found in F1 generation pups born to protein malnourished mothers. And this is something that is very alarming today these days. And attention deficit hyperactivity disorder is becoming one of the common disorders with the children born in recent years. So this is just the tracks on the open field. If you have a look at this, then you can understand in the control animals, these animals do not come to the center of the well. They are all on the sides. This is a very healthy situation where the animal is not hyperactive, is not having any impulsive behavior, and is not showing any symptoms of getting towards a condition like schizophrenia or dementing conditions later on. The time square analysis, that is what we call, when the animal is in the center, we say there's a basal anxiety and reduced habituational possibility. And the LP animals are low protein mothers, pups born to the low protein mothers, they tend to be in the center for a long duration. This is a low anxiety condition. And if we supplement it with spirulina right from prior to pregnancy and during pregnancy and later stages till 6 months of age, you can see these animals are very rarely seen on the central center of the well, and that speaks about ameliorates maternal spirulina supplementation associated, malnutrition associated anxiety disorders. This is just for all the age points from 2 months to 18 months. And we have got one very interesting thing to support this. I'll have show you one, two out of the 4. I'll just show you 2. This is a rat moving. If you can see this, this is the open arm, then this is closed arm. The animals which are normal, they will be tending to stay in the closed arm, and those who have got anxiety disorder and risk assessment, avoidance of behaviors, they will be moving into the open arm. This is a low protein group animal, pup bound to a low protein mother. You can see this animal is still in the open arm only. And when you put these animals in the same place, normally, high protein group, it stays in the closed arm, and in the other one, which are deprived of protein, they always go towards the open arm. This is a suggestive of anxiety, decreased risk of assessment and avoidance behavior. You can see this animal is not coming at all to the open arm, and this animal is largely on the open arm only. So I could have shown you 2 more here also, but we do not have time to do that. So I'll just stop it here, and then I'll go to compare this with this. The number of entries to this is the open arm. The number of entries to the open arm actually gets reduced with spirulina supplementation. And that's what we say, time spent on open arm is low, and speculate a better condition of not being in a hyperactivity state. And if you go by neuromuscular deficits or motor functions, you can go for forelimb or grip strength studies. You can see that all the protein malnourished animals show a significant decrease in the ability to have a better motor function there. So you can go for spatial learning and memory. This is again very interesting slide. You can have a look at this. This is one normal, high protein fed mother, pup born to the high protein fed mother. And this is, see, this animal is left here, and this is supposed to come to this target quadrant and be on the target. See, it takes very little time to come to this escape. Yeah, now it has reached there. If you go to a low protein animal, pup born to a low protein mother, we put the animal there and just have a look. It goes on round and round. Even it goes to the target also, but doesn't sit on that. It keeps on. It doesn't know where to go. The spatial memory and functional deficit is very high. In the pups born to the low protein mothers, the latency to reach the target and even the path efficiency, latency is very high and path efficiency is very low. You can have this one took very little time to come and sit on the escape stage, but this one is still moving around. We give about we'll go on seeing these 2 to 3 minutes. It will go on, but it will never reach to the. It touches the target, but it will not go to the target. So I leave it here and go to the next slide to show you something different. So these are the tracks we have obtained from this movement of the rat. There you can see till at the age of 18, this spatial performance is very low in the pups born to the low protein animals. So it's even very interesting if you go for to watch between male and female. Males they make effort to find out, but the females are very good in floating. So they keep floating in one place. They do not even make effort to reach there many times. And we tried this with another method, which is called the Barnes maze, where water is not used, swimming is not the issue like we have the issue with the females. There also, if you give the spirulina supplementation, you can see this is the LP, this is a high protein pup. It straight goes to the target, and this is an escape hole. It reaches there. if you go to LP1, it hardly reaches to the escape. Even if it reaches the escape, it doesn't understand that this is the escape. It goes on roaming around and never performs, completes the task. But if you give spirulina supplementation, you can imagine it is not reaching anywhere after doing so much of effort, but it does reach with a little more than the normal animal. So that is something we have tried up to 12 months of age of the rat, and we have come to this. You can ask me a question, why you go up to 18 months only? Because by 18 months, this rat is supposed to live for 3 years, but all these pups born to the low protein mothers do not live that longer. And on the rotor rod that I should have shown the video, I'm sorry, I do not have that. On the rotor rod, there's a rod which is rotating, and the animal has to be sitting on that, and it should walk. And so that when it tries to walk, it falls. And it doesn't fall means it's not performing anything on the motor skill. As again, the same thing happens, but if you give a spirulina supplementation, it performs better. And this is in the light and dark box. This animal is rat is always interested in staying towards the darker side because it likes the dark box. And if there are two boxes here, this is the light zone, this is the dark zone. And normally the animal will be moving more in the dark zone and very less into the light zone. In the low protein animals, this again, that doesn't happen. The rat is always on the light zone. It very rarely, for the very less time, significantly low amount of time stays in the dark side. And this is low anxious and hyperactivity behavior, that is what we say. But if you supplement these animals, right, from the mother's, from the maternal side itself, during pregnancy and thereafter, you can see this almost matches the control animals, although it goes to the light side a little more than the control group, but it's not significant. And this only shows that low anxious and hyperactive behavior profiles get better with spirulina supplementation, and it is worse really in the low protein animals. And you can go on doing speaking like this on different aspects of behavior and cognition, but I'd like to come to the neuroinflammatory part of it. Neuroinflammation again is very prominent and very prevalent in low protein animals, and if you give a supplement, definitely that gets lowered. And but one thing is very clear from these slides, if I tell you, this is again about the S100 beta staining, which speaks about the damage of neurons and things like that. And this is microglial activation and neuroinflammation in the LP and HP groups. And you can see this is the high protein animals, and this is the low protein animals. You can see a very high number of activated microglial cells, neuroinflammatory condition. That's what we say. They are expressing all those cytokines and chemokines, and these are definitely lowered by spirulina supplementation. If I can go on showing you a few more slides like this, but then we'll come to the neurons. The neurons, again, it's a very interesting slide. I think it's very self-explanatory. And you can see in this that this is a pyramidal neuron, and you can see the arborization. Arborization is very important as far as nerve function, neuronal function is concerned. If this is a controlled animal, and you see the low protein, you can see how less the arborization is. And as age advances, they even fall below that level. But if you supplement these animals with spirulina, you can see they tend to come closer to the control group animals. And this arborization actually speaks about the functional status of these neurons. The less the arborization, the less functional the neuron is. And this is about the spines. Everybody understands if there's synaptic connectivities are responsible for neuronal function or the brain function. So spirulina does, protein malnutrition does affect the formation and maturation of the spines or the synaptic formations, but then spirulina supplementation does help it, and it tries to bring back to the normal condition. To conclude, what we can say is collectively spirulina acts on the homeostatic controller of brain environment and partially reduces the oxidative damage, reactive gliosis, preserved and the morphology of neural cells, and elevated number of functionally viable spines, which could be the contributing factors to observed in ameliorated neurobehavioral and cognitive abilities in the F1 progeny. People ask me, why don't you go for the F2 progeny? It is really, really very difficult for me to go there because the F1 progeny also presents a very low reproductive rate, and we hardly get enough pups in them, and the delivery is not proper, and we do not get similar kind of maternalhood or maternal care conditions. So at the end, I'll just say we should put our brains together and support brain research. But before I close, I must acknowledge that the large amount of work that I've been presenting were done by Nisa and two of the research scholars with us, Ajay and Srestha. Half of this work has been awarded by NASI to Srestha Sinha through the Swaran Jayanti Puraskar. And I'm very much thankful for patient listening to me. I believe I'm in time, or I've not taken more than the time allotted to me. Thank you very much, and we look forward to provide you more data on this in the near future. Thank you.
Thank you, Professor Patro. I think an excellent talk with a lot of futuristic expectations from you, ma'am. Not able to hear, ma'am?
Yeah.
Not able to hear now? Okay.
Yeah, I'm listening to this. Okay.
Acha, thank you, Mr. Patro. Thank you very much. No, it appeared Madam was not able to listen, so that but we compliment you for a wonderful talk. We wish you and your team also excellent, because a lot more expected from you as the moves. And I think we please stay on. Yes, because the new generation of leaders which you will have to leave behind after a few years, so that's also will be very important. But I think this is thought leaders, I think we congratulate you, Dr.
Greetings to Nisha.
Yeah,
yes.
Most of it. So the half of this, I've not touched one part of it, which in another lecture sometime I'll speak, is we have also tried with the bacterial and viral infections in conjunction with protein malnutrition and without protein malnutrition. So this is one situation is very relevant and very prevalent in our country, is that children, the children born, newborn children are usually exposed to kind of infection, a bacteria and a viral infection, and if there is protein malnutrition already being there, and if these any one or both of them are there, how it is responding. We have done
So Patro, this title of the talk, Madam will give you for next Jagrukta Abhiyan, I tell you, because this is very, very, I have seen it through her, her eyes, actually, she's picked up a talk. Thank you very much, Mr. Patro.
Thank you.
We move to the last speaker of the session. Please stay on if in the end we have time. There's some comments of the people. We would definitely like to hear that.
Sure, sir. Sure.
Yeah.
Dr. Katosh.
Yes, madam.
Dr. Katosh, Professor Pramod Garg is now director of the Translational Research.
Yes, madam. Yes, madam. I was going to introduce that only. Thanks, madam. Thanks, madam. Well, pleasure to invite Dr. Pramod Garg, the new executive director of the THSTI, and one of the very distinguished colleagues who is excellent as a clinician in gastroenterology. But much more than that, what I rate him, that's for his vision of the entire medicine, actually. Entire medicine in the context of India. It's not only the clinical, public health, research, everything.
Yes, sir.
So I think
yeah.
So Professor Garg, I think we look forward to hear from you about a very broad subject, which I know your depth in that, actually, because I have the pleasure of interacting with you during all the AIMS days. As a clinician, as a teacher, as a scientist, and as a thought leader. So I think we look forward to hear your talk on the enabling ecosystem for research in biomedical sciences. And madam, I would have given that topic to you, knowing your capacities, your aptitude, your capacities. So off to you now, Dr. Garg. Yes.
Thank you very much, sir, Professor Katosh, sir, for this kind introduction. And I'd like to thank Professor Manju Sharma ji and NASI for having given me this opportunity to talk about enabling ecosystem for biomedical research in India. So can I share my screen? have you given me the privilege of sharing the screen?
Yes, you can share the screen, sir.
गर्ग साहब मिल गया?
No, I'm seeing, sir, where is the meeting link here?
नीचे जहाँ पे mute stop video उसके next share है.
Yeah, I know, but that is not coming in as this thing.
अच्छा, हाँ, नहीं इसमें आज आपके में आ ही नहीं रहा वो. शुक्ला जी एक बार देखिए फिर से.
संतोष देखो भाई.
You are allowed, sir.
एक बार लॉग आउट करके फिर से लॉग इन करें सर.
अच्छा, okay.
You are able to share the slides?
No, not yet.
संतोष.
You have to click the share button.
नेक्स्ट सेशन के स्पीकर्स का स्केच तो भेजे कि भेजा है, देखो पूछ लो मुझसे कि भेजा है कि.
It is not yet showing that I can do that. That particular button is not highlighted.
Sir, it seems somebody else is sharing their screen. Sir,
No, nobody is sharing my screen.
डॉक्टर साहब आप अपने ऑफिस से कोई स्टूडेंट वगैरह किसी को बुला लीजिए जो कंप्यूटर स्पेशलिस्ट हो.
मैं बुलाता हूँ 1 मिनट में.
वो कर देंगे.
अच्छा, ओके. तो उनको बुलाना किसी को, कंप्यूटर वाले को. हेलो.
इवन आपका सेक्रेटरी कर देगा. पूछो संतोष से.
sir, also please try refresh button from top. Top, please refresh your screen.
हेलो. हाँ. अच्छा.
So I've just sent the presentation, and I think it will be shared by the organizers there. I'm sorry for this technical glitch here. Something wrong, but I think the presentation should be on in a moment. I think Santosh is doing that from his end.
ठीक आ गया.
So once again, I'd like to thank Professor Manju Sharma ji and NASI for giving me this opportunity to talk about enabling ecosystem for research in biomedical sciences. And we all know that how research is important, particularly in the context of biomedical sciences, given the current pandemic, which is raging the world for the last more than a year or so. Can I have the next slide, please? So my outline of my talk would be, why do we engage in research, how do we do it, and what are the role of universities and institutions for enabling such an ecosystem. Next, please. So after the Second World War, Winston Churchill said, Russian actions is a riddle wrapped in enigma and shrouded in mystery. This was in the context of the Second World War. Move next, please. But he also said that perhaps there is a key. And when we talk about the complex pathophysiological basis of research of various diseases, the key, of course, is research. This is what leads to better understanding of the disease and also innovations to treat a particular disease. Next, please. So why should we engage in research? Next. Please keep on moving. So there was a famous Chilean Nobel Prize winning poet, Pablo Neruda, who said that, please go back, who said that, who am I and why am I here? If we talk about the ancient Indian philosophy, these are two very important questions that we need to answer. Who am I? And why am I here? Here means on this planet. But more mundane, in a more mundane sense, these are important questions that every one of us has to answer wherever we are working, whether we are working in a research institution, we are working in a university, we are working in a hospital setting. And that tells you that what is our role in society? In society, we are supposed to contribute to the development of human beings. So next, please. So in that context, if you see, who is a scholar? A scholar is a person who acquires knowledge. And these are very important people. A scholar is someone who will teach and train others. But a researcher is a person who creates new knowledge. And to my mind, a researcher is, of course, at a much higher pedestal than a scholar because he creates new knowledge. Next, please. And that is why we have to engage in different kinds of research. So research could be either basic, clinical, or what we call as translational research. Next. Now, it could be bench to bedside when we say it's a basic science research going on to bedside of a patient. Next, please. Or it could be a bedside to bench. But I tell you, majority of time, it is the bedside to bench research. Why? For example, if I see a patient who has been suffering from a major disease, I don't understand what is the cause of disease. Then I go to my basic science colleague and say, look, tell me what is the molecular mechanism of this disease. So I'm going from bedside to bench. And then I say, okay, go back. And then I say, what is the treatment for this? What can we find out? Is there a target? Is there a molecule we can develop? And then, okay, they will say there is a molecule which you can use. And then again, from bench, you go to the bedside. So this is how the story of basic clinical and translational research is interrelated. Next, please. Now, if you see the world ranking of countries in research, next, please. India is is up there in many fields, but not so much in biomedical research. But important question people ask is, are we really equipped for research? If you look at the Chinese success story, China was level with India in 1980s. But they persistently increased the investment in research. And today, Chinese publications are second only to the United States of America. So if we invest heavily into research, we can surely be among the top countries in the world. Next, please. Now, in terms of space and defense, I said India has really done very well. And you all know the success stories, GSLV Mark III, Mars mission, anti-satellite missile defense system, and we are all proud of that. Next. But the success stories in medicines are also there. For example, iodine supplementation. Many of you might be knowing in the 1960s, there was a major cohort epidemiological study and a randomized trial done in terms of iodine supplementation, which led to the discovery that iodine deficiency leads to thyroid disorders. And that is why today we have a national policy of iodized salt. Diarrhea in children is again something which causes high mortality. And today we have many research projects which have been completed, resulting in a much lower mortality, including, for example, ORS, which improves survival, zinc deficiency, which has been shown to improve survival in children with diarrhea and sepsis. Malnutrition have been found to be important factor for high mortality. And now we have the rotavirus vaccine, which is from India, and we have many success stories. So same can be replicated in many other fields in medicine. If you look at the research publications over the last 10 years, we find that from India, AIIMS has been among the top institutions which has published a very high number of papers. Next. And some other institutions have also done that. So it is not that we cannot do high quality research. Given the adequate resources, we can perform well among the top countries in the world. Now, how does research help stakeholders? For a country, there are three major things. One is science, which we feel should drive innovation, and this will definitely improve the health of the people. And once you improve the health of the people, the economy will grow. And if economy grows, you can further channelize your resources into science. Now, in the current era of this, the coronavirus pandemic, we have seen how this has resulted in much depression in economy. And it is the science which has ultimately taken the lead and caused a better health of people. And thus, you are seeing now rebound in the economy, not only India, but elsewhere in the world. Next, please. So one of my friends who's an editor and writer said, research within a broader context of complexity theory is where the sum can often be a multiplier of its parts. And that is so aptly applicable in the area of biomedical research. Next, please. In the modern era, it is all evidence-based medicine. It's all evidence-based, and evidence comes from research. Evidence is obtained through a systematic study in an unbiased manner, and this is what we call research. Next. So what is the role of institutions when we talk about research? And Dr. Manju Sharma has established not only one, but many institutions, and we know that today these institutions are the nurturing grounds for creating next level of researchers in India. Next, please. So the role of institutions is very important. The stakeholders of research are researchers themselves, consumers, which are in the field of biomedical research are patients, sponsors, which are funding agency and industry, it's government, and also scientific institutions. These are all stakeholders of research, and they are all interrelated in this very important journey. The ingredients of research are research environment, which is thriving, which leads to all the people involved in this endeavor to do more and more. Individuals' curiosity to drive research, and this comes from within. You have to have that curiosity to say, why is that so? Why it is happening? I don't know what is there. In the context of disease, every day we are humbled by a patient when we see, oh, I don't know what's happening there. So that's an individual curiosity which should drive research. And of course, we need institutional support for successful research outcomes. Next, please. So institutions are expected to provide many things. They should provide a thriving system where we have a good infrastructure in terms of, if you talk about clinical research, you have hospital setting, you talk about basic science, you have all the labs, fully equipped labs. You have to provide protected time to individuals. Particularly, this is important in medical colleges because medical colleges have so far lagged in research. So one of the reasons is they are always busy in treating patients. They don't have protected time for research. And I think this is an important area where I would urge the administrators to look at that how can we provide protected time to researchers. So their salary component can be inbuilt in the research project funding, and part of that time can be invested only in research. And the institution, the hospital, the medical colleges can employ more people to look after those patients. So protected time, to my mind, is an important thing. Then, of course, institutions create, go back please, funding opportunities. These funding opportunities are also in many forms. This should be both intramural and extramural. And I think for young researchers, it is very important that we have intramural funding mechanisms. What happens in medical colleges, and I'm emphasizing medical colleges because they don't have mechanisms for funding. So when an assistant professor goes to a funding agency, they say, show us some preliminary data, show us some initial research. And he says, I had no funding, I had no project so far. So this is a constraint that they face. So if there is an intramural funding, I think they will be, better suited to conduct some initial research, produce some preliminary data, then go to a funding agency like DBT, ICMR, and DST for a larger research projects. And also institutions should create opportunities for exchanging ideas and exchanging people between different institutions within the country. And I can tell you that there is a lot of expertise available in our country. Not necessarily that people have to go out of India to learn modern techniques in today's time. Next, please. There are three barriers to research. One is lack of drive, initiative. So often we find that medical doctors who are engaged in hospital settings in treating patients, they have a lack of drive. They think, there are a lot of things available in the books. I will read journals, I will attend conferences. So, which is one barrier. So second is inertia. What happens after about 5 to 10 years of being in your job? You are in a comfort zone. When you're in a comfort zone, you are happy doing what you're doing, and you don't want to take challenges. And this is very important. The third is incentive. In India, there is no incentive or much incentive for engaging research besides your own duties. There is, of course, no monetary gains. And today I was attending the DBT Foundation Day ceremony, and I found that many senior scientists, including Dr. Manju Sharma ji, talked about the issue of entrepreneurship, how these researchers can have startup companies, they can have shares in industry, and which will help commercialize their innovations and their products. So I think some kind of incentive must be given. So three barriers, lack of initiative, inertia, and incentive must be tackled. Next, please. Then other role of institutions is advocacy for research. The bigger institutions, for example, like AIMS and PGI, and now we have many institutions which are purely engaged in research, should advocate for research around the country, generate more funds, sponsor research, and of course, also help in dissemination of knowledge in regards to publication. Now, one of the reasons why go back please. One of the reasons I have put this publication issue is that now many journals are asking for money for publishing papers. They ask for $500, $1,000, sometimes even $2,000, and there's no money available with the researcher. So one of the things is that a researcher has to be mindful of these journals which are open access and they ask for a lot of money. I think if they publish in society journals, this is very good. But in addition to that, there are some journals which are society journals, very reputed journals, but still they ask for money. And I think there should be a mechanism of built-in grants for publication charges. And also now there is a mechanism by how institutions can partner with publishers so that this kind of fee can be taken care of. Next, please. Now, so if there is lack of inertia, the institute should inspire and also recognize their researchers and their scientists and their professors. We must, and for example, today I mentioned about this DBT Foundation Day. They had so many categories of awards, and they awarded so many scientists from across the country. It was so heartening to see that their efforts have been recognized by the scientific institutions, and this is what is required in the country to have more such awards and recognition. Next, please. We should also provide fellowship for conferences, attending conferences. We should provide fellowship for basic science training, both nationally and internationally. Often in medical colleges, and I have seen this, in medical colleges, there is hardly any funding for providing fellowship. Somebody wants to learn a new technique. Somebody wants to go to a basic science lab to understand a technique. Nowadays, it's all molecular biology, sequencing, next-generation sequencing, proteomics, multi-omics platforms. And these people are not been exposed to such high quality research. So I think providing fellowship for attending such courses is also very important. Next, please. Then research methodology is something that has taken a backseat. Now, when we talk about medical education, we find that during 5.5 years of medical training, there is hardly any emphasis on research methodology. So once a person comes out of this as an MBBS, as a medical doctor, he has not been exposed to how to conduct good research. During their post-graduation, we find they do one thesis, but that is also at a very basic level. So I think it is very important for young researchers and assistant professors and young scientists that they be exposed to proper research methodology courses, which could be basic and advanced. In fact, we have one course like Train the Trainer courses, and we should always, the institution should fund such courses so that their faculty is benefited. Next, please. One of the things the institutions can do is to start mentorship programs. We can have mentors within the institutions, and we can have mentors in other institutions. We can select young researchers from our institutions and then do mentor-mentee pairing. And we should again fund such mentorship programs, which will go a long way in shaping the career of young researchers. And again, this is the role of institution they have to really emphasize. Next, please. And this I've already said that the institution should have some kind of intramural funding mechanism for young researchers, and startup grants should be given so that they can start their research projects. They can have some kind of a startup company also. Some kind of grants could be available for innovations and further research. Next, please. One of the questions people often ask, do we have the money? Do we have the money for this kind of research in India? Next. And this is applicable to science. So for example, they will say, should India launch a lunar mission, do a liver transplant, or provide drinking water? Somebody will say, we don't have safe drinking water across villages in the country. So should we be providing safe drinking water, or do liver transplantation, or launch a lunar mission? My answer is simple. Next, please. That India has to do both. We have to provide both liver transplantation services and also provide safe drinking water. If we only say we will do safe drinking water and not do transplant, we'll be much behind rest of the world. Both things have to go simultaneously. You have to progress in every area. If we had not launched the moon or the Mars mission, or our own capabilities in defense and space would be at a much lower level. So both have to go hand in hand. Next, please. And in terms of resources, we can have frugal resources, frugal innovations. So every one of you might have seen this picture somewhere, that how India's first rocket was carried on a bicycle. So resource constraint cannot be the only thing which will prevent people from doing high quality science. Next, please. So frugal innovation is very important. Then one of the problems are in research, deficit in ideas, deficit in enabling environment, and deficit in funds. So I have dealt all these things, that how industry, how institutions and government agencies can enable a better research environment in the country. Next, please. One of the things in terms of funding research is money. And a concept which we should borrow from economics is deficit financing. And in the last annual budget of this country, we have seen that fiscal deficit target has been increased from, say, about 3% or 4% to about 6.5 to 7%. The concept behind this is you cannot always say that I don't have money, so I won't do this particular activity. Sometimes you have to overspend in spite of the budget constraints. So the deficit financing concept has to come in the area of science also. And I'm very happy that this year science budget has actually increased by significant percentage in India. Next, please. So we should generate research fund. In addition to government funding agencies, industry can be involved. We can have donors, and we can set up endowment funds, which will also help in funding these research projects within the institutions. So there are not one, there are multiple mechanisms how institutions can generate research funds for their faculty and students. Next, please. Now, research is very important. And I said, this is what will take the country forward. But there are 2 or 3 problems with scientists. And I want to highlight that because I'm sure there are many scientists who are listening to these talks today. Next. So one problem, next please. One problem is that many of us have this issue of confirmation bias. We try to find evidence to confirm our ideas and concept. We always think my idea is the best. And I think we should be mindful of this confirmation bias. The second is, next please, is narrative fallacy. So when we say, this is my finding, we try to explain things without direct evidence by often illogical thinking and deductive reasoning. So these 2 problems of confirmation bias and narrative fallacy, a scientist has to be mindful of. We should avoid these things, and we should look science in a much broader concept and see whether our findings, whether my ideas are reasonable or not. Next, please. The third thing that I add to these 2 is skepticism. A skeptic is someone who doubts what is known and challenges dogma. And I think skepticism also very important. Otherwise, we always feel that my research is the best, or a paper published in a high quality journal like Nature or Science is the best. But when we apply skepticism to our own research, this is very important to understand what is known and what is the right thing. Next, please. So one of the things people say, why do we need to do all that? Next. We need to do all this to guide policymakers. Next. We need to do that to allocate resources. Next. Because research will guide that. We have to assess economic loss because of diseases, and that's why you need epidemiological research. We have to do preventive strategies in the area of medical diseases. For example, yesterday there was a news that Tata Memorial Center has published a paper in BMJ showing how healthcare workers can diagnose breast cancers early on. And this will result in major preventive strategies for diseases in the country at a frugal cost. Next, please. So I would like to conclude, ladies and gentlemen, by saying that research is hard, frustrating, time-consuming, and without immediate rewards. But it is fun and exhilarating at the end. And I would urge all young researchers and students and PhD students and postdocs to engage meaningfully in research and help science grow in India, to make India as a knowledge hub, as a research hub, and as a nation, what we have shown in the case of COVID vaccines, to come to the high table in area of science and technology in the world. Thank you very much for your kind attention.
Thanks, Prashagak. I think very stimulating talk, and this has stimulated people like us also, but this I think will stimulate the generation which matters. who have to fight with the system, who have to work with the system, and who have to work with themselves, to create the right environment for them. Because I think your thoughts are every sentence, every dot which you made makes a lot of sense to different people. And really hope that you will continue to push more and more thoughts with a concrete action and create more groups, advocacy groups, so that a movement grows for I think a positive atmosphere, which is there at the moment. But the example is that we have a huge unmet potential, which we can achieve with a shorter span also. Whenever we choose to, we do it. That's all. So when we will decide to choose that, I think that's the issue. But I think superb.
And you have
Now,
yourself shown the way, sir. And when you were at the helm of affairs at ICMR and DHR, you have shown that how you have increased the capacity in this country, both in terms of technology as well as diagnostics and research. So that is very well appreciated.
Thank you, Mr. Garg. Thank you. But I think there's a lot more to be done, which should be done. I think this all successive generations. Madam Sharma belongs to a 90s generation, and continue to lead today. I think this is a continuum. I think there's a lot to be done. If there are any questions or any comments on the three superb presentations, I think we'll like to give 5-10 minutes, because we started a bit late, and we started virtually at 11:30, sharp 11:38, I think, at that time. But we'll finish another 10 minutes. I think NASI headquarters will give us for any comments, any questions. Well, if there are none, then it's my pleasure to.
I had a comment. I really enjoyed the lecture.
Go ahead.
And I liked his idea of involving undergraduate MBBS students into some research. We started at IIT Bombay. We call them undergraduate opportunities for research, UROP. And that's excellent, because then they get a taste for it, at least those who want to go into research, they can do it. I highly appreciated that comment. And of course, lots of other things.
Thanks, Mr. Mishra. Thank you very much. I think that addiction for science should begin that early, that I agree with that actually. And that's, the DG who selected our talent search scheme scholars way back in 1975, Dr. Gopalan. Yeah. All of us belong to, because we were pulled out of the routine life into a addiction to science, and that addiction stays then actually. I think I agree with you, Mr. Mishra. I think there's no replacement to that. No replacement to that, yes.
Right.
Thank you.
Okay.
Dr. Patra,
I would also like to add one thing. While in Ravensa University, we introduced one very interesting thing. Nowadays in universities, there are many guest faculties. So what we said is guest faculty comes and then teaches for 1 hour and just vanishes. So we renamed it. We said it is a research cum teaching fellowship. So you have to take at least one class, one theory and one practical if it is science department, or 2 theories if it is a non-science department, and then stay back for doing research. After 1 year and after 2 years, we will review. If you are doing good research along with teaching, then your fellowship will be enhanced, or you will be asked to go from both, from research and guest faculty. That actually encourages a lot of people to come into research. In fact, they used to stay back in the university. They are available to the student and available to the department also for supporting research of the department.
Very nice.
Otherwise, also you pay the same money. Otherwise, you pay 20,000 rupees. By name of research fellowship, you pay 25,000 rupees with a small contingency grant. So it helps.
That people treat like a pension otherwise, Dr. Lakshmaya, you want to say something, or anybody else?
Yes, I think I enjoyed the lecture of Professor Garg, and particularly his idea of this deficit financing in the research, because where the money comes from, I think that's the great idea which Finance Minister has shown, and I think this should be put up by the medical research people as well as the general research people. There's always the problem where the money is coming. Our situation is so bad. But I think this question of borrowing the money somewhere or the other for the future generation, I think is a great idea. Congratulations.
Thank you, Professor Mittal. I think I tell you, that money is always there with the government. and you don't know where it is. They know it. First, Manju Sharma madam headed the department for nearly 10 years. You know, I know story for 7 years. So the question is the advocacy, and if you continue with the advocacy, that negative money comes from somewhere. They have the money.
Yes. Always.
They keep it under a lock and key. You don't know, but it is there all the time. Yes. No, actually, question is a competitive ideas, you know, and do it actually. And I tell you, but my last comment will be, because, you know, I always said that in the previous people who made an impact in the medicine, for centuries, for thousands of years, they didn't have the big labs actually. The ideas come from the thoughts actually, the way of thinking. So I think that stays for physics, chemistry, biology, and the medicine altogether the same. Thank you, everyone. Thanks, madam, for the opportunity. Madam, your comments now. Yes.
That today in the country, biomedical research is being supported and done by a large number of institutions, both the DBT as well as ICMR, some of the CSIR institutions, also DST. The only problem I sometimes find, nothing wrong in duplicating something, duplication of research, but there must be very clear understanding and collaboration between these 4 or 5 organizations. For example, DBT and ICMR, they must consult each other. Nothing wrong if you just have one person, one of the ICMR person in DBT task force, and similarly DBT in ICMR. That will help us to, save a lot of money, and we can do more and more research, because every time we are asking for more funds for research, more funds for research. So if we do this, that we just collaborate and see that we don't duplicate too much. Some duplication is okay. At the same time, we are aware that, let's say, 6 vaccines in the country, 3 are being done by DBT, 3 are being done by ICMR. This must be known to everybody in the country. I think this type of strategy in biomedical research, especially to Dr. Katoch, I'm addressing this problem, and also to Pramod, because now he's going to head a very big organization of DBT. Now, what will he translate into products, processes? He will have to depend on ICMR. He will have to depend on DST institutions, CSI labs, etc. So here, what I feel is a networking, a collaboration is very important. And today, if you see in the world, there are large projects. One is not doing just isolated small projects. There is international collaboration, there is national collaboration, national, international networking, private public partnership. So we have to really come together to support more of biomedical research in the country. We can't keep on increasing the funds. We have to depend on a small amount of money. That's my suggestion.
No, madam, wonderful. I think there's a way to remind all of us that how we can do better, because, madam, all these things you showed the way at that time, and that's has continued. But this is in jerks. This is not to become a culture, madam. What you're saying, if that becomes it should become progressively a culture actually.
Yeah.
You established so many programs which did that way. We also tried our days. Everybody has tried in their our way, but they don't remain very fragmented efforts, madam. They should become the culture actually. That's I think your message at the conclusion side of this session is wonderful, madam. Thanks everyone, and thanks all the NASI headquarters. And madam, thank you very much. That's it.
Thank you,
Thank you, sir. On behalf of the NASI, we are very thankful to the Honorable Chair, Dr. V.M. Katoch sir, all the speakers of this session, Professor Ishan Patro sir, Dr. A. Lakshmaya sir, and Professor Pramod Garg for delivering such nice lectures. And also Madam Manju Sharma to convene this session also. And I think we will assemble here after 30 minutes.
Yeah.
No. We are not quitting, madam.
Huh.
Kindly, should we start the next session?
No, we have to have lunch by खाना नहीं खाना.
Okay, madam. So
आप
at
देती
what
नहीं है
time?
कुछ.
No. At what time we should assemble again, madam?
We should
It is
come back if now it is 1:30. 2 o'clock now.
2 o'clock. Okay.
Because the next session
Was at
it's
1:30
we
actually
have
scheduled.
4 speakers, so it's a
Yes, madam.
very sort of a big session.
Yes.
Okay.
So at 2 p.m. we are meeting again.
Yeah.
Okay, madam. Thank you, madam. Thank you. Thanks to everybody.
Congratulations to the organizers of the DK Mission Award. Go ahead. सतीश कोचर जी की मुद्रिका का कुछ मैटर है, मैंने जवाब फ्री हुई पर प्लीज देखें तो मुझे कागज आए. सीधे कह रहे थे अगर ट्रांसफर देख नहीं आप उनसे बात करवा उसे थोड़ा सा कर रहे हैं ग्राउंड की कुछ डायबिटीज बाहर
मैडम नमस्कार।
गुड
मैम
आफ्टरनून
आपकी
मैडम।
आवाज नहीं आ रही है मैम।
आपकी आवाज नहीं आ रही।
मैम आवाज नहीं आ रही प्लीज।
Hello, Sudhanshu.
नमस्कार अखिलेश।
Namaskar, madam.
आप कैसे हैं?
We heard you in the other meeting just now.
You were there?
Oh yes.
अरे मैं 10 मिनट के मैंने कह दिया था।
आप मेरे में नहीं थे, मुझे मालूम है।
ऐसी बात क्यों नहीं? यहाँ से लॉग आउट किया, वहां गई, वहां जाके फिर वापस।
I could realize, yes. But it was
कुछ ठीक था कि नहीं? क्यों अखिलेश?
What you said was very refreshing.
क्या चीज?
जी?
ठीक था?
हम कह रहे हैं आपने जो refreshing था।
अच्छा, नहीं मैंने कहा बाकी तो चीजें आप लोग सब बोल ही रहे थे। आज ना अगर प्रोफेसर पद्मनाभन, ये सेशन बहुत टाइट है, आप नहीं ज्वाइन कर रहे हैं तो हम शुरू कर लेते हैं।
अच्छा मैम, जी मैम,
है ना?
जी,
क्योंकि हो सकता है वो थोड़ा सुबह से लगे हैं ना, थक गए हों।
तो मैम स्टार्ट कर दें आपसे।
हाँ।
A very good afternoon to all and welcome back to this event. Now we move on to the last session of this symposium, and we have very distinguished speakers with us to elaborate on various aspects of health as well as healthcare, like therapeutic management for COVID-19 pandemic, emerging viral infections, smart medical devices, which is a very emerging concept of smart healthcare, and most importantly, the potential of our alternative systems of medicine, especially the Ayurveda, for exploring the innovative methods for this thing, taking care of healthcare system. And I am very much honored to invite Honorable Madam Dr. Manju Sharma ji, the NASI Distinguished Human Scientist Chair, former Secretary to the Department of Biotechnology. And she is a role model for us, and we request you, ma'am, to please start.
Not necessary all this. भैया पानी छोटी गिलास में।
Over to you, ma'am. Ma'am, please start.
Since Professor Padmanabhan has still not joined, maybe he's taking a little rest. I will start the session, and my first speaker is Dr. Sudhanshu Vreti. I don't think he needs any introduction. Everybody knows Sudhanshu for such a long time, especially for the Japanese encephalitis vaccine on which he worked long ago. He is an Indian immunologist and also a microbiologist and the director of the Regional Center for Biotechnology. And he is known for his studies in the field of RNA virus replication and vaccine development. He is a fellow of the NASI as well as Indian Academy of Sciences. The biotechnology department gave him the National Bioscience Award for Career Development, one of the very important awards in biotechnology for his work in 2003. He also got a Vasvik Award, and he's got several awards. He's a very decorated scientist of the country. Presently, he will be talking on a subject which is most relevant in the present context, that is COVID-19 therapeutics. And he is actually working on that, and he'll be speaking. So, Dr. Sudhanshu Vreti, please.
Thank you, madam, for a very generous introduction, and thank you very much for asking me to speak at the NASI annual general meeting. I will try to share my slides. Okay, I think everybody can now see the slide. So I'll be talking about therapeutics of coronavirus disease, COVID-19, development of therapeutics against SARS coronavirus 2. But Before I get into that, I thought I'll spend a few minutes talking about the virus and the current scenario with respect to the pandemic. So the ongoing pandemic of coronavirus disease, COVID-19, is caused by a virus called SARS coronavirus 2, SARS-CoV-2. This is a spherical enveloped virus of about 18 nanometer size. Virus has 4 structural proteins and there are 16 non-structural proteins. It is a positive sense single-stranded RNA virus containing a RNA genome of about 30 kilobases. The receptor for the virus on the host cell has been very well identified as the ACE2 protein. Virus infects the epithelial cells of respiratory tract, and this particular virus causes both upper and lower respiratory tract infections. There have been a lot of controversy about the origin of this virus, but it would suffice to say that virus has 96% similarity to bat coronavirus. Therefore, there is a possibility that it might have originated from bats. COVID-19 scenario is pretty grim currently. This slide I have taken from the data that was available on the site yesterday. In 192 countries, there have been more than 100 million cases of COVID-19, which has resulted in 2.5 million deaths. So most people infected with coronavirus 2, SARS coronavirus 2, experience mild to moderate respiratory illness and recover without requiring special treatment. However, older people and those with underlying medical problems like cardiovascular disease, diabetes, chronic respiratory disease, and cancer are more likely to develop serious illness. And depending upon the location, it can be said that anywhere between 1 to 2% of these cases are resulting in mortality. Indian scenario has been grim all this while, but for last 1 month or so, there was some respite. In India, we have had more than 1 crore cases of coronavirus which were recorded. This has resulted in 1.5 lakh deaths. But as you can see, the number of corona cases in India peaked somewhere around October, and after that, the numbers started to decline. But in last couple of weeks, the numbers have picked up again, and especially there has been concern in a couple of states like Maharashtra and Kerala, where a significant increase in number of cases has been seen in last couple of weeks. Okay, so vaccines have been considered as the best bet against infectious diseases, but vaccines are useful when you know the pathogen, and vaccines will be useful if these are available. So they could be used either as a prophylactic against the possible outbreak of the pathogen, or if you already have the vaccine and the outbreak has taken place and the population is not immunized, you can still use that vaccine to immunize and protect a lot of people. But when a new pathogen emerges or a new virus emerges, we know nothing about the virus, nothing about the pathogen, and therefore we do not have a vaccine. So what do we do? And this is precisely the situation we are in today. This new virus emerged sometime early in 2020 or late in 2019. And of course, as we did not know about this virus a whole lot, there was no vaccine available at that point of time. Of course, now vaccines are available, but it would take a lot of time and a lot of effort and a lot of money to vaccinate the large population that is required to be vaccinated. So what is required in such scenario? You require affordable drugs that would act fast against these novel pathogens. Now, for coronavirus infection or to deal with coronavirus 19 illness, you could attack 3 stages of virus replication or virus infection. You could develop drugs that block virus entry into the cell, You could develop drugs that prevent virus replication inside the cells, or you could develop drugs or use those drugs that minimize the damage that virus has done or will do to the organs. Now, various strategies across the world in different labs are being taken to develop drugs against COVID-19 illness. And foremost among these has been repurposing of existing drug. There are others which I will describe a little later, but let's talk about repurposing of existing drugs. For that, let's see what is a drug development pipeline. So in the lab, you develop the drug molecule in silico or by chemical synthesis or by screening of a library. And this molecule undergoes the discovery and development phase, including the preclinical development in the lab, which takes anywhere between 5 to 7 years. If you are successful, it goes to the clinical development another 5 to 7 years, and then it goes through the regulatory approvals, etc., before it can hit the market. The whole process takes somewhere around 10 years, and typical cost of a new drug molecule development is around 2.5 billion US dollars. And then chances of success are also very low, anywhere around less than 5%. So a new strategy is being employed in recent times to make use of existing drugs. There are more than 200 drug molecules that have gone through all this drug development pipelines and are prescribed or are available for various medical indications. Now, the repurposing means that making use of these drug molecules to treat a new indication or a new infection. And that's it. That is what has been done for coronavirus 2 precisely. A number of molecules were identified as possible inhibitors of virus replication or virus infection. And these are listed over here like remdesivir, lopinavir, and ritonavir, favipiravir, hydroxychloroquine, ivermectin, and there are a few others which come under this category. And these molecules have been tested in hospitals through various clinical trials. And I'm going to describe in the coming slides what is the status of these studies and the outcome of these studies. But before I do this, the other methods that are employed for developing new drugs or drug molecules are in vitro screening for virus inhibitors. So if you know the viral proteins or their functions and the critical viral proteins that are required for virus replication, you can develop in vitro methods, high throughput methods for screening antiviral molecules. In the recent time, using high performance computing, it is also possible to identify molecules in silico which might be useful to be used as inhibitors of virus replication, that is based on the structures of the protein, critical proteins, and the possibility of these molecules blocking the active site of those molecules. Then, of course, therapeutic antibodies are also useful, and I will talk about a couple of therapeutic antibodies. And in India and China specifically, there have been a lot of herbal drugs and herbal products that are used routinely, and these have been explored as possible therapies against COVID-19. Okay, so what do we know about remdesivir? It's a nucleoside analog, which was originally developed to treat hepatitis C infection. It was successfully tested against Ebola in rhesus monkeys. However, the drug was found to be ineffective in clinical trials in humans, both against hepatitis C and Ebola. You might remember in 2004, we had another SARS coronavirus infection. And at that point of time, this drug was found to have antiviral activity against the SARS coronavirus, that is the earlier 2004 coronavirus. And subsequently, another coronavirus that emerged, that was the MERS coronavirus. So based on this, this drug was tested in China early, I think it was in the month of February or so, but they did not find any great use of the drug in the patients. However, in rhesus monkeys and more recently in other animal models, such as hamster models, remdesivir was found to be a potent inhibitor of virus replication and was shown to prevent COVID-19 progression. WHO then tested remdesivir as part of the solidarity trial in a large number of hospitals across 30 countries and large number of patients, and they did not find any positive indication for use of drug. They said the drug had little or no effect on hospitalized patients with COVID-19. However, in a controlled trial that was conducted at NIH, the studies published in November 2020, remdesivir was found to reduce the recovery time from 15 to 10 days and also gave some survival benefits. So based on these and other observations, the drug has been authorized for emergency use in the US and India and for compassionate use in Europe. Several companies in India have launched generic version of remdesivir, and in India, this drug has been extensively used to treat COVID-19 patients. The other drug has been Kaletra, that is the commercial name of the drug, which is a combination drug of lopinavir and ritonavir. These are actually HIV inhibitors, which are used to treat AIDS patients. However, in 2004, the earlier coronavirus outbreak, it was found that this combination drug reduced the risk of adverse clinical outcomes, as well as reduced the viral load among SARS coronavirus patients. Lopinavir has activity both in vitro and in animal models against MERS coronavirus also. And based on this, clinical studies were conducted in COVID patients using Kaletra. And this study, which was published in October 2020 in Lancet, found that this combination drug was not associated with reduction in 28-day mortality or duration of hospital stay or risk of progressing to invasive mechanical ventilation or death. Therefore, had limited use or actually no proof that it was helping COVID patients. WHO also conducted or tested this drug as part of the solidarity trial, and their outcome was that drug had little or no effect on hospitalized patients with COVID-19. So these findings do not support the use of this combination drug for treatment of patients admitted to hospital with COVID-19. Favipiravir has been another drug that has been extensively used. This is a nucleoside analog and approved drug to treat influenza in Japan. This drug is incorporated into a newly formed RNA strand, and it prevents its elongation and thus proliferation of the viral genome. Drug has antiviral activity against other RNA viruses such as West Nile virus, yellow fever virus, foot and mouth disease virus, as well as several other RNA viruses in cell culture and in the animal models. During the early phase of pandemic, specifically in Italy, the drug was approved for use as experimental drug against COVID-19. A randomized clinical trial was conducted in India in 150 patients, which showed 28.6% faster viral clearance and 40% faster achievement of clinical cure. This drug has been found giving promising results in clinical studies in China, Russia, and Japan. However, more trials are underway in multiple countries with larger number of patients. Currently, treatment guidelines from many countries and some states from India have included favipiravir in the treatment protocol. Hydroxychloroquine has been the most controversial drug that was used for coronavirus treatment. This is an approved drug for treatment of malaria and rheumatic diseases. It has known anti-inflammatory properties, and in the cell culture models, at least it has antiviral effects against several viruses. US FDA issued an emergency use authorization for use of this drug in patients suffering with COVID-19. A French study actually showed some effectiveness of hydroxychloroquine in reducing the viral burden in treated patients. However, an observational study published in New England Journal of Medicine showed that drug administration did not affect the mortality. WHO also tested hydroxychloroquine as part of the solidarity trial. Drug had little or no effect on hospitalized patients with coronavirus 2, patients suffering with coronavirus 2 or patients of COVID-19. Since then, FDA has revoked authorization of chloroquine or hydroxychloroquine as COVID-19 treatments. Ivermectin is a potent drug to treat parasitic warts. Doctors use it against river blindness, a parasitic disease, and other diseases. Veterinarians have been using this formulation for a long time to cure heartworm. Actually, somewhere around the month of, I think, May or June, Australian researchers showed that drug blocked coronavirus replication in cell culture model, albeit at a very high concentration. A number of clinical trials were then taken up, and a large clinical trial has been going on in Singapore, which includes 5,000 patients, to see if this can prevent people from getting infected. A recent study as early as this month, published in International Journal of Infectious Disease, this was a placebo-controlled study reported from Dhaka. It used 12 milligram of ivermectin and doxycycline, 100 milligram daily for 5 days, combined with the standard care in 72 hospitalized patients. The study demonstrated a clear benefit to treated patients. They showed that virus clearance took place in treated patients in 9.7 days as opposed to drug-treated patients or the standard care treated patients, where it took 12.7 days, that is the placebo. So there was a clear benefit of ivermectin in treating COVID-19 patients. As I said, there's a larger trial which is going on in Singapore that will establish this, either way, whether this is really effective or not. But ivermectin has been increasingly used in Latin America, and in India, this is currently being prescribed as COVID-19 therapy. Convalescent plasma therapy has been talked about a lot, and more so in the newspapers when Delhi government actually started plasma banks. Mayo Clinic in US suggested that treatment provided a modest benefit, but only to patients who got treated early in the disease. An open-label trial was conducted by ICMR on 464 hospitalized Indian patients who were moderately ill. This study is published in British Medical Journal. 239 patients received 2 transfusions of convalescent plasma, while the control group comprising 229 patients received standard care. 1 month later, 44 patients who received the plasma had progressed to severe disease or had died, compared to 41 patients in the control group. So, although plasma treatment was associated with earlier resolution of shortness of breath and fatigue and higher virus clearance, it did not provide any clear indication that it had any benefit to COVID-19 patients. The major limitation of this study was that neutralizing antibody titers of the convalescent plasma that was used were not known. A recent, I think it was published a month ago in NEJM, January 2021, a double-blind placebo-controlled trial in 160 subjects in Argentina showed 48% reduction in progression to severe respiratory disease. Here in this study, they had established the neutralizing titers of the plasma that was used, and they found that plasma with high IgG titers of 1:3,200 or higher reduced the risk of severe respiratory disease by 73%. They also showed that early administration of high titer covalescent plasma against coronavirus 2 in mild mildly ill patients reduce the progression of the disease to severity. So there is some indication of help coming from convalescent plasma, but it is important to know the neutralization antibody titers, or at least antibody titers in these plasma, and it seems only plasma containing high titers of neutralizing antibodies provided the real help. Virus neutralizing monoclonal antibodies have been under investigation and development, and at least 2 companies are pretty advanced in this area. Eli Lilly announced promising results from a phase 1/2 study on 452 mild patients. The viral load was significantly reduced with a large dose of antibody, that is 2.8 grams, 1800 milligram dose. The monoclonal antibody reduced the risk of getting hospitalized by 72%. Regeneron is another company that announced promising results in a preliminary study of a combination of 2 monoclonal antibodies on a large number of non-hospitalized patients. Large placebo-controlled studies are currently underway with these antibodies. The US FDA has issued an emergency use authorization for investigational monoclonal antibody therapy for the treatment of mild to moderate coronavirus patients. Dexamethasone is a corticosteroid which is used in a wide range of conditions for its anti-inflammatory and immunosuppressant effects. It was tested in hospitalized patients with COVID-19 in the UK. Oral or intravenous preparation of 6 milligram dose once daily for 10 days was tested. For patients on ventilator, the treatment was shown to reduce mortality by about 1/3, and for patients requiring only oxygen, mortality was cut by about 1/5. WHO strongly recommends that corticosteroids such as dexamethasone, hydrocortisone, or prednisone be given orally or intravenously for the treatment of patients with severe and critical COVID-19. WHO advises against the use of corticosteroids in the treatment of patients with non-severe, so mild COVID patients need not be given corticosteroids unless the patient is already taking this medication for some other condition. Time and duration of medication should be once daily for 7 to 10 days. That is the WHO prescription. So early during the pandemic, we set up a facility for testing the antiviral activity against SARS coronavirus 2 using the RT-PCR method. And we used remdesivir as a positive control in our studies, and this method established IC50 of 0.1 micromolar. This facility has been used by a large number of pharma companies and academic research labs in India to test more than 1,000 molecules or herbal extracts that they thought had antiviral activity. Since these are all commercial molecules, I will not be talking about those molecules and the outcome from those. But this method was a low throughput method, requiring almost about 6 to 7 days before we would be able to give results for about 20 compounds. Since then, and this was developed because at that point of time, antibodies were not available and no other method could have been developed except RT-PCR. Since then, we have developed, with the availability of good quality antibodies against SARS coronavirus 2, a immunofluorescence-based high throughput method. This method is in a 96-well plate, and we can screen something like 200 molecules in about 2 days, or depending upon per person. So if you have 3 or 4 people working, you can really screen almost 1,000 molecules per week easily. The method was validated again using remdesivir, and IC50 was similar to what was found with the RT-PCR method. We are collaborating with Ayush, and this is just a representative slide I'm showing over here, where a large number of herbal products or plants and their extracts have been provided to us for screening using this method. And as you can see over here, Tulsi, Kalonji, and Kalmeg out of the, I think 12 or 13 different plants that were tested, they showed a substantial inhibition of virus replication in the cell culture model. So for example, you see over here, remdesivir is used and it gives a inhibition of 99.9%. If you look at Kalonji, it also gives you inhibition of 97%. Tulsi gives you an inhibition of about 85%. And Kalme gave us inhibition of about 98%. There are many other, such molecules, and because of their commercial nature, I'm not describing them over here. But what we are doing right now is we are carrying out activity-guided fractionation of those molecules to zero onto the extracts or perhaps the purified molecule that might have antiviral activity. And all I can tell you right now is that there is some good progress that has been made on this front. Now, once these molecules have been have shown potential to inhibit virus replication in the cell culture model, in collaboration with THSTI, we have also established a golden Syrian hamster model for SARS-CoV-2 infection, where the young animals are infected intranasally with the virus, and these animals show active virus replication in their lungs, and they stop gaining weight. So for next 4 days, they actually lose weight. And after that, they start gaining weight. And there's a liver pathology, lung pathology, which can be clearly seen. And here's the slide. You can see animals that are infected, let's say this is the red line, they start losing weight once they are inoculated with the virus, and only after 4th day, they start picking the weight. Whereas the animals which do not receive virus, they continue to grow, the green line. And there is, of course, lung pathology and splenomegaly. And in the lung histopathology, you can clearly see mast cells, inflammation, and all other markers. Remdesivir is used as positive control in these studies, and you can see remdesivir treated animals. So these are red line shows animals that were given only the virus, they are losing weight. Animals which were given remdesivir, green line, they are not losing weight, and blue line is animals which were receiving only the just the PBS, so they are not losing weight. In fact, they are gaining weight. And again, there is no splenomegaly when animals are treated with remdesivir. So using these methods, in vitro and in vivo method, we are in a position to screen large number of molecules or plant extract that is currently ongoing in laboratory at RCB and THSTI. So what does WHO prescribe for treatment of COVID-19? This is a living WHO guideline, which they keep publishing. And what they have concluded, hydroxychloroquine has a strong recommendation against. Lopinavir, ritonavir has a recommendation against. It's also a strong recommendation. Remdesivir, also they do not recommend. So there is a recommendation against, although weak against. But corticosteroids, if you look at it, they have a very strong recommendation in favor. All right, so till we have any drug which specifically can target SARS coronavirus 2, mask wearing seems to be the best bet. And there is data to support the Children's Hospital at VCU in US. What they have shown is that countries that prescribed mask wearing, within 15 days of the first outbreak, they had very little or no mortality. You can see with this red line over here. Countries that took 15 to 30 days to prescribe mask, there was some mortality, the blue line. And countries which did not prescribe mask wearing, even after 60 days of outbreak, they showed very significant mortality. So the only thing that you can do right now is wear masks, save lives, wear a face cover, wash your hands, and keep a safe distance. This is the only prescription that is currently available. Thank you very much. I will stop here.
Thank you, Sudhanshu, for this very interesting and a very in progressive type of a lecture, where you have shown that what are the existing drugs and where we are heading towards, especially with regard to herbal drugs. I will now invite Professor B. Ravi. He is from IIT Mumbai, and he is the chair professor of mechanical engineering at IIT. He has developed several novel technologies and designed for castability and rapid tooling, printed medical models, etc. And his innovative work has won him several prestigious awards, including the DST Lockheed Martin India Innovation Gold Medal. His book, Made in My India, The Past, Present and Future of Indian Manufacturing Industry, it received an award by the then Prime Minister, Shri A.B. Vajpayee, in 2003. He is committed to indigenous product innovation, working with teachers to enhance the employability of students in the manufacturing sector and contributing to the thought leadership and policy making at various levels. Professor B. Ravi will be talking on smart medical devices for affordable screening and diagnosis. Professor Ravi, please.
Very good afternoon, Dr. Manju Sharma ji. I hope I am clear.
Yeah.
Oh, thank you very much. And Dr. Sudhanshu ji, what a nice overview of the entire COVID medication treatment protocols. I think we all have to, but finally the end was very nice. It all comes down to common sense, I suppose. But thank you for that. And I'm also looking forward to my next speaker. So I would keep mine very short, maybe under 20 minutes or so. I'm unlike Dr. Sudhanshu ji, I'm sharing more of my experience about not a specific medical device, although that will be part of my talk, but also about the overall ecosystem of how to create many more success stories like that. So I'll mention what we learned about the values of death from an idea to the innovation or impact. We will also talk about at least one success story I'll share. And then I'll take you behind the scene about what goes behind that to create success story. And finally, some best practices that we have learned. Hopefully, some of these things will be interesting and useful to everyone in the room here. Now, I wear multiple hats at IIT Bombay, in addition to a professor of mechanical engineering. So you know where I'm coming from. I also now head the Center for or School for Entrepreneurship at IIT Bombay. And of course, my main reason for being here is that we created this center called as BETIC over the last 5-6 years. And this story is actually from BETIC. So to take a quick step backward, we have seen fantastic examples of the innovative nature of Indians during this pandemic. Whether it's a teacher who used a chair and a ceiling fan to take her classes, the milkman, someone's using steam from pressure cooker to disinfect the vegetables, even Adivasis, maintaining a distance. An entrepreneur said, I'll do a steam treatment, effective or not, don't ask me. And of course, PPEs and things like that. So with all those things, the question is that why are we at this point of time importing a large number of medical devices? As per some estimates, 80% of about 50,000 odd crores of devices per year that is required. The point that I would want to highlight particularly is that the countries where we are importing from, mainly USA and Germany and so on, their per capita expenditure on healthcare is more than 50 to 80 times of India. And so even if we give 90% discounts, these devices are not affordable to the majority of our population. So we must do something about it. If you look at the industry landscape, especially the Indian medical device industry, it is very nascent. We can say very, that's why I put a baby pink color here. And we are struggling to compete either with the Western countries in terms of quality or with China and other Eastern countries in terms of low cost. And of course, regulation has kicked in now, so the manufacturers cannot have the way they were doing earlier. They have to follow all the rules of the game. But given the situation, when we talk to the doctors and clinicians in particular, hundreds of them, they all say that, no, we are always ready to look at something which has novel, better features, more suitable for our anatomy, our functionality, our requirements, as long as it has high quality reliability. And of course, it has to be affordable, adaptable, accessible, and so on. So it's easy to give up hope with this kind of a situation. But I say that given these new technologies which have come up on the horizon, there's a 3D printing or CAD/CAM or artificial intelligence, machine learning, augmented and virtual reality, cloud, Internet of Things, sensors, robotics. All these have an element of IT, information technology, and of course communication technology into them. And somehow we Indians are naturally good at these things. And using these things, we can actually reinvent and recreate these devices, making them smarter, much more accessible, affordable, reliable, and so on. Except that the issue is that we need to get different kinds of people together in the room. We need definitely people with medicine background, design, materials, manufacturing, even management, even I would say social sciences, public health, and so on. Until they're all working together in a seamless way, this is going to be a pipe dream. So we really need to look at what is holding us back as Indians. And again, when you look back at it from academia on one side to society or industry on the other side, we have a lot of ideas coming from academic institutions, R&D laboratories. They're building proof of concepts. Some of them take it forward in terms of a prototype, because many institutions do have these innovation centers and incubation centers and so on. And then you have business incubators where you actually take from prototype to product stage. And of course, then you license it to a larger company, or the same startup scales up, and then you go into mass productions and so on. And of course, the amount of funding that you need goes by about 10 times as you go from TRL, technology readiness level 1, to all the way to the end. If you are thinking which is the deepest or the deadliest value of death, and if you thought the third one, then you are right, because that is where the boundary between academia to industry happens. And both of them think that it's the job of the other person to convert a research prototype into a marketing product. So unless we get all these four actors in the place, government, of course, for funding and regulation, academia for research and development, industry for manufacturing and marketing, and society in general, also for where we can go and do market research to define the problem and validate a solution. But this is not enough. I keep saying that we need 4 more players, and this is the incubators funded by government, investors in large numbers who are still shy about medical device, healthcare sector in general. The media, can we not have the media reporting much better stories of what is happening? And of course, industrial parks. Unless we get the ecosystem right with all these 8 players, we are doing a piecemeal solution about the whole thing. So let me tell you a story at this point of time. So this story has 3 actors. One guy called Tapas Pandey, who hails from Dehradun, an electronics engineer who at that point was working in Hyderabad in a semiconductor company, Intel. And then we had Dr. Nambiraj, who was a rural hospital, a clinician in a place called Derwan, which is a midpoint of Bombay and Goa. And the third guy is Adarsha, who hails from Kopa. Kopa is very close to Sringeri, and he's electrical / software engineer at that point working in L&T, Mumbai. So these 3 people met for the first time in a medical device innovation camp. We call it as MEDIC in IIT Bombay. You can see Dr. Nambiraj mentioning a problem that when a patient comes to me in a rural hospital and I put the stethoscope onto the patient's chest and I hear a sound which I never heard in my training life, I have to take a call. Should I send the patient to the city hospital for an expert opinion, or is it not a serious affair and maybe I can ask him to relax? He said, instead of sending the patient to the hospital, can I send the auscultated sound to the expert doctor? That was a problem that he defined. And 4 days down the line, these guys had a proof of concept where they could take a normal stethoscope, convert the analog sound into digital sound, take it into laptop to a Wi-Fi to speakers in the room, and Tapas could transmit his heartbeats to the entire audience in the room. But then, of course, life is as it is. They went back to their jobs. And then about 6 months later, I get a phone call from both of them saying, Professor, we want to come back to IIT. Is there a way we can take the innovation forward? I said, welcome. They came back to IIT. I put them in touch with multiple doctors from multiple hospitals, which is Hinduja, and also in BJ Medical in Pune and other places. So I said, you spend time with doctors understanding what the problem is, understand the nuances of that, find out their wish list, the pros and cons of every current solutions and everything else. Then only we'll start doing your development. So over a period of next 2 years, from the proof of concept that they developed in the hackathon in 2015, it took them 1 more year to create an alpha prototype, which is almost demonstratable with some limited functionality. And finally, the beta prototype, which is just a batch of some 10 pieces, which they give it to different doctors to try it out. And finally, a product which is now made in mass production. Hundreds of them are produced every month. And on top of that, they created a software by which this phone with a Bluetooth can link up to a mobile smartphone, and you can visualize, analyze, transmit, share, can do a lot of other things with these sounds. And this has become a very big hit, and doctors are loving the app, and they're buying the stethoscope because of the app. By the way, this is just a simple module, the blue one which you see. Any normal stethoscopes, and apparently doctors love their own stethoscopes, they don't want to give it up. They just have to plug the tube and put this module in between the chest piece and the tube. It becomes a smart stethoscope. Very simple. So these guys filed a patent, and we are very thankful to BIRAC that they got the BIRAC Biotechnology Ignition Grant. And with that, they started a company called IU Devices. So this was IU Devices team in about 1.5 years back. Now the team is almost like 30-40 people now. They are now doing very, very well. They've got multiple awards. I told them go to only those awards where you get cash, because cash is valuable for business. So they got a lot of cash, but also some of the government hackathons, instead of cash, the government would give them orders. So both the Gujarat Startup Summit and Maharashtra Startup Summit, the award was 100 order for 100 stethoscopes or something like that, which was very nice. So today they have sold more than 2,000 units all over the country in the last 2 years. Many companies are actually telemedicine companies who are serving rural areas, rural or small towns, very urban towns. And I think that the stethoscope has now touched more than, we are estimating about several lakhs of people by now. And we are very happy about the whole thing. When COVID happened, this became a boon because you don't even need the earpiece. You could link up to a headphone. Headphone can be with a Bluetooth, wireless headphones, and the clinician could remotely auscultate the patient. In fact, a nurse could auscultate the patient, and the doctor could be in the next room or even in their houses. Many senior doctors had actually comorbidities, so they said we will play safe, but we want to be valuable to the community. So they were helping the patients even though they were at home. And many doctors said this was really fantastic. You see the bottom right picture, just about if you can see. The little girl is able to put the stethoscope on her chest, and the clinician is able to auscultate from a distance. This is possible by the miracles of sensors and Bluetooth and all these electronics available today. So these guys got featured into Forbes, into Business India, into all mainstream newspapers, many TV channels. They have become now inspiration for many other innovators through the country. That was one story. I have many stories like that, but I thought one more I'll just mention in brief, one slide version. Diabetes has become a very big problem in the country, and one of the fallout of diabetes is that you have diabetic foot ulcers, DFU. And these are claiming apparently DFU amputation, a toe or a leg, is happening every few minutes in the country. So these guys came with a device which is doesn't depend on the patient feedback. It is far more smarter. You can see the display in a mobile phone. They're coming with a new version by which the device can be in a patient's house, which can be like you measure your shoe size, your leg size in a shoe shop. You can put the leg on a device, and it can automatically beam the entire pattern of the tissue stiffness and your pressure sensitivity, temperature sensitivity, vibration sensitivity. All those things can be beamed through the mobile Bluetooth to the clinician's laptop or whatever. So this is one more example. So like this, we have about now 16 startups which are come out of this Betic lab in IIT Bombay. You can see from head to toe, screening devices, monitoring devices, diagnosis devices, surgical instruments, rehabilitation devices. The bottom one, actually, if you look, funny looking thing, actually is a portable operation theater, which you can put in a backpack and go and do an operation anywhere. This is also proving to be very valuable to burns victims, very low cost burn victim isolation. Plus, we are doing several projects for the industry, which is coming to us saying that you become our R&D house. These are typically small and medium companies, not large companies who cannot afford R&D engineer. They're saying that we know the market, we know the specifications, you develop the technology and product for us. So like this, we have done about 16 devices in-house where the innovator himself incubated their own startup company. And then you have industries who came to us and said that we license it to them. So about 20, 25 devices like that we have done so far. By the way, all the startup companies out of 16, 15 have won the BIG award. And in fact, all of them won multiple other awards also, including India Innovation Growth Program and so on. So what is the secret behind the whole thing? The secret is this boutique, which you see, it's a very humble shed. It was abandoned in IIT Bombay, so we took it over and we converted into a beautiful place. It's a dream place for people who come in there. You can see the natural setting with a lot of banyan trees and so on. It's supported by the Maharashtra state government, in a small measure by the DST in New Delhi also. But essentially, we have positioned this lab as a running partner for medtech innovators. We look at medtech innovators as someone who are running a race, a marathon. And we want to be their partner, supplying to them water and glucose and maybe oxygen, and of course, cheering them on the way. So, and BETIC is not just one lab now. BETIC is a hub and spoke model with 2 other centers, one in Pune, one in Nagpur, funded by the state government. And we have several self-supporting centers, 4 more engineering colleges, and about 7 medical institutes. So these 13, 14 partners are the core network of BETIC. But then we have many more partners with whom we are working without signing MOU. With all these, there is a MOU signed, but there are others who are not signed. There are about 30, 40 more institutions like that. That makes BETIC more or less now India's largest medical device innovation network of its types. The facilities typically in all the centers are basically some proof of concept building, some medical modeling, electronics prototyping, plastic prototyping, metal prototyping, and so on. We also have a nice gate lab in a partner institute where which we can do gate studies, human movement analysis for various ailments. Apparently, a walking signature can reveal many ailments, and not just skeletal but also neurological and many other things. So this is important slide in case you're wondering of. What we have done is to put a process in place, and this is one major reason why we could manage that. So it all starts from a doctor who defines a problem. We never start a problem which is not vetted by a clinician, ideally multiple clinicians. So that is the stage 1 is definition, stage 2 is development, stage 3 is deliver, stage 4 is deploy. And each stage has 4 steps. So 4 into 4, there are about 16 steps which you see in this picture. And each stage, there's a leading role being played by either a clinician or researcher or entrepreneur or an investor, but all of them, of course, have to work together from the beginning. So at this point, we have about 400 odd unmet clinical needs gathered from more than 150 clinicians from all over Maharashtra and also outside Maharashtra, out of which we have developed we have created 250 different proof of concept for different devices. And then we have developed about 50 working prototypes, which are under testing of different types, and about 25 products have been licensed, as I just showed you some time back. The other good thing we have done was to put a pipeline in place. How do we create multiple products year after year, month after month? So the pipeline comprises a hackathon, which we typically do in April. We are doing an e-Medha this year because of pandemic. And the winners of the Medha go into a camp, which we do in September typically. It's a 1-week intensive training camp for that. Then those who win that, we bring them as fellows in our BETIC for 1 year. And after 1 year, we tell them typically you put an exhibition your device after patenting, of course. We organize our own exhibition called MEDEX. And once that happens, and the person is very clear about whether they want to create their own startup or license it to someone else, we tell them to go to some business incubator. So Sign is an incubator of IIT Bombay, but our startups are there in multiple incubators also. And finally, they can move on to the medical path. The dotted line is again the demarcation of BETIC and the incubator. So BETIC essentially takes innovators up to the edge of commercialization, and then they can start the companies. So we are like a pre-incubator in some sense. Okay, so that is what takes the whole process forward. I'm just going to show you quickly some pictures of, and then I can close very quickly. So these are some of the pictures of hackathons, which are typically 2-day hackathons. We have done it in Bombay, Pune, Nagpur, Wardha, Kolhapur, Marias. In fact, it's good to do the hackathons in other towns because we are creating the local innovation ecosystem. The local doctors and clinicians, business people and faculty, engineering faculty get connected. and slowly they start their own betting center in those places. That is how we are able to expand the network. Then I also mentioned to you that we do a camp, intensive in fact, it's a 5-day, 4-night camp. No one goes to sleep for 4 nights. And we have done about 5 of these camps, and it's really a life-changing experience. People actually said that my DNA is modified after 5 days. I can no longer think or walk or talk like how I was before that. These people truly become, change makers or change agents in life. And then I mentioned in the pipeline also exhibitions that we organize. So just I need a quick feedback. Am I audible? Are the slides working fine? Anyone from the audience?
Yes, they are.
Oh, thank you. Because you never know in this situation. Thank you very much. So we have also organized our own exhibitions, as well as we put them into India Innovation Science Fair, where you can see Dr. Harshvardhan 3 times. But the sweetest thing has been, the nicest thing has been our Prime Minister, who when had come to IIT. You can see the governor behind him. I had a special privilege to showcase our best medical devices, and he spent a considerable amount of time asking what we are doing, how we are doing, and so on. It was a privilege to be presenting it to him. But our happiest thing really are these pictures, and these pictures show a doctor, an engineer, and in some cases a patient also. We call them our happy pictures. We look at them. It gives us a lot of energy to say that we are, and working with these clinicians has been extremely great. Many of these clinicians actually are those who wanted to become engineers, but somehow they went into medicine. So they're somewhere in their subconscious mind, they wanted to, always work with engineers. So when we talk to them, it's a very beautiful relationship that they build. And our own team also, there are several engineers who wanted to be doctors, but they could not do medicine. And so it's a very nice give and take mechanism there. Okay, so I summarize my entire thing into one slide here. And what we have been able to do is to build an ecosystem. We call it as reinvent. I'll tell you what it is in a minute. But the ecosystem comprises of 4 pillars. One is a team. The people in our team, they have mechanical materials. We have medicine, biomechanics, electronics, software, management, quality systems. We have all kinds of people. At this point, we have about 40, 45 people, researchers, full-time staff, students, and so on, and mentors who are experienced innovators, managers, and continuous team of experts coming to a lab of different types. So collaboration, transcending personal comfort zones. I say you're an electronics guy, now you learn mechanical. You're a mechanical guy, you learn electronics. You both go and attend a surgery and see what happens. Take a video and find out what is happening in the surgery. How is a clinician, is he having a difficulty in the tool or whatever it is. So a lot of transcending comfort zone happens. We take a lot of calculated risks. Otherwise, innovation cannot be without risk. But when you take risk, failures are absolutely certain. But you learn from failures and move on from there. All this is foreign to Indians. We are very, very risk-averse kind of a people. So we need to really break those silos and mindsets. And the infrastructure is very critical for product engineering, prototyping, pilot batch manufacturing, which is a major problem. We have not able to build that. It's very expensive. Industry doesn't want to share their facilities, and academia doesn't want to put those facilities. The pilot batch manufacturing is a major, major bottleneck that India has not addressed. Silicon Valley, within a radius of 50 kilometers, I could find 5 places like that. Singapore has that, China has that, Korea has that, Japan has that. In the entire country, there's just one place in Visakhapatnam where this manufacturing can happen of medical devices. Nowhere else, which is a shame. I think we need a place like that in every innovation hotspot in the country. And then, of course, the procedures, quality procedures, SOPs, records, all these are absolutely critical, not just for industry, but also academic institutions, R&D labs like ours, where we are doing innovation. Medical innovation, you need to have SOPs in place, standard operating procedures, and quality systems in place. All this sounds very difficult and challenging in academic institution, but I tell my team, keep the end user in your mind. Think about a patient who you saw last, in your camp or surgery. We are working for the patient. We are not working for us or IIT or anyone else. We are working for that patient. And that somehow seems to give the energy level and the goodwill and support systems that is really essentially put a system like that. So more information, there are multiple sources. One is I have put down all our experiences in a book form called Essence of Medical Device Innovation. Slightly out of print right now. I'm writing the second edition of that, hopefully in this year. We are perhaps the only lab to have an ISO 13485 certificate, which is typically industry certificate for quality systems. But this IIT lab has a certificate for that. A lot of content is there on Swayam channels, and there's a channel called Living Science. The BETIC website is there, and also the School of Entrepreneurship, where I also teach innovation entrepreneurship. All these give a lot of information about these things. So I'll just conclude by saying that what I showed you was a way to go from research to innovation to entrepreneurship. We call it as reinvent. And this has led to multiple medical devices, right from implants and prostheses, surgical instruments, diagnostics and monitoring. And we have done it not just in one place, not just in IIT Bombay, but now a large network of about 13, 14 centers direct, and then another 13, 14 indirectly we are working with them. So I hope this presentation, something was interesting or useful for you, something for you to take forward and engage further. And thank you so much for your patience.
Thank you very much, Professor Ravi. It was really fantastic. I mean, to believe that so much of work has been done, and so many startups and so many students involved, and with all sorts of things, surgicals and implants and all the things which you have shown. It's really remarkable. And I congratulate you, and also on behalf of NASI, congratulate you for this outstanding work which you are doing. Thank you very much, Dr. Ravi.
Thank you, madam.
So can we have the next speaker, Dr. Srivastav? आप हैं अभी? यूसी श्रीवास्तव?
नहीं, मेरा नहीं है।
आप यूसी श्रीवास्तव नहीं है?
मैम त्रिपाठी सर।
हाँ, नहीं, मैं पूछ रही हूँ, यूसी श्रीवास्तव हैं?
जी हैं।
डॉक्टर श्रीवास्तव, आप मेरी हेल्प करिए, अब लास्ट के दोनों आप पढ़ लीजिए उनका बायोडेटा।
हाँ,
और मतलब आप को चेयर कर लीजिए। अब ये हमारा ही सेशन कंटिन्यू हो गया है। सो
त्रिपाठी जी आ गए? ओके।
My co-chair,
Dr. Tripathi is a professor of biochemistry and former dean in the faculty of Ayurveda at Institute of Medical Sciences, Banaras Hindu University, and specialized in drug development from traditional knowledge of Ayurveda. He has patented 3 products in USA, China, European Union, and India with the help of DBT and DRDO funded projects. He is a recipient of UGC Career Award, ISCA Young Scientist Award, DBT Technology Transfer Award for his academic achievements. Now I invite Professor Y.P. Tripathi to present his presentation.
Thank you very much. Am I audible, sir?
Yes, I can listen you, but your PowerPoint is not clear. Now it has
come. Clear?
Now it's coming.
Now it has come.
First of all, respected Professor Manju Sharma ji and the G. Padmanabhan, who is not here, and all the NASI executive members who have given me the chance to share my experience with all of you. And I have been given a topic, Ayurveda innovation. I think the way back when for first NDA government, when a Jai Vigyan mission was initiated, when Professor Manju Sharma was the Secretary DBT, from that time innovation started, but it was in a very low scale. But after the COVID pandemic, it has gone to the very speedy manner, and all over the country, the Ayurveda is being tried at the molecular level. And I devote my all lectures to my father, Professor S.N. Tripathi, was professor of Ayurveda and Dean Faculty of Ayurveda also he was. And he used to say that Ayurveda is a science which can only be proved at the molecular level in those early 70s. And now it has become true. Before I go to the innovation, I want to introduce the subject Ayurveda to the science community, because this is the hybridization which is being done now.
थोड़ा सा loud कर दीजिए, little louder.
अच्छा, how to do loud? Okay. That Ayurveda is not only the medicine. In fact, there are three major components which has not been developed in the country, and everybody thinks that Ayurveda means herbal medicine. But if you see this slide, this says that the Deva Vyapasya, spiritual healing, Sattva Vajay, psychological counseling, and Yukti Vyapasya is the medicine part. The whole of the words looks like Ayurveda is only medicine, that is herbal or herbo-mineral. But I think we should focus on these 2 points also. The research is required on these things. And another important point that Ayurveda has 8 branches and Ashtanga Ayurveda. And out of this, in this country, only 5 branches have been developed. After the post-independence, 3 have been left behind. That is the Bhut Vidya, Vajikaran, and Rasayan Shastra, Rasayan Vigyan. These have not been developed. And in fact, these are for the wellness. And Ayurveda says, Swasthasya Swasthya Rakshanam, Aturasya Vikas Prasamnam Cha. It means that healthy people should remain healthy and patients should be treated. But healthy will remain healthy only when it is being taken care. And for that, these 3 branches were there. But unfortunately, because of the hospital culture and not the society culture, these things were left behind. It is the time when we should re-explore these 3 branches of Ayurveda by scientific tools. There is no harm in trying it. If they are not good, we will again drop them. But nobody has tried till now. And another important thing that the preventive and 3 branches that I told you, Ashtanga Yoga also. It is a yoga is a part of Ayurveda and yoga, they sit together. In yoga, yam and niyam has been left. Only asana and pranayam and meditation have been popularized. So I think yam and niyam is very important. I come to the next slide. This is the present scenario. I think yesterday in the inaugural lecture, Ram Bhargavaji and G. Padmanabhan told the long story. What is the national mission and what is the actual story when the G. Padmanabhan wanted to mix allopathy and turmeric for the treatment of malaria, and how the DGCI put hurdles round and again. These are the things which we have to change. Recently, just last week, I had a presentation in the BIRAC, and what they said I want to share with you. This was a clinical trial of a product BH2X, which was developed under Jai Vigyan Mission in 2002 for the atherosclerosis. And for the 20 years, we could not have the clinical trial. Thanks to the COVID pandemic, when the government has allowed us to go for this. But even then, the people said, take such medicines for the CVD management. And this kind of discouraging things are there. So my worry is that the scientific committees of different funding agencies, the true implementation agencies in the country, are still in the old thought process and not allowing Indian knowledge, Ayurveda, to grow. So this is the summary of what I have done in the last 40 years. After doing my PhD in biochemistry, I joined as a lecturer in Faculty of Ayurveda, medicinal chemistry. And I have done plenty of medicinal plant. I have these are the products which I have developed with the help of the funding agency of Government of India, different projects. One thing more that before I go to pillar, there are 3 pillars of good health. Ayurveda is the food, sleep, and code of conduct. And yam and niyam, pratyahar of the yoga, they define yam and niyam is the social health. And pratyahar define the mental health. And asana and pranayam define the physical health. And this is the spiritual. I want to show that the Ashtanga Yoga and Ashtanga Ayurveda, they are overlapping. The terms are different, but it has the same thing, that of psychosomatic. First psyche, then soma. Both has to be handled. And now, Ayurveda was scientific, and it is scientific. It has been proven by last 3 Nobel Prizes. You can see that 15, 16, and 17. The last was the seasonal cycle. It was the autophagy. All these things are related to our Ayurvedic concept, but they have not been tested on the clinical observational study. The intervention is not required, but the observational study is very much required, because these things are in practice in the society, in different religions, in different names. But nobody has documented these things. This is the worry why Ayurveda could not develop. And recently, bioinformatics has given a good boom to the Yukti Vapasha, means the medicines of Ayurveda. Because bioinformatics, we are testing all these phytochemicals from these medicinal plants which are already in clinical use. I have published this paper in last October, November, where ashwagandha, giloe, and tulsi have been studied. This was the journal which was published. So this we all know that supporting importance of daily body cycle, seasonal cycle, and food cycle. This is called the Bhoj Kalanam. You know, in the modern medicine, the dietitians always talk of protein, fat, carbohydrate, minerals, and vitamins. But we talk different. How the same rice can be cooked and in which form it should be taken and how it will be effective for different kind of aging people, different kind of diseases, and so on and so forth. What I mean to say that the Ayurvedic knowledge of food is also very deep, but it has not been scientifically validated. This is one. So, you know that Bhoj Kalanam, so this is the cycle of Vata, Pitta, and Kapha, which regulates your health. So these three cycles should not be compromised by your lifestyle. If it is compromised, then there is always a problem. So you know the another important thing that about Bhoj Kalanam, which I told you, that every organ has their circadian rhythm. So depending on liver, we know that liver is the master gland. So it has to be taken care for all kind of diseases. You know, the Vata, Pitta, and Kapha imbalance covers all the diseases described in allopathy. But in Ayurvedic people, they talk in terms of these three terms: Sattva, Raj, and Tam, Vata, Pitta, and Kapha. But this has to be relooked in our scientific language. This is what we have to do. So this is the autophagy. You know, it supports the body purification at the cellular level, at the organ level, and at the system level. And because in Ayurveda there is a concept called Am Dosha. Well, most of the arthritis and autoimmune disorders are because of the Am Dosha. And we can see that amyloid body accumulation and then immature and mature amas have been described. So these are the Sanskrit terms, but scientifically still we are fighting to explain them. So this innovation is the demand of time. And you know, autophagy is the disease progress and the health improvement. This is AMPK and mTOR cycle is very important. And I think with the Langhan, there are 10 types of Langhan have been described in Ayurveda, not only abstaining from food, abstaining from water, abstaining from salt, so on and so forth. Maharishi Charak has given a good description of that. That has to be looked into. So this is the slide just to educate that all the food material and medicines are made up of 5 Panch Mahabhutas: Akash, Vayu, Agni, Jal, and Prithvi. And the body is also made up of these 5. And within the body, Vata, Pitta, and Kapha is the physical, and Sattva, Raj, and Tam is the mental component. But you see that these only 5 components are controlling everything. For the treatment and for the wellness, there is a concept of simile. Means if you are having a scarcity of gel, then gel-related component will be affected in physical. Gel-related component, tama, will be affected in mind, and gel-affected component, this sweet, ras, will be affected in your food. So you have to see that you have to cover up all these components which are linked to this Panch Mahabhuta by your food or by your diet. This is the very important thing. And another important thing, that the kalpanas, I have told you earlier, that the same food will have a different therapeutic value if they are taken in the different preparations, that is called the pharmaceutical form, product development. To show that the Sattva, Raj, and Tam, that the sense organs, body, and psyche, all the 4 makes your body, makes your life. If anything is damaged, you will get a disease. So you have to take care, and for only for that 3 approaches of treatment has been recommended. So this is the paper I published in 2002 in Indian Journal of Experimental Biology, because I wanted to validate Vata in terms of signaling pathway, Pitta in terms of phosphorylation and dephosphorylation, and Kapha in terms of gene expression. This is a very old paper. It is because in those days everybody was looking what is Vat Pitta Kapha from the scientific point of view. So, but this I am trying to decode the treasure of Ayurveda, because the Ayurveda, this says that either the drug will decrease or increase this Vat Pitta Kapha. So how to monitor objectively, these are the points. And one thing more, that for good health, there are 13 type of Agnis we have been described, but Jatragni is the gastrointestinal tract, and Bhutagni is the intermediary metabolism and the clearance. Dhatu, 7 dhatu. So Agni has to be 7 dhatus, 5 Bhutagni and 1 Jatragni. So what is this? Why the disease appears? Asatma Sangyog, improper use of sense organs, chronological changes, and psychological insecurity. So these are the 3 causes. I think that my earlier speaker has developed many devices. I would expect that he can help Ayurveda in developing such kind of devices, so that we can validate our Ayurvedic concepts. So this is the slide which I am showing, that the psychosomatic, which I told you earlier, because it is controlling your pancreas and the GI tract and the microbiome of your intestine. So these things has to be looked into. Physiology is controlled, so both has to be looked into. This is the take-home message, and this is the psychological effect on Vata, Pitta, and Kapha I've told you. And this slide I have already told. One thing more, that there are 6 rhythms: solar rhythm, doshic rhythm, life rhythm, seasonal rhythm, daily rhythm, and dietary rhythm. For these 6 rhythms, different kind of recommendations have been given by Maharshi Charak for the food and for the lifestyle. This has to be relooked. So this is a cartoon I made, that hari bari and curry make you prone to the metabolic disorders. I mean the chronic diseases, which are diabetes, blood pressure, because the earlier people were peace of and calm, less calorie diet, more fruits and vegetables, herbal drugs, and less strenuous exercise. Now people are not following these things, so they are getting the NCDs, which is going on very high. And the biochemistry behind this is the excess oxidative stress, free radical stress. You see, the worry makes you catecholamine. Catecholamine reacts with iron and makes more hydroxyl ion. Hurry makes more mitochondrial activity, so more superoxide production by electron transport chain and oxidative stress. And curry means already we are taking toxin by the peroxide foods, the deep fried foods. All these things are leading towards oxidative stress and death. So this is the another thing. The nowadays this adipose obesity is a big problem. But you know that there is a healthy adipose and there is a unhealthy adipose. The M1 embedded adipose tissue, that is the inflammatory adipose tissue, that has to be looked. And in Ayurveda, Maharshi Charak has given a group of drugs called the Lekhan Dravya, Medha Dravya. There are 10 medicinal plants which have been clubbed together. And I think the why that vision, Maharshi Charak put 10 plants. I was working with this Lekhan Dravya. Accidentally, I found that one of the plant is this Nagar Motha, Cyprus rotundus. It is not hypocholesteric, but it is TNF alpha inhibitor. So this is, I thought that Maharshi Charak might have thought that Lekhan Dravya means anti-obesity means not only lowering the cholesterol or the triglyceride, but it should be inhibiting the inflammation. So this slide shows how visionary they were, and now we are trying to. This is another slide which I want to share with you, that the Rasayan and Vajikran which I told you earlier. What is the main function? It prevents the aging and diseases, gives longevity and strength, cures diseases, means regeneration and better sexual power. But one thing more, it is not only drug, it is drug, diet, and lifestyle. This is the Achar Rasayan. This is called the Ajarsik Rasayan. This is called the Namitic Rasayan. So all the medicinal plants which belong to the Rasayan group have been classified in this way. That has to be explored. Another more thing, the Ashtanga Hridaya is one of the textbook of Ayurveda. He has classified the 100 years of age span into 10 years block. And for each 10 years, they will say that one physiological weakness will be there. For example, in 41 to 50, the skin wrinkles will come. So Jyotismati, like that they have given. So that has to be again searched out. And now I am coming to my innovations, just a few success stories. This is the BHUX, which was funded by DBT, and we got a US patent. And now I am approaching BIRAC for clinical trial. I hope I will get it or not, I don't know. So this is, the main idea, the concept was that this collagen cap is there. This becomes very weak. And then this cholesterol bumps and heart attack takes place. So my idea was to develop some herbal composition which stabilize it, number one, and doesn't allow plaque to grow. And after the Peter Libby was the scientist who came in 1992. He said inflammation is the primary cause of atherosclerosis, not the cholesterol. Goldstein said cholesterol, but he said inflammation. So my Ayurveda drugs, Lekhan Dravya, became very pertinent for this. So I make a hypothesis. These are the 5 plants: Commiphora mukul, Semicarpus anacardium, Terminaria arjuna, this is the Samuga, Boswellia serrata, are the 5 medicinal plants we used in different combination. And then we requested to DBT, and I was kind enough that DBT was kind enough to support us. And these questions, whether effect on HDL, effect on the plaque disruption, and effect on the collagen cap. So these are this is the model which I have used on the rabbit model, and they are the 7-8 parameters we did, and all papers were published. And observational study was this: the intimal thickening was reduced, and the collagen cap was intact, and calcium content in the tissue was low. This we can see. So, and the same thing we did with the cell culture in collaboration with the Mayo Clinic, USA. And we found that in the smooth muscle cell culture, you see the calcium content is significantly low at this dose. But on higher dose, it was not that effective. That I could not answer. Why only particular dose it is coming down, but on it is lower than the normal, but higher than this low dose. It means that Ayurvedic drug should also be treated like a medicine. Not only it cannot be taken as food of whatever one want, one can take. It should be under a physician's supervision. So we came to the conclusion that this is increasing HDL, and HDL is coming up, and this is inhibiting the inflammation and inhibiting the MMP. All hypotheses were proved. So management of diabetic nephropathy, this is the new project again I got 2016 from DBT, and PTY1 was patented in India, not in foreign. And still we are in process of negotiating with companies for the mass manufacturing. The prototype we have made, but now mass manufacturing, and the India industries are not very comfortable in investing money. They don't want to take risk. So still I am flying. So this is the pathogenesis, stage 1, 2, 3, 4, 5 for diabetic nephropathy. This is all you know. And this is the main thing I want to show here, the podocytes. This is the podocyte which produces nephrin and the podocin. And when expression goes down, it becomes flat, and then proteinuria starts. And this is the intact. That has to be done, healthy and unhealthy. So we focus, this is the Pruria tuberosa, very cheap drug and very common in Himachal and South India. And they are being used as a rasayan dravya. It is one of the component of Chavanprash. But for the first time, we tested it for the diabetes and its nephropathy. And we are working for the last 12 years for this plant. 4 PhD students have submitted their thesis. And ultimately, what is the good part of this? It is a hypoglycemic. At the same time, it is directly acting on the kidney abnormalities. That is the nephrin gene expression, VEGF gene expression, and all these things we tested. And we found that hypoglycemic, antioxidant, anti-inflammatory, anti-apoptotic, and MMP activator. 5 properties in one plant. This gives another strength in Ayurveda that when we are using total extract, then it may be multi-target action may be better rather than giving one molecule isolated from this. Maybe the effect may be less, but the side effect also will be less, and there will be additional benefits by taking this drug. You can see this the same PTY2, the incretin level is going high. So GLP-1 agonist has been found in this property. This paper has also been published. Shivani Srivastava, who is now doing postdoc, in USA. She has done it. You see, she has designed this model also, that PTY2, because of the incretin, is also helping the deteriorating pancreas to stabilize. So GIP and GLP-1, DPP-4 inhibition at one hand and GLP-1 agonist on the other hand with the same plant extract. This is something very good which we have published. And this slide is showing the histology of that. This is a confocal microscopy we have done with the PTY2. And these are the novel and diabetic. Another important innovation which I have done is the cinnamon tamal leaf, the tej patta, which is common in the kitchen. And I took help from the NCCS Pune, another Department of Biotechnology Institute, with Dr. Bhatt. And we found here in our lab that you see the combination of Ayurveda and allopathy is also important. You see this is the hexane fraction of the C tamal, and the effect is only 21%, hypoglycemic effect, plasma glucose. And when we are using 0.01 unit of insulin, it is only 11%. It is dose dependent, but very low dose of insulin is giving 11%. When we added this low dose, this and this, we found that 59% hypoglycemia was. What I mean to say that there is no harm in combining allopathy and Ayurvedic drugs together for getting more effective responses. This is my feeling. So the same thing I did it with this alpha glycosidase in the intestine, and we found that very good. This is the carbose and this is the CT extract, and dose dependent increase was found. The last innovation which I want to share with you, this was the DRDO funded project. We did it on the DMBA induced breast cancer in mice, and with the help of the Department of Zoology, Dr. Jagat Roy was our co-investigator. The semicarpus anacardium and the Rubia cardifolia, Manjistha. We gave a combination of these drugs, and you can see the significant reduction in the nodules in the. So this shows this is the same thing, the AGNOR dots you can find. And these are the herbal things which we did before COVID. In the COVID also, as the speaker has told detail, I am not going into detail, but the protease inhibitors is one thing which we focus, and ACE inhibitors in the host. And these are the pathology. Immunoglobulin level has been described. So this is the protocol developed by WHO, and we also developed a protocol. This paper has been published in Indian Journal of Traditional Medicine in CSIR recently. And we developed the Sanchay, Prakop, Parashar, all these things by the agri doctors. And the avoidance of these causative factors, prophylactic management and treatment of COVID-19 positive patient based on the severity and symptoms. For that, we got the 3 projects from the Ayush. One is the Shirshadi Kasai. The clinical trial is going on with the Department of Medicine. And then another drug is the Sunti Adrak, dry, that also is going on with the help of Red Cross Society in Varanasi as a prophylactic measure. But the Shirshadi Kasai is going in the positive hospitalized patient, because this drug is being used for the asthma and other diseases since 1984. It was developed in BHU only. But when COVID came, we tried to repurpose it, and we got the project of Ayush Mantralaya, and work is going. So this is the treatment strategy of Ayurveda. Here also, I always congratulate our Prime Minister that उन्होंने थाली बजवाया, ये सब किया. This is very important. The Sattva Vajan Deva Pasha was the important component of this. So this is the last the paper which I have showed you. We have published it. So with these words, this is my team of PhD scholars who have contributed. They are the recent students, but in the past 30 students have done PhD with me, and all these projects are dedicated to them only. Thank you very much.
Thank you, Dr. Tripathi. This was a very, very informative and very thoughtful lecture. And I'm sure you'll be able to convince the authorities to support such research in future. All the funding agencies, you will have to make an effort to go to them. So thank you very much. And now we have the last speaker of the symposium, Dr. Shahid Jamil. Dr. Srivastava.
I will introduce. I will introduce.
Please.
मैं introduce कर दूंगा. Dr. Shahid Jamil is a renowned virologist. He is currently the director of the Trivedi School of Biosciences at Ashoka University. He was formerly the Chief Executive Officer of Wellcome Trust DBT India Alliance. Known for his research in hepatitis E virus, Dr. Jamil is an elected fellow of all the three major Indian science academies, with Indian National Academy of Sciences India, Indian Academy of Sciences, and Indian National Science Academy. He is a recipient of several prestigious awards. The Council of the Scientific and Industrial Research awarded him the Shanti Swarup Bhatnagar Prize for the Science and Technology, one of the highest Indian science awards for his contributions to the medical sciences in 2002. Now I request and to present his presentation, Professor Jamil.
Thank you very much, Dr. Srivastava, and thank you very much, Dr. Manju Sharma, and my sincere apologies for putting you to so much trouble for changing the schedule, but certain things were really out of my hands. So apologies, and I'm very grateful for the opportunity. Let me share my slides. Are you able to see my slide?
Yes.
Put it
on
on
view.
screen.
See the slide and we can listen you all.
Yes, wonderful. So I was asked to to speak about emerging viral diseases, and over the next 15 to 20 minutes, that's what I plan to do. If you look at diseases that are emerging, there are three kinds of diseases: newly emerging diseases, re-emerging diseases, and deliberately emerging diseases. So of course, the newly emerging ones are the ones that have not been seen in humans or in animals. Re-emerging diseases are those that were once found and had sort of disappeared, and they are now back again. And the third category, which is deliberately emerging disease, there's really only one example of that, and that is anthrax, which has been used for bioterrorism. So the other thing on this slide that is of note is that disease emergence is a global phenomenon, and it's really present on all continents, whether it's the Americas, Africa, or Asia, or Australia. So important to understand how pathogens emerge. Pathogens usually emerge from wild animal populations. And if you see this little pink line at the bottom, this is how, let's say, there is a cycle of pathogen cases going up or down in wild animal species shown on the left here. But if situation is conducive, then there can be a spillover from wild animals into domestic animals. And this would be, for example, when farms are and dwellings are close to forested areas where wild animals and domestic animals have a chance to exchange pathogens. And this exchange could be direct. This exchange could also be through vectors, such as mosquitoes and ticks and other arthropods. The next stage really is spillover from domestic animal populations into humans. So the newly emerged pathogen amplifies in domestic animal populations, and of course, because of close contact with humans, spills over into humans. But there are also occasions where the pathogens in wild animals are also able to directly spill over into humans. And when that happens, either direct spillover or through domestic animals, the pathogen being new to the human population, the population is naive for it, and the pathogen very quickly amplifies and causes a lot of disease shown in the red part of the curve here. But as more and more humans get infected, they develop immunity, the population develops immunity, and the pathogen eventually becomes endemic, so really disappears from the circulation, causing outbreaks. But small outbreaks, isolated infections keep happening. Now, if you look at the kind of pathogens that are there in human populations, viruses contribute to only about 14% of human pathogens, but they cause roughly half of all new and emerging diseases. It has been seen if you look at data over the last 50 years, it's been seen that roughly 75% of all emerging viruses are also zoonotic in origin, meaning that they jump from wild animals into humans. And the key drivers for this are climate change and deforestation. And I will discuss both of those a little bit. And the key carriers of these viruses are bats and mosquitoes as vectors that can transmit from a variety of animal hosts into humans as well as between humans. An example here is the Nipah virus outbreaks, and I'll show this towards the end of my talk, where in all our recent memory, whether it was 2018 in Kerala or in Siliguri in 2001 or in Malaysia in 97, Nipah virus, which is also a virus carried by bats, jumped into humans either through domestic animal, and in that case it was the pig, or also directly into humans and caused disease that had very high levels of mortality. Here's a very busy graphic which essentially shows you the viruses on the left, the natural host where these viruses are present, and the vector that finally transmits it into humans. So if you see the first SARS virus, the natural host is a bat, and it was transferred to humans through civet cats and possibly also pigs. Similarly, the MERS coronavirus also resides in bats, but was transmitted to humans through camels, so a very different host. The most recent coronavirus also came from bat, but it's not clear whether it really used a secondary host like a pangolin, or it jumped directly from bat into humans. And the list goes on. I don't have to really go down, but just to highlight that mosquitoes are also very important vectors, and especially when we're talking about climate change, mosquitoes become very important for discussion. So there was this very interesting paper that was published almost 12 years ago by Kate Jones and Peter Daszak, where they looked at over 300 emerging infectious disease events during the period of 1940 to 2004. And their analysis showed that 60% of these events were linked to animal-to-human transmission. Over 70% of these diseases originated in wild animals. About 50% were due to bacteria, and that brings in another dimension of antimicrobial resistance into the picture. They also found that these correlate with socioeconomic, environmental, and ecological factors. And generally, the resource allocation and the reporting was very skewed. So resources were available in countries that had the least risk, whereas countries that had the highest risk had very poor resources allocated to this. And the same case was for reporting. Countries at the lowest risk, since they had resources, they were testing more and they were more, had better surveillance programs compared to countries that had poor resources and couldn't do those. So if you look at these 4 world maps here, the first one shows zoonotic transmission from wild animals, and these are heat maps. Zoonotic transmission from non-wild, so domestic animals, drug-resistant pathogens, and vector-borne pathogens. And the thing to really see on this from our perspective is that India appears very prominently yellow or red on this map, which means that India has a high propensity for the emergence of infectious disease. And mind you, this analysis was published 12 years ago. Another important review which was published in Science in 2014, first of all, documented all the emerging infectious disease at that point in time, but also asked what facilitates spread. So what facilitates the spread is, of course, commercial air travel. We could go from one part of the world to the farthest you can go today in less than 36 hours, which is often less than the incubation period for most of these infections, meaning that you could actually be infected without symptoms and you could take that infection to another part of the world and develop symptoms there. Global trade and global supply chains are also linked to spread of pathogens because as products transmit from one part of the world to the other, pathogens also go. And a very famous example of this is how dengue has gone around the world in used car tires that have been shipped in containers. They often collect water, and in that water, mosquitoes grow, and they go from one part of the world to the other. Urbanization, of course, means you require space for building more spaces in cities. For that, farmland is often reduced, and to grow more food for the people, the farm is moved closer and closer to forests. So forest is cleared to make space for farmland. And of course, climate change, because as the earth warms up, it allows vectors such as mosquitoes and ticks to survive at higher altitudes. This review also addressed what facilitates control. What facilitates control are, of course, global communication networks, and we have seen global communication networks in operation in COVID times. Information was exchanged very easily. Almost all knowledge that was generated during COVID time was made open access, and that really speeded things up. Genome sequencing has come in a big way. So when COVID broke out, within a week of identifying the pneumonia clusters, the genome sequence was available, so we knew what was causing it. And that leads to rapid diagnostics, and that leads to new approaches to vaccines and therapeutics. I mean, at no point in infectious disease history have so many vaccines been developed in such quick time. So these are really conditions that both facilitate spread of infectious disease and also conditions that facilitate control. global hotspots and correlates of emerging in zoonotic diseases, if you look at that, then zoonoses that are originating from wildlife are a threat to not just health but also security and economic growth. And we have already seen this happen in COVID times. All economies have really been shattered. The emerging infectious disease risk is elevated in forested areas, or in tropical regions, and regions that are experiencing land use changes. So if forests are being cut down to make plantations or farmlands, and if this is an area where the mammalian species richness is very high, then it is cause for concern. And from India's point of view, the Western Ghats and the Northeast are very sensitive and very susceptible to these changes. So here are two world maps, and the difference between these world maps are that the first one has really not been, the first one gives you the actual picture of what has been reported from where, but the second one is based on the low reporting bias that comes from many parts of the world. And this is what I was talking about earlier, that countries that have low risk have more resources and therefore screen more. Whereas countries like ours have not been screening as much as we should be. So if you normalize that world map, you see it that, again, India and much of Southeast Asia appears to be high on this map. Okay, so let's get to deforestation, which is a very prominent driver of the spillover from animals into humans. If you just look at Southeast Asia, which I have just shown you is a hot spot, Southeast Asia in the last 40 years has lost 30% of its forests. At the same time, human population has increased by about 130 million people in the first decade of the 21st century, and is expected to rise by about 250 million in the first 3 decades. This, of course, needs, people need food. Food has to be grown on farms. So what you see is an increase in farmland across Southeast Asia. And I'm not going to read through the data here, but since land area on Earth is the same, where is this farmland coming from? This farmland is essentially coming from what this picture shows, by destroying forests. And if you destroy forests, you destroy habitats of wild animals, and you increase the contact between humans and wild animals. What is the situation in India? If you look at the State of Forest Report 2019 in India, our total forest cover is about 21.7% of the total geographic area, with an aspiration to go to 33% of total geographic area. So on the surface, things look fine in India, but they're actually not fine, because the very dense forests in India, which stands at only 3%, and this is at the cost of open forest, which is increasing. So open forest is an example shown here, where forests and plantations are together. And on plantations, you have both domestic animals and humans, and that leads to exchanges. So both in the Western Ghats as well as in the Northeast, you have the situation where dense forests are decreasing and open forests are increasing. So that still poses a problem. Now, let us look at mammalian populations on Earth. On the left hand, there is a graph that plots the mammalian species richness on one axis and zoonotic virus richness in that species on another axis. So it essentially means that rodents have a very rich species diversity, And rodents also harbor a lot of viruses. If you see bats, they sort of fall intermediate, lot of species richness, and also a lot of, they also harbor a lot of viral species. On the right, if you see, which is the animal that has the highest population on Earth, and that animal is humans. So the density of humans on Earth is increasing, and naturally, if there is going to be a spillover from wild animals into animals, the most prominent animal on Earth is going to be the biggest target for that spillover. And that's why infections in humans are emerging at an increasing rate. Now, we've been talking about bats and emerging human diseases. There are over 1,200 bat species in the world. Bats carry about 60 different species of viruses. Just coronaviruses, if you see, about 3,000 coronaviruses are circulating in bat populations. We have only so far seen just a few of them emerge in human populations. There is also increased diversity of bat species closer to human habitations. Why does that happen? Because bats feed on insects. Insects are attracted by house lights, so bats come closer to human habitations. When the dwelling of bats is destroyed, they often roost in barns on farms, and that brings them closer to humans. Similarly, fruit-eating bats, when forests are cut down and they don't have fruit trees in the forest, they come close to human habitations, to fruit orchards that are put on these plantations, and therefore come close to human populations. So again, the same thing, showing how coronaviruses have moved into humans and how various other viruses also are found in bats and are able to get into humans. This is really a world map that shows you all the diseases that have emerged from bats at various times in the last 50 years or so. Now, what do we know about bats in India? First of all, this spillover, I've been talking about it over and over again about open forests and plantations. So I won't speak about that, but in India, apparently we have about 128 bat species, but we know very little as to what is present in these bats. What viruses do these bats harbor? We know very little about it. There's this report that I could find in almost a year back, which showed that, which found 2 coronaviruses in Indian species of bats, but then we know nothing beyond that. There are groups in India that have the ability to do that, who have been looking at the Northeast and other parts. So one hopes that in future, in this research would be fast-tracked in the country. And I just wanted to bring this home. This is South Delhi. This is Haus Khas Lake. And this is a picture I took a few weeks back when I went for a walk around the Haus Khas Lake. And if you look at the circle here, which is magnified, this is bats in South Delhi. And in this picture, you see, and this was a time when actually bird flu was making a lot of news. So in this one picture, you have birds capable of transmitting bird flu and bats capable of transmitting corona and other viruses to human populations. And they are very close to us. So let's talk just a little bit about global warming. What global warming essentially does is to make it more conducive for insect vectors to survive at higher latitudes. And in this picture, you see two of these vectors, the mosquito Aedes aegypti and Aedes albopictus, which are both vectors for yellow fever, dengue, Zika, many viral diseases. So as the world temperature goes up, you see that the number of months in the year when the mosquito species can survive at various latitudes also increases, which means that people in these populations become more vulnerable to insect-borne diseases. And again, if you look at Aedes aegypti and albopictus, you see that people in Western Europe, if we do not control global temperatures, people in Western Europe, Eastern Europe, Sub-Saharan Africa, all over are going to become more and more susceptible to these insect-borne diseases. And essentially, it is estimated that under extreme global warming conditions, which means that if the temperature of Earth goes 5 degrees above what we have, then nearly 1 billion people could face their very first exposure to many mosquito-borne diseases. So it's also in our interest to control global temperatures. And this is what the Paris Convention and everything is all about. There's this interesting report from Alaska, which also showed that global warming is causing a risk by possibly revealing diseases that have been hidden in the permafrost for a very long time. And what happened in this remote village in Alaska was that when permafrost thawed out, a reindeer carcass came out which was infested with anthrax. And that caused an anthrax outbreak in this entire village. And this had not happened earlier because it was frozen and it was in the permafrost. Bringing home this point further, a paper published early last year looked at glacier ice, and they drilled down into the glaciers to look at ice cores that were up to 15,000 years old. So, and carried out viral metagenomic sequencing from these ice cores. And they found that there were 33 viral populations found in these ice cores. 28 of these were novel viral genera. These are viruses that humans have not seen before that were in these ice cores. So what else is in the ice core? What else will come out when glaciers melt? What else will come out when permafrost melts? We have absolutely no idea. So just a little graphic to show you the impact of climate change on human health. It's not just increasing CO2 levels and rising sea levels, which lead to, of course, air pollution, severe weather, but it's also diseases. Diseases because vectors become more accessible. Diseases, waterborne diseases come up. So all kinds of effects happen when there is climate change. McKinsey and company put out this report around the middle of last year, simply saying that COVID is not the last pandemic. How do we reimagine public health systems? And basically, they bring out 5 things, 5 shifts in healthcare systems that will reduce the chances of future epidemics. First is that currently we are in this reactive model that, if something happens, we will react to it. From this, we have to go to a health systems model that is always on, something that will be rapidly scaled up to take care of the surge. Second is that currently we have uneven surveillance, and surveillance will really have to be strengthened at a local, national, and global levels. Currently, we are waiting for outbreaks to happen. We have to get into a mode where we have really an integrated prevention agenda, which essentially means that systems have to be on all the time. We today scramble to build healthcare capacity, but we have to go to a system where those systems are really ready and ready for a surge to take place very, very quickly. And finally, currently we are really under investing in R&D for emerging diseases, and this really needs to change. This is happening globally. COVID has really emphasized the need for this. So coming back to my original spillover figure, how do you really mitigate these effects? So, if you have forecasting ability, you can forecast based on what is circulating in wild animal populations. If you can detect early in wild animal populations, you can develop control measures, and therefore you can prevent that spillover into domestic animals and control operations in domestic animals. This will also reduce risk to human populations. So what you notice is that the green area under the curve also reduces, which means domestic animal transmission reduces, and therefore spillover and transmission into human populations also reduces. So we really need, by the time we come to diseases coming into humans, it's almost always too late. We have to do early detection when they are still in animal populations to be able to forecast. One health strategy is essentially what is needed. And I illustrate this by an example of how Hendra and Nipah viruses have moved into human populations. So in Australia, Hendra virus went from a bat to horse, and from horse into humans. So one mitigation strategy would be to actually develop vaccines for horses, which will prevent transmission into humans. And once it has transmitted to humans, you could have post-exposure prophylaxis. So, therapeutic antibodies to reduce the effects. If you look at how Nipah went from bats to humans in Malaysia, for example, it circulated primarily in pig populations in Borneo, and then the virus spilled over from domestic pigs into humans. But there is also evidence of Nipah virus spilling directly from bats into humans in the outbreak in Bangladesh. So viruses have different ways of getting to other populations, and we really need to know what's in there, what is in the bat populations, so that we can have tests and vaccines ready for them. So my final slide is about the Global Virome project. And this is a project that wants to build capacity for global monitoring of viral infections, or global monitoring of viruses and viral spillovers. And it aims to discover 500,000 viruses. These are viruses that have not been discovered yet. And once you discover these viruses, then of course, once you have the sequences, with the power of technology today, you can start fostering solutions. The question is, how much would it cost? And it is estimated that it would cost about $5 billion to discover 500,000 new viruses. Now, this is a lot of money. But if you put this in the context of what COVID has cost us, International Monetary Fund estimates that the cost of COVID is likely to be somewhere in the range of $25 to $30 trillion, which is about 5,000 times more than what it would cost to discover 500,000 viruses. So that is what we are really looking at, and that's the kind of investment we have to make to be able to forecast and mitigate future pandemics. Thank you very much for this opportunity.
Thank you very much, Shahid. It was a really very inspiring and lot of meaningful things you have told us. And in fact, we have understood to some extent the whole pandemic coronavirus and why we have not been able to immediately contain and how we can do it and how more research is required. So it was a very good lecture, and I thank you for that, and thank you for adjusting your schedule. I will now request our President, Professor Padmanabhan. Sir, will you like to give some concluding remarks for the symposium? Sir, can you hear me, Professor Padmanabhan?
Sir, please unmute yourself.
Yeah, I was muted. Thank you, Dr. Manju Sharma.
Sir, since you were not there, so I started the session in your absence.
I want to apologize. I got caught in another, not only DPT, that was the emerging variants that is happening in coronavirus. Anyway, I caught the last two talks, the Ayurveda and the Shahid's excellent talk, Shahid. It has been extremely informative, as Dr. Manju Sharma said.
Thank you, sir.
And the Ayurvedic talk was also very useful. My point is, in Ayurveda, we have gone into this drug discovery based on single molecule on single sites. I feel that concept has to change. Now, whether you call it Ayurveda or not, it becomes important that we have to have multiple targets, single target, single site, single drug. That is how the older approaches were abolished, actually. And we are somehow rediscovering some of them. For example, in plant extract, the extract is a lot more effective than the pure molecule. It will be 10% effective. So I feel, this is, I think he made a very important contribution there. But one issue I have is many of these publications, international community has to be taken aboard. Many international communities do not believe in our systems. They keep saying, "Oh, you have metal toxicities." Many times it is unfounded. I really feel we need to take it up in a serious way. If we have to think that our traditional medicine has to be taken forward. And I don't have to say much about what Shahid said. Extraordinarily important talk, Shahid, which is the way the kind of investment that is needed. But I really do not know even getting 500,000 viruses will be able to solve this problem. Knowing them, knowing the sequence is one thing, but finding an antidote, I really do not know. But getting to get rid of the forests, becoming open forests, I think this made a very important point. For statistics, we may say we have 27% or 28% forest area, but the dense forests are disappearing. And I think this is a very important. The climate change, of course, this is something which is really contributing the spread of these vectors, whether it is mosquito and viruses have many other ways by which they permeate. I think very important points have been made, and I really thank thank you, ma'am, for getting the symposium started. And any comments you have before we close this session?
Thank you, sir, for your concluding remarks. So now the symposium has concluded, and I want to thank once again all the speakers, very distinguished people, and the various subjects which we covered. Also, I want to thank Professor Balram Bhargava, who gave us the suggestions for the actually drafting of the program for the symposium, and which has been very useful. So thank you very much, all of you, and I wish you the best and also safe from the pandemic. So Archana, would you like to give vote of thanks?
Thank you, ma'am, for sharing your expertise, and we are also thankful to Honorable President and the distinguished speakers of this session. And with this, we come to the end of this session. So we had very productive 2 days of scientific deliberations and covering all the aspects of health and healthcare. And now it's time to express our gratitude to all who have contributed towards the successful organization of this event. So to begin with, I would like to express my profound gratitude to Honorable Madam Dr. Manju Sharma ji, the past President of NASI and the Women Scientist Distinguished Chair of NASI, for all her concerted efforts to uh, develop the program, and that too are very important aspects that contribute towards the national development, and during such a time when the entire country was facing a very challenging situation. And she coordinated all the experts from all across the country, so we had very nice deliberations. And she is the soul of NASI and a very great source of energy and motivation for all of us. So we are really thankful. We have no words to express our gratitude for Madam. So thank you, ma'am, for sparing your time and enlightening us as always. And you have very rightly pointed out in the beginning the programs of NASI with the special mention of two recently initiated programs, the Potion program and the Jagrukta Abhiyan of NASI. And NASI is very much thankful for your kind support and active kind blessings as always. We are very much honored to have Honorable President who has always supported us and always contributed to all the activities of NASI. Thank you, sir, for your kind contribution and very elaborating on different aspects in the beginning, and especially on the curcumin drug in the treatment of cerebral malaria and also various aspects. And we are really fortunate to have your valuable guidance, and we are proud to have an exceptional leader like yourself. Thank you, sir. We are also honored to have Professor Balram Bhargava, who attended the first day of the meeting and to actually inaugurate this session, the Director General of ICMR and the Secretary from the Department of Health Research, Government of India, for gracing the inaugural ceremony and very nicely describing the overview of health scenario of the country, with emphasis on need to invest on healthcare and maintain a balance between socialistic and private healthcare, integrative and preventive medicines, with the emphasis on biosecurity, and above all, a take-home message, one nation and one health vision. We are extremely grateful to Professor Bhargava sir also and his all contributions to NASI. We are very much grateful to all the chairs, co-chairs of the scientific sessions for all their help to moderate the session and sharing their expertise, which will help in formulating the recommendations. And we also joined by distinguished speakers from all across the country who shared their valuable insights on several crucial aspects of health as well as healthcare, such as the bacterial infections, management of various diseases like cancer, diabetes, and cardiovascular care, drug discovery, malnutrition, brain development, aging, and many other aspects like the emerging viral epidemics, infections, and most importantly, the preparedness and resilience on healthcare systems to tackle the health emergency, with special mention of COVID-19 pandemic, and also increasing the accessibility and affordability of the healthcare by using different smart healthcare devices and uh, intervention of the potential of our alternative systems of medicine like Ayurveda, for providing the innovative solutions. And we are very much thankful to them for sparing their time and sharing their expertise on these subjects. We are very much thankful to both the section presidents, Dr. Sumitra Bandyopadhyay and Dr. Smita Mahale, for their presence and contributing to the scientific sessions. On behalf of NASI, I am also very much thankful to all the invited speakers and the finance awardees. We also acknowledge the contribution of the past president of NASI and also all the eminent fellows, members, and the local chapters for providing immense contribution. And we are also very much grateful to all the participants, especially the students and researchers who joined us and became the part of the event with great enthusiasm. And NASI is also very much thankful to its Honorable General Secretary, Honorable Professor Satyadev Sir, Professor Khurana Madam, and also the Honorary Treasurer and past General Secretary, Professor U.P. Srivastava, for their valuable contribution and guidance. And last but not the least, I extend my I extend my thanks to all the executives and staff of NASI for all their hard work and valuable contribution to make this event a grand success. And I again thank all.
Is there any announcement for tomorrow?
Sir, I would like to request our Honorable President, Professor Padmanabhan Sir, to kindly preside this addresses by the sectional presidents. I would also like to request our past presidents, Honorable Madam Manju Sharma ji, Professor Mittal Sir, and all others who are there in this event to please be here with us so that we could have this last session of this second day, that is the addresses by the sectional presidents. And I would like to request Professor Padmanabhan Sir to kindly introduce the two sectional presidents, Dr. Sanghamitra Bandyopadhyay ji and Dr. Smita Dilip Mahale ji.
Thank you, Neeraj. It's my pleasure to invite first Professor Sanghamitra Bandyopadhyay to give the sectional president address physical sciences. A brief introduction. She is an eminent computer scientist and the director of the Indian Statistical Institute, Kolkata. Currently, she is on the Prime Minister's Technology and Innovation Advisory Council. She is an Infosys Prize Laureate in the Engineering and Computer Science category and a recipient of several prestigious awards, including the TWAS Prize for Engineering Sciences, the World Academy of Sciences Infosys Prize in Engineering and Computer Science, Shanti Swarup Bhatnagar Prize in Engineering Science, and J.C. Bose Fellowship, to name a few. As I said, she is a fellow of the World Academy of Sciences, Indian National Science Academy, Indian National Academy of Engineering, Institute of Electrical and Electronics Engineers, and National, of course, National Academy of Sciences, India. I think, I can introduce Dr. Smita Mahale probably after this lecture is over. May I request Professor Sanghamitra Bandyopadhyay to give her talk?
Hello. Am I audible?
We can hear you. Yeah.
I'm just trying to start my video also. Yeah. And I will share my screen. Just a minute. How do I share?
Yeah, madam,
Yeah.
please share your slides.
Yes, I'm sharing. This one share. Can you see my desktop now?
Yes. Make it full screen. Okay, thank you.
It is made full screen. So, first of all, thank you very much. And if I'm not wrong, there is, besides these two talks in this session, there will be also from the young fellow, I mean, young, what is it called? Young Association, Young Academy. So there might be a talk from them. So I will try to keep it short. I'm going to talk on interface between computer science and biology. As Professor Padmanabhan has already kindly introduced me and mentioned that I am a computer scientist and I have special interest in looking in developing algorithms which can solve, or which we hope to solve some problems coming from biology. And it's not only that computer science algorithms are there for solving problems in biology, but biology also inspires computer science methods in computer science. So I'm just going to touch briefly on the symbiotic relationship, how computer science can help biology, and also how biology has helped computer science to come up with some algorithms. As has been mentioned, I'm from the Indian Statistical Institute. I'm based in Kolkata. And just very quickly to introduce my institute, Prashanta Chandra Mahalanabish established this institute in 1931. And it's also interesting to note that the first computer in India, the HEC2M, was brought to the Indian Statistical Institute in 1956. Mahalanabish, of course, is very well known for his Mahalanabish distance, his contributions in large-scale sample surveys, flood research. He also pioneered, he led the second five-year plan for India. And ISI, although we are headquartered in Kolkata, we are spread all over the country. We are present in about 10 different cities with big centers in Delhi and in Bangalore, and also presence in Northeast. We have a center in Tejpur as well as in Chennai. We have a branch in Giridih in Jharkhand. And besides that, we have smaller units of the statistical quality control in Mumbai, Pune, and Hyderabad. So overall, we have presence in about 10 cities in all across the country. To come to what I wanted to talk about today, there have been several revolutions in healthcare, starting from revolutions, discoveries in molecular and cellular biology, the discovery of the structure of DNA, for example, the most fundamental thing on which all computational biology, or most of the things that we do these days is based upon. Genomic was another revolution, and then in present times, it's the convergence. It's the convergence of life sciences with engineering, with physical sciences, with mathematics, statistics. That is the revolution that is going on now, has already started. And that is where we are in the present times. So again, I'll not go into these things. It's there because this slide is meant for a more general audience. Everybody knows this in this particular audience, at least. I mean, I just wanted to put in perspective the cell and essentially the DNA over here. And we know that from the DNA through the process of transcription, we get the messenger RNA, and from there, through the process of translation, we get the protein. Of course, this is just a very simple schematic. A lot of things happen here, but traditionally this is called the central dogma of molecular biology. But what I'm really, as a computer scientist, interested in is the different levels of data that is getting generated, that has been generated for a long time now, and which is exploding these days. Entire genomes, transcriptomes, proteomes, the expression data. So the first line is essentially sequence data. We have the expression data, the expression of genes, expression of microRNAs, other types of expression data, structural data, the structure of proteins of RNA, graphical data, network-oriented data, which measures the interaction between, let's say, the DNA protein, between the genes, how genes regulate each other, protein-protein interaction, drug-disease interaction, drug-drug interaction, metabolic network. We have the epigenetic data and a lot of other data sets, as well as in healthcare, we have so many images, etc. So that is what interests me as a computer scientist. If there's so much of data, then we are sure that there is much work to be done here and much insight to be gained by an accurate analysis of this data. And I must tell you, in today's time, analyzing just a single level of data is not sufficient. It has to be an integrated analysis, a more systems level approach, because biology is much more than the sum of its parts that we all know. So just understanding the parts will not do, but how these parts interact with each other is of crucial importance to enhance our understanding of biological systems. So to start with, I just want to tell you how the biologist, the biotechnologist has challenged development of an algorithm. So as we all know, the Human Genome Project, its main goal was to identify all the genes in the human DNA, to sequence the entire DNA. And the cost, of course, I'll not go into this, but what happened is the sequencing technology which was available could only sequence in one go shorter stretches, not the entire genome. So these, the DNA had to be split, had to be cut in different fragments, and these smaller fragments, typically of the order of 1 kilobases, about 1,000 bases. So we had smaller fragments of about 1,000 bases long. And the algorithmic challenge, the computational challenge was, okay, we have sequenced these 1,000 long strings, but many, many of them. How do we build the entire string back? So that was shotgun sequencing approach, the fragment assembly problem essentially. Now, if you see, if we have just a single string and we cut it into different pieces, different of a length almost about 1,000 bases, and we have no way of knowing which is the first piece, which is the second piece, which is the 100th piece, and so on. And we are asked, okay, now join these pieces and give me back the entire string. Well, each of us can understand that this is impossible to do if we have just a single string. So how to solve it? Well, the solution came, very simple solution, but a very elegant solution, that you cannot have a single string and cut it into pieces and then sequence all these pieces and ask the algorithm developer to join them. But you have to take multiple copies of the same string and then do what you were doing anyway. Cut each of these copies. So the same string had multiple copies, and they were cut in approximately 1,000 base long substrings in smaller pieces, and these were sequenced. But now you have a handle of how to align them, how to join them with each other so that the original string could be rebuilt, of course, with certain errors. So this gives just a small naive example. Suppose this was the string and it was cut, 2 copies of the string were made. One was cut somewhere here and the other was cut somewhere here. And now you have actually in hand 4 pieces. This piece, this piece, this piece. I don't know, I hope you are able to see the cursor moving on the screen. So we had 4 fragments. And then what was done is pairwise, you tried to align these strings. And of course, because they are coming from the same, essentially it's the same original string, of which we have multiple copies. So this piece here, this fragment 3, is going to align very well. Ideally, if there were no noise, no errors, then ideally it would align with 100% match to fragment 1 over here. Now, immediately you would know that, okay, this is one piece where this matches. Now, what happens to this? This at a certain region would match this part of fragment 1. So it would match a certain part of fragment 1. And at the end, it will also match fragment 2. So this gave us a handle of trying to rebuild the string. So this actually, then you can now place these fragments one over the other so that you slowly have a way of regenerating the entire string by looking at the different matchings. So this was a computational challenge which was posed by a biological problem, solved very elegantly. And if this algorithm were not there, we wouldn't be knowing what the entire DNA stretch looks like. So this is one example where biology challenged computer science and algorithm development. Sequencing, of course, in the present times has moved ahead. We are now in the era of next generation sequencing, and in fact, we are leaving that behind also. NGS data, low cost, less time, massively parallel, generating millions of very short reads. Now, with this very short reads now, it was not possible to actually align these reads with each other and build the entire genome or entire fragment. But what is now done is you have a reference genome and try to map these short reads into areas of this reference genome. Of course, with very short reads of the order of, let's say, 200 to 300 bases long, it would match at different places. So there would be multiple matches, repeats, and that is creating a problem. Of course, the use of efficient computational, there are many computational methods which are out there which can help do this task. But also recent technology enhancements, developments have led to longer reads now, with the Pack Biosciences data or technology coming in, Oxford Nanopore data coming in. And here you can see that Illumina, the NGS sequencing, the read lengths were of the order of 100 to 300 base pairs with an error rate very small of 0.1%, while as soon as the read sizes started becoming longer, with longer reads, actually the benefit is that you can, there'll be less errors, less mistakes, because shorter reads would match in many places. But the longer the reads become, the matches will go down. So whatever match actually happens is likely to be more reliable. So Pack Bioscience, this is SMRT technology. Here 10 to 100 kilobases, that's quite long. But look at the error rates now, 5 to 15% errors. And Oxford Nanopore, it's up to 1,000 kilobases. Each piece can be sequenced, but again, the errors are very high, 5 to 20%. So there is no win-win situation yet. The longer this read becomes, the error rates are going up, and if with higher error rates, you finally land up with a confusing match anyway. So demand for new algorithms still remains. And we have been doing some work in this particular domain with my PhD student who just graduated about a year back. We initially had, initially when she started doing her PhD work, I had just given her a bioinformatics, a computational biology book to read. And she was, first thing to read, of course, was the algorithms on sequence alignment. And she read the Needleman-Wunsch dynamic programming based optimal sequence alignment algorithm, and was immediately able to see how this can be improved without sacrificing the optimality. So it was still an optimal algorithm, which we have here, fast optimal global sequence alignment algorithm, which was 70 to 90% faster than Needleman-Wunsch for genome sequences and 25 to 40% faster for protein sequences. Note that the sequence alignment score or the quality was not compromised, was not less than what Needleman-Wunsch is, and that is the optimal. There is nothing which can be better than that. Then we went on to develop algorithm called context-based, locality-sensitive hashing algorithms for sequence alignment. Again, I'll not go into that, but this was an improvement over the first version. And very recently, 2021, this algorithm has been published, where we have gone for alignment-free gapped mapping of noisy long reads. So this is actually for the PacBio, the SMRT data, where we have developed a new algorithm which will be robust to the noise. Because as I already mentioned in my last slide, the longer the reads are becoming in PacBio, it's about 5% of data is noisy. If you go to Nanopore, Oxford Nanopore, noise level goes up. But we've done this for PacBio data. So that is how algorithms were developed to help biology. I'll also, at the end, I'll mention one more. But how did biology also help computer scientists? How did it help develop new algorithms which may or may not be applied to biology? Well, we took the biologists, the computer scientists took lesson from nature, from evolution. And as we all know, nature is the best teacher. And it has done a fantastic job of optimization in its evolutionary mechanisms. So if nature has done such a fantastic job of evolution and has turned out organisms which are very well suited to the environment, to the situation, adapted, it is robust, then can we borrow principles from natural evolution and come up with an algorithm which will also do optimization. So it's essentially an optimization technique that is developed, but it is based on the principles of natural evolution. So an algorithm called genetic algorithms was developed. And I must tell you, genetic algorithms, although the name genetic appears here, but it is purely a computer-based method with no biology over there. There is no genes or nothing. It's only in the nomenclature and in the principles that are applied. It is essentially a computer software. It's a computer program. And genetic algorithms is a very commonly used search and optimization technique for problems which are really, really difficult to solve. So most real life problems actually cannot be solved in polynomial amount of time using any deterministic algorithm. Wherever there's a simple algorithm available which can solve the problem nicely, one should not use genetic algorithms, but wherever the problems are such that it would take huge amount of resources, huge amount of time to solve that problem optimally, it is there where one should use genetic algorithms. Genetic algorithms does not guarantee you optimality in the limited amount of number of iterations that you run it for. It has theoretical properties, but practically it will not guarantee optimality, but it will do much better than any other algorithm which is out there. But it will not guarantee optimality, of course. So it's a search and optimization technique. And what happens here is just as in nature, we all operate in populations. With each individual is represented in genetic algorithm as a solution, as a string. It's like a binary string, which is actually corresponds to an individual in nature. The string is called chromosome, as we have chromosomes inside the cells. The string, which is typically a solution to the problem, is a chromosome. The components of the representation are also called genes. The set of solutions, because genetic algorithm works with a set of solutions. It never works with individual solutions, but it works with a population of solutions, and it is called a population. Again, inspired by the population which appears in nature everywhere. It is based on the Darwinian principle theory of survival of the fittest through his mechanism called selection. And there are search operators which mimic the crossover and mutation which appear in natural systems. So, as I said, it is only in the nomenclature and the principle on which this happens that these names have been given. So essentially, it's a population-based search which goes on generation after generation. Each loop is called a generation, and the operations performed are selection, crossover, and mutation. What these operations essentially do is to produce from one population of individuals, it produces another population of individuals. And then the algorithm goes on. There are theoretical results behind it. I will, of course, not go into the details of that, but it does a fine job of optimization, search and optimization, and typically should be used for problems which are in computer science parlance called NP-hard or NP-complete problems, like the traveling salesman problem, etc. So while genetic algorithm was based on taking lessons from nature, genetic algorithm has been used to help in the drug discovery process also. I have myself done some research in this area. As we all know, drug discovery, essentially from the disease, you try to figure out the target proteins, essentially, more often than not. And based on those targets, we try to develop or identify potential compounds, the drugs that come to the lead compounds. And then, of course, it goes into clinical testing phases, etc. And what we did was, essentially we found that I will not go into these because I don't think I have time for that, but drug design essentially is a multi-dimensional problem solving. It requires expertise from different areas, including from computer science, including from mathematics. And we did it from a computer science perspective by using genetic, because we realized that for designing a small molecule, it is essentially, it will use the small molecule has to go and fit into the target, the active site, the functional site of the target protein. And to do that, first of all, it has to fit there nicely, with having nice properties, energy properties, electrostatic properties, van der Waals potential, etc. At the same time, it should not fit into other areas, because that is what often, more often than not, gives rise to the side effects of the drug when it binds to areas of the target which it is not intended to bind to. So essentially, if you look at it, drug design problem is an optimization problem. And optimization of what? What we were trying to do is to the objectives that we were trying to actually optimize dealt with energy components, with Tanimoto coefficient, which actually there's a scaffold. It tries to measure the similarity with the scaffold. And also we were trying to optimize the oral bioavailability measure. So we were trying to optimize 3 different types of objectives at the same time. So this actually makes the problem still more difficult. It goes into the domain of multi-objective optimization, where often multiple objectives which may conflict with each other are optimized simultaneously. So we were doing a multi-objective optimization. We used genetic algorithms, which there exists a multi-objective optimization version of genetic algorithms, which we adopted. And we also came up with our own method based on something called simulated annealing, which of course is not based on biological principles, but based on physics. But it's again another search and optimization strategy, simulated annealing, very well known. So we were, this is some result I'm showing. We were trying to target the REC-A protein of Mycobacterium tuberculosis, and REC-A, we know, repairs the bacterial DNA which are damaged by antibiotics. Therefore, if we can inhibit REC-A, then the effect of antibiotics or the toxicity potency of the antibiotic may be enhanced. So REC-A was taken as a target, and we were using genetic algorithms to design a molecule from scratch. So that is in silico and from scratch. It is not like discovering from existing databases, but we were trying to design that molecule. I will not go again into the details of these. There were different biophysical properties, docking scores, etc., which we looked into. And of course, we realized that the method that we had developed was doing reasonably well. But I will just tell you this, and this is more or less towards the end of my presentation today. So interestingly, we were able to reconstruct the method. This method was able to reconstruct some known inhibitors of Mycobacterium tuberculosis, of REC-A. The question might be that if these inhibitors are already known, so what's so great about it? Nothing great about it, except that it gave us a little more confidence in the method that we had developed. And in addition to these known inhibitors, what was more interesting was that it also came up with some molecular structures which were not known, which are not there in the database where known inhibitors of REC-A was present. So these could be interesting things to look at. So we had several such predicted probable binders. Of course, our expertise ended there. We did some QSAR type of studies but that's also on computers, theoretical studies. But thereafter, our expertise ended, and this we published, of course, in some journals. Some of the methods we published in a few journals, and this particular example actually shows that how computer science can also help in drug design and many other related problems. But I must say that this particular application of genetic algorithms for the drug design problem does not mean that the problem is solved. Of course, it is not, because there are so many other variables which we have to account for, which is not. First of all, as computer scientists, we don't know, but we have been talking with other biologists. There is limitation of knowledge available. But the good thing is the mechanism, the framework is flexible. with more and more objectives or more and more constraints, it's possible to build in. It's not a frozen framework. It is all a very flexible framework where you can build in or bring in newer things as and when newer knowledge becomes available. With that, these are some references, usually of this work that I presented at the end. I must acknowledge my own institute, DST, DBT, Alexander von Humboldt Foundation, and Infosys Foundation, ICTP, and of course all my students and collaborators around the world, without whose help nothing could have been achieved. And thank you very much. Just to point out, if you look a little carefully within this thank you, you will see the face of Maulanubish over there. Thank you very much.
Thank you, madam. May I request our Honorable President to kindly introduce other sectional president for the biological science, Dr. Asmita Mahalaji.
Very good. Very good. Excellent.
Thank you. Thank you very much.
Professor Padmanabhan, sir.
Sorry, I forget to always unmute myself. Thank you, Dr. Sangamitra, for educating us on computational biology and telling us about genetic algorithms, which really are not genetic, but it means randomized search and optimized techniques, basically. Interesting to know that you have tried to apply to RECA inhibitors and perhaps on drug design. I do hope someone will take this forward. As you said, drug design, drug development is a very complex process, as we all know. But I'm sure these approaches towards designing helps a lot. And thanks again, as sectional president, for an excellent lecture. We now move on to the next lecture by Dr. Smita Dilip Mahale. This is on President Section Biological Sciences. She has been the director, I am told she recently retired, and a senior scientist at National Institute for Research in Reproductive Health, Mumbai. She has over 35 years of research experience in the field of reproductive endocrinology. She is leading a team of scientists working in the area of basic clinical, operational, and socio-behavioral research. She has received several prestigious awards in recognition of her work in the area of gonadotropin research, such as Swarna Kanta Dingley Award, Subhas Mukherjee Award, ICMR Award category, Lapsetwar, I hope I am pronouncing it right, Lapsetwar Award from Lapsetwar Foundation, International Royan Research Award, to name a few. She is a fellow of National Academy of Science India and Indian National Science Academy. And I have known she has been very closely involved in many of the programs of Dr. Manju Sharma, to take science to society. And it is my pleasure to request Dr. Mahale to give us a lecture on structure-function relationship of proteins, applications in biomarker identification. Dr. Mahale, please.
Thank you very much, sir, for kind introduction. I'm going to share my slides. Please allow me to share my presentation.
Yeah, you have been allowed, madam. Please share. If any problem, I can share from here also.
Yes, you can share it from there.
Okay. I will just share.
Yes. So at the outset, I'd like to thank Professor Manju Sharma Madam and the NASI Council for giving me this opportunity to present my work at the session where I'm talking as the president of section on biological sciences. The work is carried out in my lab, at the structural biology lab, and also at the bioinformatics center at NIRRH Mumbai. Next, please. Next, please. Next slide, please. When we talk about structure-function relationship of proteins, we also look at the application part, and we know there are n number of proteins in biological system, and we would like to understand their structure, their function, so that we can apply the knowledge to identify the surface-oriented regions or to delineate the bio-neutralizing epitopes. We have been hearing about COVID and how important these epitopes are to identify the core or the functional domains, or to develop novel molecules, which we just heard from Dr. Sangamitra, and also to develop biomarkers. Next, please. So I'm going to take you through to two important proteins which we have studied in our lab during last 2 decades. One is the follicle stimulating hormone receptor. It's an example of a G protein coupled receptor, which I have spoken in the past also. The second one is prostate secretory protein, which we call it as PSP94, which has a Greek key motif protein. Next. Next, please. Follicle stimulating hormone receptor. The structure is not known complete, but partial structure is available. But before that, we started our work where we utilized different approaches to understand the regions of FSH receptor extracellular domain involved in hormone binding. Next, please. Next, please. We all know that FSH is very, very important hormone and plays a major role in mammalian reproduction, both in males and females. In females, it is required for folliculogenesis, and in males, it is required for spermatogenesis. It exerts its action by binding to FSH receptors, which are present on the gonadal cells. So the main question is, how does FSH interact with the receptor? And if we know this information, how can we apply this knowledge in understanding the diseases? Next, please. There are evidences to show that FSH receptor is very, very important, especially in female reproduction, because when the knockout studies were done in mice, both with FSH beta and FSH-R, the animals were rendered infertile. Next, please. So we have predictive algorithms. I think my talk will be complementary to Dr. Sangamitra's talk, where we have used computational biology tools to predict the regions involved in the interaction, and then demonstrated by performing in vitro and in vivo experiments. We also use synthetic peptides and antipeptide antibodies of these proteins as tools, E2 hybrid screening, and at the end, we also looked at the polymorphisms and mutations present in the population in certain category of infertile women. And then after demonstrating the presence or the association, we showed by site-directed mutagenesis that the regions or the residues are important for biological activity of that particular protein. Next, please. Several peptides were used, so also the antipeptide antibodies. My initial training when I started was with synthetic peptides, and that's how I used those tools for screening the various assays where FSH and FSH receptor interaction was monitored. One in a radio receptor assay, in a hormone binding, and then subsequent signal transduction. And for this, we used either the receptor preparation from animals or HK cells transfected with the FSH receptor. Next, please. We made and were used in the competition. Next, please. Next. Next, please. This slide summarizes some of our publications where we have slow. The previous slide told us about the publications, the regions we have identified cellular domain. It's okay. And how we could develop some molecules as antagonists of hormone action. And we also developed bioneutralizing antibodies, and clearly indicating that these tools can be utilized to find out the important regions of the receptor so that we can target those. As you know, G receptors are being used as targets for many diseases. Next, please. Then we moved on to the extracellular loops. For this, here we develop, we know FSH are similar in their structure, so also their receptors. The residues of LHCG were substituted in FSH receptors, and that's how we made several chimeras and then tested. For that, FSH receptor extracellular loops are very important. Next, please. Next, please. Couple of to show the significance where we have clearly demonstrated that the loops are very important. This is the structure we modeled for the extracellular loops using computational. Paper was picked up by the Journal of Molecular Endocrinology for the cover page. Next, please. Next, please. So at this point of time, it was a post-genomic era. ICMR also came up with the programs, and we thought we have identified certain regions, certain residues. We wanted to see what happens in a real life scenario. What happens in patients who are infertile, whether there are any polymorphisms, whether there are any mutation. That's how this part of work was initiated. Because there were a couple of research questions to be answered, and we knew that FSH was used, and now also it is used as a therapeutic in IVF, where and there are a couple of challenges there. So the challenges are why only few individuals show adverse drug reactions. This is of course common. Why some individuals do not respond to a particular drug. Why there is a variation in drug dosage within individuals for a given condition. Next, please. So this is a classical scenario where pharmacogenomics is being studied. There are a set of individuals with the same diagnosis and same prescription, but we know because of the genetic variations, they can be further classified, where the drugs could be toxic, where the drug could be beneficial depending on the SNPs involved in the drug metabolizing enzyme. So then there are challenges also, and we utilize this particular scenario for our study. Next, please. So we had two sets of individuals in our study model: infertile women who had high gonadotropin levels. We reasoned that there is some defect at the receptor level because there is a loss of feedback and steroidogenesis is affected, resulting in serum levels of FSH going very high. The second set of individuals who were receiving gonadotropins as part of their assisted reproductive technology therapy during ovarian stimulation, and we could get back this information from our clinician that the management of poor and hyper responders still remains a challenge in an IVF setup. Next, please. So we identified mutations and SNPs which were known that time. We also identified several novel mutations in our study population, and that's how the journey of this FSH receptor polymorphism work started. Next. We could identify picked up the important ones. The one was the SNP at the 307 position. We had already identified this as a very, very important epitope at the hinge region. It is unique to FSH receptor, and it was also observed as a bioneutralizing epitope. And this particular SNP, when we looked at, the amount of FSH required for when it was alanine and alanine at 307 position, it was very, very minimum compared to the FSH required for patients with TT. So this particular SNP was well correlated with the hyper responders, and in hyper responders there are conditions called as ovarian hyperstimulation syndrome. So we compared, in the next slide, we try to compare the patients who had gone into the OHSS mode. Next, please. So here we can clearly see that almost 85% of the women who had AA genotype, they were falling into the category of ovarian hyperstimulation syndrome. The next, I will tell you about the work we have done with -29. It is at the 5' UTR region. The SNP was by our group. The scenario is exactly opposite. Here it is more of a poor ovarian response. You can see from the graph on the left, administered is more in AA individuals. At the same time, oocyte retrieves were comparatively lower. Here also almost 72 to 73% of women with AA genotype were poor responders. So this clearly helps the clinician to adjust the dose of FSH required for ovulation. Next, please. At the same time, we also wanted to understand the biology behind this. Simple association may not be only because of FSH receptor SNPs. So the question asked was, is FSH receptor genotype for differential expression of FSH receptor? Will it affect the transcriptional activity? And this point in time, we collected granulosa cells from the leftover follicular fluid from these individuals. And next, please. And look at the FSH receptor transcripts by real-time PCR. We also looked at the protein level on the granulosa cells using Western blot, and clearly indicated that women with AA genotype had lower expression of FSH receptor both at the transcript and also at the protein level. In the next slide, we demonstrated the presence of FSH receptor on the granulosa cells by confocal microscope. Here again, we could see that women who had AA genotype, their granulosa cells showed very, very minimal expression as compared to the other genotype. Next, please. These are the couple of publications coming out from these association studies. And thanks to my students who worked very hard and had to set up new techniques in the lab. Next, please. So this part of the work clearly indicates that SNPs of FSH receptor may serve as better markers to predict altered ovarian response in women undergoing IVF. Next couple of slides, I will take you through the mutational aspects. We have looked at different mutations, and we also wanted to set up some functional studies to characterize these mutants in the lab. And we used again either HEK cells or the CHO cells transfected with wild type and mutant construct. Various assays were utilized for screening these mutants post transfection. And next, please. One example I'll give you here. The two mutations which we found in patients. The 514 mutation was observed in a patient with ovarian hyperstimulation syndrome. And here you can see the binding of FSH has gone up. At the same time, we have another 575 mutation. The binding, the blue bar, it's very, very minimal. At the same time, we also looked at the signaling, the cyclic AMP production post FSH challenge. And you can clearly see here the blue line belongs to the ovarian hyperstimulation syndrome patient, where the receptor is at the basal level itself is active. And the other one, the red line, is corresponding to the 575 mutant. You don't see any cyclic AMP production. We wanted to find out the reason why it is happening, what is happening to the FSH receptor expression at the surface level. So next couple of next slide will tell you the reasons for this. The FSH receptor expressing cells were visualized under a confocal microscope. And we have this very good antibody. It's again a monoclonal antibody, which I had characterized in one of the US labs. And we have access for this, clearly demonstrating that in a hyperstimulation syndrome patient, what happens? Because there is excess of receptors available onto the cell surface. The patient who was 575 mutation we saw is a primary ovarian failure patient, where we don't see any expression, and it also was a primary amenorrhea patient where we don't see any expression onto the cell surface. But when we permeabilize these cells in the lower panel, you can see the signal indicating that the receptor, though it is expressed, there is a trafficking defect. Next, please. Since then, we have worked on several mutations from the literature we have picked up, or from our clinics we have picked up, and done these functional studies. And it has been published 3-4 years back in again molecular and cellular endocrinology. Next, please. So these are the couple of models we have worked with. We kept on refining the model of FSH receptor interaction based on the residues we identified, and the work is still continuing in the lab. Next, please. This is to summarize the part of the work with FSH receptor interaction. The information generated is very, very important for developing receptor targets, and also for the management of female infertility when FSH is used as a therapeutic. Next. I will now move on to the next protein, prostate secretory protein PSP94. It's not a new protein. It's been there since last 30 years or so. late Dr. Shade from our institute was the one who isolated this protein from the seminal plasma, and I'm sure Dr. Padmanabhan will remember this protein. And at that point in time, it was called as inhibin because scientists were looking at gonadal secretions, non-steroidal in nature, having effect or regulation at the pituitary level. And that point in time, it was referred as human seminal plasma inhibin, but subsequently the names have been changed. And now there is a consensus and everybody calls it as PSP94. The primary sequence has been deduced. Next, please. It is conserved across species and must be doing some species-specific functions. At present, the functions are, please go back. Yeah, thank you. So we started looking at this particular protein because I had worked for my PhD and I just wanted to see what is the function and what is the secondary structure, tertiary structure. So last almost 12 years, we have been working on this. We have solved the crystal structure and we are looking at the function with reference to prostate pathophysiology, its role in sperm function, and also trying to understand its interactome. So next couple of slides, I will share with you the major findings. Next. The protein is abundantly present in human seminal plasma. So using pooled human seminal plasma, we could purify this protein in large amount, which was required for crystallography work. Next, please. So we had good collaboration with a group in BRC, Dr. M.B. Hosur and his colleagues, Dr. Mukesh Kumar, took up this work. Next, please. So we were successful in solving the crystal structure of this protein. The uniqueness of this protein is, as we see, it's a Greek key motif thing, and it has several disulfide bonds. And we could clearly show the disulfide bond pairing, which was a hot topic that point in time because everybody was coming up with different disulfide bonding pair, and finally we could conclude that these are the important disulfide bonds in this particular protein. Next, please. There are a couple of literatures, papers available telling about the function of this protein, but till today we are still struggling to find out what the function of this particular protein. It's not known, and our lab is still working, and it will continue working on this particular protein, trying to understand the major function of this protein when it is present in such large quantities from the prostate secretions being secreted into the seminal plasma. There are a couple of speculations what it could be doing, but nothing has been proved very convincingly. Next, please. Next, please. So we tried to look at the PSP94 interacting partners based on, again, some of the information which we got from the literature. And that's how we have identified a couple of interacting partners of PSP94. Next, please. At least by understanding the function of those proteins, whether we can deduce the function of PSP94. The next slide will tell you our attempts to look at the functional significance, mainly with reference to the sperm function and prostate pathophysiology. Next, please. Next, please. Next slide. Yes, we could identify CRISP3. It's a cysteine-rich secretory protein as one of the binding partner, because during purification we could purify this particular protein. And next please. During couple of site-directed mutagenesis, next please. In my lab, Dr. Bhakti, she has developed several mutants and next please.
What would you like to send? You can ask me to send an
So
email.
these are a couple of papers which am I audible?
Yes.
It doesn't look like it. If you'd like, I can
You
help
are
you.
audible. You are audible.
Yeah, yeah, please go ahead. Please go ahead. So at this particular point in time, after we identified several binding partners, we still were looking for its function. And that point in time, we decided to develop an ELISA to measure the serum levels of PSP94, because we had all the reagents in hand. We had the very, very pure preparation of PSP94. We developed antibodies in the animals, rabbit and rat, and these antibodies were used to develop and sandwich ELISA. And here you can see the ELISA for a standard, the sample dilution plot, and one particular company was selling the kit that time. Now it's not available. We could procure it, and we tried to compare our assay with the assay we did with the kit, and it was quite comparable. Next, please. So we set up an experiment where we collaborated with KM Hospital and Tata Memorial Hospital. One of the student, Deepa Mhatre, took up this challenge and confirmed cases of healthy controls, patients with benign prostatic hyperplasia and prostate cancer. Their serum samples were collected, and we could monitor PSP94 levels. And at the same time, we also looked at the serum PSA levels, because it is being used as a gold standard at present. And we can clearly see PSA, in prostate cancer, PSA levels go up, whereas in BPH, the PSA levels are not increased. Whereas in case of PSP94, we can see increase in BPH and not much increase in prostate cancers. So we thought of looking at the ratio of PSP94 versus PSA, the extreme right graph, and where we can clearly see that the ratio is highest in controls as compared to prostate cancer, and the BPH lies in between. So we wanted to have a cutoff for this particular ratio. And the next slide. So how do we utilize this particular information in prostatic disorders? So we looked at the monitoring the ratio of PSP94 and PSA in patients with lower urinary tract symptoms, what we call is as LUTS, because PSA is not very, very specific to prostate cancer. Any injury to prostate, if there is even infection, the PSA levels go up. And if the levels are between 4 to 20 nanograms, it's a dilemma for a clinician. They are not very, very sure. And then the patients are referred for biopsy. So the question we asked was, can the biopsies be prevented in patients with LUTS based on the PSP94 PSA ratio? The work is at present going on in collaboration with the major hospitals in Mumbai. So far, this is the unpublished data. We have data for almost 64 biopsies. And we now have a cutoff of 5.3 for the ratio. If you see the first row where we have 26 patients, biopsy was recommended based on the PSA alone values, and from our values of taking the ratio, putting the cutoff as 5.3. We don't recommend biopsy, but the confirmed negative results we obtained from the pathology reports. Here you can see that almost only for 4 patients biopsy was positive, but unnecessarily all the 64 were referred for biopsy. So here we can cut down. We cannot completely prevent, but definitely at least in 41% of the cases we could prevent, and we can, if this is reproducible and convincing, we can tell the clinicians not to send patients who have cutoff of 5.3 for biopsy, and maybe they can be treated and monitored later. So this is in short what we have now for PSP 94. Next, please. I take this opportunity to thank all the collaborators. It's not a job of one particular lab. The inter-institutional collaborators we had for FSH receptor, right from Indian Institute of Science, right from Dr. Maudgal's time, Dr. A.J. Rao, Dr. Rajan Dige, they have been very, very kind enough. Dr. Sadhna Desai and Vijay Mangoli from the fertility clinic. Dr. James Diaz, he is my mentor, postdoc mentor, and I also agree with Professor Padmanabhan when he said yesterday that he visited that lab so many times. So I also took this opportunity and I visited Diaz's lab during last 15 years a couple of times just to learn techniques, different techniques which we have been using here to monitor the protein-protein interactions. And within the institute, my PhD mentor, Dr. Iyer, Dr. Nandedkar, she is also a NASI fellow, a great biologist from whom I learned so many animal experiments. Dr. Bhakti Pathak, she is a cell biologist. Dr. Meherji, she was a clinician at our institute who was running a IVF clinic. Dr. Deepak Modi, who helped students in most of the molecular biology work, and he is a new entrant in NASI, and last year he was elected as a NASI fellow. All my research students, fellows who have contributed immensely and doing very well and placed in various industry and academia. The core facility of the institute. Next, please. For the PSP 94 work, again, we had very good collaborations with BARC and University of Hyderabad. And at present, the work is going on with the KM Hospital, the Sion Hospital and Nair Hospital, where we are enrolling almost 1,500 LUTS patients for validating our results of PSP 94 work. And I must thank late Dr. Anil Sheth, who was instrumental in discovering or identifying this particular protein. Though the focus was on contraception, it looks like this particular protein has a great potential in prostate pathophysiology. And I once again thank NASI Council for giving me this opportunity to share some of the important findings from our studies, and also to impress upon the young students how a basic study of interaction of proteins and proteins can lead you or take you, and how one can apply this knowledge in our day-to-day biomedical sciences. Thank you very much, sir, and Dr. Manju Sharma, madam, for once again giving me this opportunity. Thank you all.
Thank you, Dr. Geeta, for an excellent lecture highlighting the structure-function relation of protein, taking all the way to biomarker identification, extensive studies on FSH receptor, the extracellular domain, polymorphisms, mutations in relation to ovarian response, infertility issues. Also highlighting on the other protein prostate secretory protein. I remember Sheth's inhibin. I think it's the same protein which Dr. Pushpa Bhargava took it up in seminal inhibin.
Slightly different. They were working with another protein and slightly different.
Okay. So, excellent studies, going all the way to prostate cancer, a biomarker based on PSP64 prostate antigen ratio. Huge number of publications. I want to congratulate Dr. Smita for such committed work and her colleagues and her students who have made a lot of contribution. I also remember Dr. Maudgal, who had a great interest in FSH and LH, if I remember right. He was the first one to have set up the primate facility in the country, actually. So thank you, Dr. Smita, for
Yes, sir. Thank you very much. I learned those techniques from Maudgal's lab, radioreceptor assays.
Thank you. I hand you over to Neeraj.
Thank you, sir. Thank you. Thank you very much, sir, for presiding over this session. Actually, these sessions, scientific sessions, are the part of our annual session every year, where we used to give the chance to the young researchers to present the papers in the presence of the sectional presidents, the prestigious chairs, and a lot of students used to participate in such sessions. But this year, unfortunately, due to the COVID-19, we are not having so much of exposure of our session, although about 200 people or something joined that session, but still the program's enthusiasm, which was used to be felt in past years, that is not there because we are all helpless due to the COVID pandemic. But we are very much grateful to all our senior fellows and members who are participating, and especially to Honorable President Professor Padmanabhan sir, who has conducted this session also, and also was present in the other symposium part. And I am also very much grateful to Madam Manju Sharma ji, because she has not only conducted the complete symposium sessions of 2 days, but also present in this session to grace the occasion. I am thankful, madam, and we are thankful to both the sectional presidents, Professor Bandyopadhyay as well as Professor Mahale, for giving a very enlightening speech regarding their research work, and also that was inspirational for the young researchers because they decoded many intricacies of science like sequencing of genome, storage, indexing, retrieval and analysis part, which has been done with the computational technologies and which has been very clearly elaborated by Dr. Bandyopadhyay ji. Similarly, Professor Smita Mahale ji has given a very wide panorama of the FSH protein and its mutation and all types of such other proteins which are very much essential in regulating and in deciding the fate of several diseases also. So we are very much thankful to you, and we are thankful to all our past presidents and who are connected with us. Professor Akhilesh Tyagi ji is here, Professor Ashok Krishna ji here, Professor Kamboj sir was also in the session. So I am very much thankful to all our past presidents, our vice presidents, and also the general secretaries and treasurer and all other fellows and council members. So with this now we move to the next part, which is the last part, last but not the least. Actually, the very important in that sense, it is a part of the presentation regarding the Young Science Academy, the INYAS, and it is being presented by the president of that INYAS, Dr. Chandrasekhar Sharma ji, who is with us now. His presentation is basically what the Young Science Academy is doing, and in the next 15 minutes, he will tell us about the different activities of the Young Science Academy. We are very much grateful to Dr. Chandrasekhar Sharma as well as Dr. Chandrima Sahaji and Professor Ghatak sir also, because they connected Dr. Chandrasekhar Sharma ji to this program. And last year also he presented a very nice presentation during our 89th annual session at Hyderabad. So now over to Chandrasekhar Sharma ji. Thank you. Dr. Chandrasekhar Sharma ji, please. Here you have shared your slide. Please make it full screen. You are muted perhaps.
Yeah, can you hear me now?
Yes, thank you.
Thanks a lot, Dr. Neeraj. Yes, it was really good to interact with NASI fellows in last AGM, which was held in Hyderabad itself. And since I belong to Hyderabad, so it was nice to interact with you and ma'am. But this year we could not have it in person. And I myself is a NASI member, so I was looking forward for this meeting. But thanks to Professor Ajay Ghatak for connecting us with this presentation and giving me this opportunity. I really thank Dr. Padmanabhan also for his approval. So I would like to put it very briefly about what Indian National Young Academy of Sciences, which we call INYAS, is doing. Especially, I will focus on last 1 year activity in the post-COVID era. And then, as Professor Ghatak suggested, we have proposed, we are proposing some activity which can be taken, which can be considered by the NASI jointly with INYAS in future. So very brief history, we started in 2014 our journey by INSA Council by choosing the 20 founding members who all were the INSA Young Scientist Medal awardee. And we are the only established and recognized young science academy in India as of now. So we are 6 years old, we have completed 6 years. With the mission to engage in the interdisciplinary and intergenerational dialogue on scientific issues. And these were the vision statement for us, including the promotion of science education and outreach, networking amongst the young scientists, not only in the country, but worldwide, and also the building scientific temperament across the country. And some of these objectives are also, of course, in line with NASI as well. A structure of INYAS is like this. So there is a chair for 2 years. Currently, I am heading the INYAS for another 1 year. And then we have a core committee members of 9 in the strength. Again, they are elected for 2 years by the INYAS members in the general body meeting. Generally, we have half the core committee leaving every year. So it's a mix of old and new committee members. We have the membership of 5 years. So it's a dynamic body. It's not lifetime membership. And that's how it remains always young. And currently, every year we induct around 20 members. And currently we are having 95 members, and 2 of our batches now have become alumni. So we are having the current alumni strength of 29. This is the core committee of INYAS to 2021, and you can appreciate the gender inclusiveness in the highest apex body of INYAS with 5 women members out of 9. Some of the key initiatives of INYAS are listed here. Like we have been doing the National Frontiers of Science meeting with the support of Principal Scientific Advisor Office, which is a kind of 3 days residential meeting, unique platform for brainstorming among the young scientists on multidisciplinary areas. We have edited special issues. We are also looking for our annual newsletter in the multiple languages so that we can reach out to the more people. We have started organizing the National Science Day jointly with INSA, and day after tomorrow we are again doing it. Apart from that, we have taken several innovative science outreach activities. I will just make a slide on that. And of course, some of the routine activities for us are the science camps and the remote area lectures. Some of the achievements in last 6+ years is that we have really helped in scientific capacity building and gender inclusiveness. We have active collaboration among our members, as well as we participate worldwide meetings on young academies. In fact, our founding member is currently heading the Global Young Academy as a co-chair. We are also having the global engagement on research, especially with the Asian countries. And some of the members are also part of the National Task Force on COVID and decision-making and policy-making committees of the country. And several of our members are top science awardees, editorial board members of international journals. So if you want to summarize the activities of INAS in one slide, it's like this. So we have outreach events like remote area lectures and science camps. They are targeting towards the school students, and as I understand, this is of the very special interest group of NASI. Then we organize the training program for the workshop and in the form of workshop and webinars for the young scientists. We also do the community service by having the awareness program to the general society. And then we have the publications through proceedings of INSA. Some of our members are part of the National Task Force, and we are also working on the white papers in terms of policy. We do the liaising with the national and international bodies, including the Global Young Academy. And then, of course, we do a lot of symposiums and technical webinars and the National Science Day. So I would focus on last 1 year activity in which we have extensively used the digital platform for science outreach. We also introduced a media meeting with focus on the technical sessions. And in last 1 year, we have introduced our local chapters to have the more liaising with the local INSA chapters for wider impact. And focus of INIAS is on participation of all members, inclusiveness, and decentralization. So we have very successfully conducted the INIAS Vigyan Setu webinar series on the COVID-19 as soon as the pandemic started and national lockdown started. And in this case, as you can see, we have invited 15 esteemed speakers, and there was a huge response from the viewers. So total 15 Vigyan Setu webinars have been conducted, and we just concluded the series last month. Then with the DSP Rajasthan, we have done a lot of activities in last 1 year, which includes the remote internship for the undergraduate students because they could not join in person because of the pandemic. Then we have provided the intellectual support for their various programs, especially for the supporting women in STEM. And there are a lot of webinar series we conducted in DSP Rajasthan. Then there are more efforts in the science capacity building program. Some of them are listed here. I would like to highlight one such program in which we have organized such a scholars skill development workshop in which there are more than 3,000 registered participants. Then one of our members, she has organized this very unique introductory data science course with the University of Cambridge, exclusively for the women scientists. And initially we were not very sure about the participation, but then we had to really choose 50 participants out of 450 applications. And we look forward for the second edition of it very soon. These are some of the other activities and promotional activities. Many of our members are writing actively on the issues related to the COVID-19 and participating in the panel discussions on the TV and news media channels. Yes, as I mentioned, we have formed the local chapters to spread our activities further. And in last 6 months, since we have formed the local chapters, 7 local we have really gone with the meetings with the INSA chapters, and I think the last I would mention we have conducted recently the event with the NASI Chandigarh chapter. These are some of the activities. You can see the variety of activities which we have done on these topics. Again, we have started a new series, Scientists from India's Past and Present, and the aim is to highlight and popularize the Indian science from past as well as present. So we are organizing the monthly lectures on the past scientist achievements, especially on their birthdays, and also the current science, which is reflected in very top-notch journals. We are highlighting that science not only just from our members, but throughout the country and scientists through our social media pages. As I mentioned, we have edited the special issue of INSA. This was second special issue. Third issue is also in the progress, which will be out next month. And in the second issue, which was completely edited by the INIAS members, we have 16 articles, in which out of which 2 articles were on the COVID-19 research. We have also made new horizons in the international engagement. We have organized this international poster presentation competition with the National Young Academy of Bangladesh, Sri Lanka, and Thailand, in which we have 250 participants. And again, we were invited. In fact, I was invited to attend the National Young Academy Bangladesh GBM, and I was honored to make a presentation on INIAS there. Currently, we also organize the International Sci Art Image Competition. I was mentioning one of the very innovative outreach events. So here the aim is to identify or to encourage the creativity among the young researchers through the artistic manner to communicate the basic science about their findings. And this particular edition, international edition, is currently going on. We are going to announce the result on day after tomorrow at the National Science Day celebration. Again, this is done jointly with the National Young Academy of Bangladesh and Thailand. These are just two images you can just see to appreciate the creativity in the scientific findings. This was the last year event, which was done at national level. This year we had moved to the national level, international level. Two white papers which are currently undergoing and in the final stage. The schedule is little delayed, but we are kind of finishing these status and challenges for young researchers in India and fostering the curiosity-driven fundamental research. And we did a survey, and that outcome of the survey is also coming soon on the impact of COVID-19 on the current as well as freshly graduate PhD students. We have received 2,000 responses, and we are also exploring a joint online survey on the women scientists in India with India Bioscience. This is just a membership update. So last year, we really made special efforts to reach out to the underrepresented region institutes and universities. And we conducted a membership call in the regional languages. We have received 306 applications. And out of that, we have finally selected 24 new members after 5 stages of selection process as approved in our new guidelines. And these 24 members, they represent 15 new organizations this year. And we are proud to have around 30% women members into it. These are our new members, which have been inducted January 1st. We also institute first time the National Award for the Research Excellence, especially targeting the PhD scholars, because we realize that there is a category of PhD scholars we have such national awards. And thankfully, our INEAS members and also the industry support to have these awards. Again, we are going to announce the winners of these awards day after tomorrow. We recently conducted our CBN, of course, online meeting over a span of 4 days. And we had different sessions, which were open to all, public sessions, and also exclusive session with the alumni. We had panel discussion and technical symposium on infectious diseases. We're proud to say that we have 80% attendance of our members in all the sessions, and for voting 91%. These are some of the glimpses from our recently held program. And as I mentioned, we started this joint event with INSA National Science Day from last 1 year, and we are releasing our annual newsletter in this event in the English as well as regional languages. And this year we are going to have it day after tomorrow. We will be having Rohini Kodbole and Sri Sanjay Dhotre, Union Minister of State for Education, will be joining us for the award ceremony. We have some of the upcoming major events, and again, I would like to highlight this chemistry orientation workshop. We already have received more than 3,000 registrations for this event. And one thing I would like to highlight, we are going to have mass awareness campaign on COVID-19 vaccination. And we already had discussion with the DST and Gyan Prasad. And some of the activities listed here are, we are working on vaccine mythbuster document in the 11 regional languages. We have pamphlets, preparing the pamphlets and the infographics. We have started the Gyan Tika webinar series, which was inaugurated by Dr. Shamil Jamil. Then we are going to organize the webinars in the local languages. We have planned to engage the school students and teachers in various ways for this campaign. And we are also planning to have a vaccine ambassador workshop in which we will prepare the young students who can spread the message further in the society. We are also proud to have some of the members achieving the highest awards in Indian science, including the Sanshiro Bhatnagar Prize, Suryanti Fellowship, Star Award in last 1 year. And of course, we are proud to have a lot of INEAS members for the NASI membership. 5 members were selected for the NASI membership in 2020. And also, we are having the NASI Young Scientist Platinum Jubilee Award 2020 to one of our members. In fact, 23 INEAS members and alumni are currently the NASI Young Scientist Platinum Jubilee Awardee. And several of the members of INEAS, they are also members of NASI. This is just recent event I was mentioning. So we already have the NASI Chandigarh chapter joint events on this COVID-19 vaccination awareness webinar, as well as discussion meeting on the 5th National STIP. And also our member was invited for the webinar, which was organized by STSCI and Chandigarh chapter of NASI. With this, we propose a few ongoing activities of NASI where INEAS would be very willing to contribute and join hands. For example, summer and winter schools for school children, because I understand school children are primary focus of the NASI, and with our activities and the experience and interest also, we would like to join hands with the NASI on organizing the summer and winter schools, and we can volunteer to organize, as well as we can also coordinate with the local NASI fellows for that. Something similar to National Science Day, we would like to jointly organize the National Technology Day with NASI. And then there are some events like scientific writing contest, Vigyan, Jal and Health dropouts, which can be transformed into the digital platform given the current situation. And I think INEAS members can pitch in to contribute more in terms of giving new ideas to these existing activities of NASI. And also, we would like to cooperate, extend the cooperation with the NASI local chapters, with our INEAS local chapters, so that we can have the joint activities in a particular region, state, or city. And finally, we would like to have a joint working group with NASI so that we can also formulate the future events with NASI, which can be taken forward at the grassroots level. Apart from these current activities of NASI, we would like to propose two new activities for the consideration of NASI Council. So one is the PhD student summer internship. Basically, if you see, there is already a Academy's internship program for the summer, which is organized by all three science academies. However, that is limited to the undergrads and masters. There is no such program for the PhD students, and especially this kind of PhD students internship will be encouraged to have the more multidisciplinary research collaboration among the INEAS members, as well as NASI Young Scientist Awardee. So if it will be a joint basis, and one of the members from NASI Young Scientist Awardee and the INEAS members, they can come up with some proposals in which there might be some financial support for the PhD internship for 2 to 3 months. And a joint committee of INEAS and NASI may supervise the call and to take it to the decision level. So this is one proposal from our side in which we can join hands with NASI to have this new kind of internship, which may reflect in the near future for more scientific collaborations. And second is a special project for the science promotion. And here we would like to invite proposals from our members and again, NASI Young Scientist Awardee to prepare various kinds of concept notes, monograph, illustrative books on topics of general interest, and also to the interest of scientific community with some partial financial support. And this project may be of up to 6 to 12 months. We can work out on the different kinds of mechanism, how to go about it. But idea is to have such maybe 5 such grants in a year, so that we can. So these outcome of these joint proposals will be in terms of either some book or some concept note for the public or for the Indian audience, in which again NASI and INEAS will be acknowledged. Thank you. That's it from my side. Thank you for your kind attention, and I would like to take any of your questions.
Thank you, Dr. Sharma ji, for a nice presentation encompassing several spheres of the scientific activities which are being taken up by your Young Scientist Academy. And I would like to mention here that already, because NASI is the only academy which is having the two-tier system. Right from its inception in 1930, we have the membership as well as the fellowship. And many of the, about thousands of the young scientists are the members of this academy. So we have around 22 chapters.
I myself is a proud member of NASI as well as Young Scientist Award.
Yes, so and we have 22 chapters spread all across the country. And all the chapters are very much active. They are having the guidance of our Honorable President and the past President, and especially of Dr. Manju Sharma Madam, because she is very actively coordinating with the chapters to make them active and vitalize their enthusiasm. So all these chapters and NASI activities are being carried on, and whatever you have shown for the collaboration also, that is also being done by the NASI. But for the collaboration, I would like to just request you to send your proposal to NASI, which because it would be taken in the council of the NASI. So please send the proposal to the NASI council, and then that will be discussed and decided. But before summing up, I would like to invite Madam Manju Sharma ji to say a few words before it is concluded by the chair, Professor Purnavan sir. Madam Manju Sharma ji. You are muted, Madam. Unmute. Unmute yourself, Madam.
Can't hear you.
Madam, you are muted.
Is that okay now?
Yes, madam. Yes.
Okay. So congratulations, Dr. Chandrasekhar. This was a very good presentation and gave us the insight of what the Young Scientists Academy is doing. First of all, my first comment is NASI is always willing to join hands with any organization which will support cause of science and which will take the mandate of science to society. So from our side, at least I would say that we will always support such proposals, joint proposals. We have 22 local chapters, which are also very active. So many of the programs can be taken up with the local chapter. And certainly we will have to look at the financial implications of these programs, because we already have a very big program with the 3 academies for the which is for the education, which is run by Dr. Mukunda at Indian Institute of Science, Bangalore. Then we have just now reconstituted the Inter-Academy Panel for Women. And there we have a representative from your academy also. And I think we'll have to look at the overall financial implication and how much money we have and how much money we can spend. But at the same time, within our own programs, we will certainly be able to join hands with you. And students program, rural India program, Chopals, and for awareness in amongst the women scientists, especially in the rural areas, for the removal of their drudgery, to help the farm women to take up the new agri instruments, etc. There are several activities which NASI is doing, and we would certainly be happy to join in us with that. So at the moment, we'll see your proposal and the council will approve and the president will approve, and then we'll go forward. Thank you.
Thank you, ma'am. I mean, somehow there is some technical problem. My video is not working. But yes, I do agree. And in fact, for any current activities, if we are going for some joint activities, definitely we are not really requiring any financial support extra for that. I had discussion with Professor Chandrima Saha also about it, and she was also very clear that for any joint activity, we will be funded by the INSA side only.
She has talked to me also.
Okay.
Chandrima has talked to me also.
Okay, ma'am.
And she has, in fact, most of these programs she had already told me.
Okay, ma'am. Yes.
Thank you, Dr. Sharma. May I request our Honorable President to make some comments and conclude this session, today's session now.
Thank you, Neeraj, and so far as NASI is concerned, I think Dr. Manju Sharma and also Dr. Neeraj have explained the processes, and perhaps if they submit a proposal, whether it involves financial or not, even though it has to be formally approved by the council, and I'm sure it can take it forward. But NASI is always looking for collaboration, I'm sure, with young scientists, especially rural sector, women. This is a priority for NASI. And in general, I want to, they have had 2 days of symposia, excellent presentations. And I think the choice of speakers, I think Dr. Manju Sharma must be complimented. The way these, despite the online issues, I think mostly 95% has gone all right. The presentations are excellent, and we have not had any technical problems in that sense. So I want to, congratulate headquarters for doing an excellent job on this. And of course, I will have one more occasion tomorrow to address the AGM, and that would be my last address, I suppose. And I think it has been an extraordinary effort of NASI, I think, for the whole year, and culminating in this wonderful symposium. It has to be postponed. I wish, as Dr. Ishan Patro said, I wish we had had it in Revancha University, but the pandemic has deprived it. But still, the symposium has gone on very well. So I think, thank you, Neeraj, and over to you at this point.
Thank you, sir, for giving a very brief but exact remark for the science communication activities with the collaboration with the NAS, as well as thanking Madam and others also who did a lot of effort for making this program, the 2 days program, very much successful. And all the scientific presentations were not only up to the mark, but they were excellent, and giving a detailed look about what the scenario is now presently in this country, and what could be done for the betterment of the health research and its methodology in India. I hope Madam will certainly make very sound recommendations for sending it to the government, and we request for that also, Madam. And tomorrow, sir, actually, we are meeting for the scientific sessions in 2 parallel sessions separately. I will send once again the link to all the council members and the presidents and the past presidents, as well as this 2 parallel sessions. Just after these 2 parallel sessions, we will have the fellows meeting at the AGM. The program has also been sent to your good self and the madam and others. Once again, I will repeat today with the links so that you all could join, and I request all of you to please join tomorrow also, if possible in the scientific sessions also, and then certainly in the fellows meeting and the AGM. So with very warm and good wishes and all regards to every elders, and also for a very successful program to be held tomorrow, we wish that it would be done. Thank you, sir. Thank you, everybody. And thank you, madam. And thank you to both the sectional presidents and our vice presidents, past presidents, and everybody.
Thank you, sir.
Okay. See you tomorrow.
So we close the session, madam?
Yeah.
Yeah. Thank you.
पूरे दिन काम कराया, पूछ रहे क्लोज करो.
Thank you, madam. This is all because of your inspiration, madam.